think the biggest challenge for a country like India is because there is a heterogeneity in the population. So this would be out of bounds for most of the centers that are treating. So cost is one issue, definitely. Most of the centers will not be doing it in-house, so it has to be sent out. So then turnaround time and how do you select a lab, and those issues will come to that in the discussion. The interpretation requires experts, so it cannot be interpreted by any regular, most of the labs that are coming up will have a lot of PhDs on board, so we really don't know whether that informatics. So when we are doing genetics in, like for example, whole exome sequencing for a genetic disorder, all of us would know that there are many conditions, many situations where a diagnosis would be missed because it was not looked into at the first go. So when you reanalyze the raw data, we end up finding much more information. So that happens all the time. So what this could happen in the setting of leukemia genomic profiling as well. The other issue is germline versus somatic. So how do we know which requires a germline evaluation? We'll discuss that also in a bit. And finally, if you have a VUS, how do you assess functionality of that? So these are challenges that we'll discuss later in the course. Yeah. So now I would like to invite Dr. Gaurav to come up and discuss his heme path perspective.
Thank you, Dr. Neeta, for that, I think, very succinct primer on use of NGS in pediatric BALL. So what I will do in the next 10 minutes or so is just try to, give you a biologic perspective of what we know about pediatric BLL. And then we'll see from a case angle, like how to integrate all the techniques to detect all the relevant biologic abnormalities. Please ignore the font. I think I used Aptos, so it just doesn't come sometimes. Anyway, so if we look at what are the major problems, major abnormalities, if we try to classify them in BALL. So this is a paper we'll come back to. This is from Dr. Mulligan's lab at St. Jude, where they looked at almost 2,000 children with BALL and data integrated from copy number alteration, gene expression, as well as chromosomal rearrangements. And they were able to classify BALL in this is kind of a framework which we follow. So we already knew that BALLs were dominated by structural changes, such as this hyper and hypodiploidy, as well as isochromosome AMP21. And then we have the BLLs which are determined by fusion, such as BCR-ABL1 and so on. So this is what we already knew. So we'll see what are the new things. So this is a 13-year-old male. I think he presented with a fever and bone pain. You can see the CBC here. There was 81% blast. The marrow is full of blast. You can see it's a very hypercellular, full of blast. Again, I'm not going to detail. Cytochemical MPO was negative. We did flow. Again, this is not as part of a session. So just to highlight that all the B markers, you can see 19, 10, 22, everything was positive. No problem whatsoever. This is a case of BALL. That diagnosis was established. So then the question is, how will you work up, right? So from a cytogenetics, from a molecular perspective, what are the things that you are looking for and what are the techniques you will use? So I think this is one of my most favorite chart that we use. We had generated this for one of the reviews we published earlier. So, in today's state, I think it's very important for the lab person as well as for the treating oncologist to be aware of what exactly molecular test you're ordering and what is the abnormality that you're looking for, right? So we are trying to move to a situation where there will be a broad spectrum whole genome or whole transcriptome sequencing for every case. So for that, from when you go there, maybe this is not required, but till there, we need to know that what test we are ordering and what abnormality you are exactly looking for. So for example, if you're looking for chimeric gene fusions, the kind of test you need to do might be different from what we are, let's say, if you are looking for something sequence mutation. So this will be completely different, right? If you want to do gene expression, it's a completely different set of tests that you need to do. So maybe if I can ask some residents or who are present here, what are the tests you're looking for in a case of BLL? Like this is the child in front of you, the child that we showed. It's a child of BLL, and these are the probable abnormalities and the tests that you can do to detect them. So what will be a reasonable approach according to you? If anybody can say anything. What are you looking for? Yes? So I think this could be a reasonable approach, right? This is what traditionally we have been doing. So we are looking for fusions such as ETV6 junction, BCR-ABL1. For that, we need to do FISH, karyotyping, and PCR. We are looking for copy number alteration as well, like ploidy. So again, FISH is required. Flow also will give you that ploidy information. And at least BCR-ABL PCR is something we must do because to identify the exact transcript so that we can monitor them. And this will give you this, like what are these abnormalities that are listed here? These abnormalities will be detected by this kind of method. But what is the problem with this though? So the problem is that what about the rest of the abnormalities? We now know, as Dr. Nita showed, there are many BLLs which are determined by fusions, which does not become a part of this. And even if you know what fusion to track, let's say you have a list of 100 fusions. So how many probes you can add in FISH, right? It's impractical to add 100 FISH, 100 fusion in a particular case. There is something like, so there will be some genes like KMT2A, which individually can has 50 partners. So are you going to put 50 partner gene FISH for only KMT2A? That is not practical. And even if you can detect, you will never know what is the exact fusion sequence, right? So for monitoring purposes, then it doesn't make sense because you do not know the exact fusion sequence. And then again, Dr. Nita has said about metaphase failures and cryptic fusion. So therefore, this is a problematic problem. And then what about potentially actionable B others? So what technique will you prefer in this kind of situation? Would it be, I think there is a misconception about what technique you need to do. So will it be a DNA sequencing? Will it be RNA sequencing? What will you do? Ideally, both, of course. So in this kind of cases, especially in the space of BALL, I think RNA-seq is something that you must do. I mean, DNA you can still do. You should do if RNA doesn't give you anything, but RNA is something that you must do. So this is a bespoke modular RNA-seq assay which we had designed in our lab as part of a project to Dr. Patkar. And you can see this what we call this Narsima. So I'm not going to the chemistry of this, but just to tell you that there is a universal primer and there is a gene-specific primer. So what it means is that if you know one pattern of the gene, you can detect n number of fusions. So for example, if I know that I have to target KMT2A, I don't need to put anything extra for those all 50 partner of KMT2A. I can detect everything with one shot. So that is the beauty of this RNA, a very simple targeted RNA sequencing assay. And using this, and this is a old data actually, and this will not be 200, this will be at least more than 500 fusion that we have identified using this. So we did this RNA sequencing panel in this child, and we identified this NUP214 ABL1 fusion. So now what would be the diagnosis, if any resident can tell me? It's a BLL with NUP214 ABL1 fusion. How do you know these BLLs? This is of course a BCR-ABL like BLL, right? Which has this particular NUP214 ABL1 fusion. Yes, sorry? pH like BLL, yes. And then this is another case just to show you the spectrum. This is again a BLL 10-year-old male. And in this patient, the RNA-seq detected this P2ROI8 serolF2 fusion. So what about this? What is the difference between these two then? Both of them are same? Yes, but the last one was also a BCR-ABL like, right? This is also BCR-ABL like. Is there a difference between the two? In which case? The RBL one, right? Yes, you're right. Absolutely right. Right. So, BCR-ABL like BLL is an important entity that has come up. So I just wanted to spend 1 minute on it. Like, why do you think it is called BCR-ABL like BLL? If anybody can tell me. Don't you think it's a very weird way of naming some leukemia, BCR-ABL like? Why do you say that?
Gene expression profile for the BCR-ABL and for the BCR-ABL like is same.
Yes. So the similarity here is at the transcriptome level or mRNA level, as you have said. They do not have this fusion at the DNA level, but at transcriptome level, this fusion is present. I mean, the gene expression pattern is similar. That's why they are called as BCR-ABL like BLL. I think it's an important concept in oncology as we move forward. This is coming in many other fields as well. So for example, we now have something known as double hit like lymphoma. So it's a concept remains same, that they are similar to at the gene expression level, but they do not have that abnormality at the DNA level. So this is, I think you all know, this is the incidence of this increases with age, it is associated with unfavorable outcome and so on. But like what is important is, as we have already alluded to, that this is not a uniform entity though. Within BCR-ABL like BLL, you have all these subgroups. So important to know at least these two, like what is ABL class fusions, like our NUP214 ABL1, and what is JAK-STAT pathway perturb, like our CRLF2 rearranged leukemias. And because they will require a separate type of therapeutic approaches. There is some other rarer subset as well, and very commonly they're associated with IKZF1 deletion also. However, IKZF1 deletion is not a surrogate for determining pH like BLL. That is something we should remember. It is commonly associated with pH like BLL. And why it is so important to identify, this is, I think we have already discussed, that these are actionable, especially the ABL class fusions. You can target them using tyrosine kinase inhibitors. So for our cases, I mean, this is just for illustration purpose. Don't think that CRL2 rearrangement leukemias do not yet have very evidence-based guidelines for target therapy. But in this patient, in our two patient, the NUP214 ABL1 at post-induction time point had 10% disease, and at this point he received imatinib. And as you can see, then this particular patient, it was very, very helpful. Like at this point of the RNA-seq result came, and the imatinib was added to the protocol, and you can see that this was very helpful in improving the clinical outcome for this particular patient. Right. So then I'll just finish with two more short things, and then we will go for the case discussion, which is, I think, the most important thing. So this is a 2-year-old female with BLL, and you can see this is an NGS plot I'm showing you. This is just I wanted to emphasize that copy number alteration can be detected by NGS, especially the gene-specific ones. Like FISH or karyotyping can give you chromosomal or arm level changes, meaning let's say 7q deletion or 17p deletion. Those are detected by FISH probably better. But the gene-specific ones, you don't have that resolution in FISH or karyotyping. You can't go that below, right? So here you can see this is the PAX5 gene. This is the CDKN2A, 2B gene. And you can see this a portion of PAX5 at exon level. So exon 1 to exon 5 is kind of increased. The coverage here is increased. So what will be the diagnosis in this case, if anyone can tell me? There is what is known as an intragenic amplification of PAX5, right? So this will belong into a group of leukemia known as PAX5 alt. So PAX5 alt BLL is an important subset of BLL. We will come to the clinical significance of this. We now know that PAX5 determines at least 2 subset of BLL. One is by this point mutation, the PAX5P80R, and the other one is PAX5 alt, which encompasses an amplification, as we have seen, PAX5 fusions and so on. So these two have different gene expression profiling, and they have different outcome as well. So again, this is important to know because it is not fusion. Sometimes even gene-specific copy number alteration, or even point mutation, which is something we never knew, that point mutation can also determine a subset of BLL, right? That was not the idea usually. I mean, we know that in the space of AML, of course, but in BLL, we know it is structural changes or fusions. But even point mutation can determine a subset of BLL, which is this example. So now if we complete this chart, this is the, just to give you an again, this is not all inclusive, but just a rough idea. Now we have lots of other fusions like this, like DUX4, ZNF384, MEF2D, and so on. We have even point mutation, as we have just seen, PAX5P80R, IKZF1, N159Y, and in especially adult setting, even IDH mutation, which again, we know that it has to do with only AML, but it has a subset of BLL has this mutation. And this is again cut, so please ignore that. But there are subset that phenocopy, or as you have correctly said, subset that mimic at a gene expression level some other defined entity, such as BCR-ABL like BLL, or ETV6 junction like BLL, and so on. So these are the driver mutations or driver alteration that determines the subtype of particular BLL. But what about this though? If a child has this, like this is, you can see exon 2 to 8 IKZF all deletion, right? So you all know this is poor prognosis, right? IKZF has to be poor prognosis. Why is it not a subset of BLL though? I mean, it is quite common, I think. Why do you think it is not a subset of BLL? We don't know a BLL called BLL with IKZF1, right? Why it is so? If anybody can have any guess. So this is, you can think of it akin to, let's say, FLT3 in AML, right? So these are secondary mutations. This comes in known drivers. So IKZF1 occurs in pH positive BLL, pH like BLL, DUX4 rearranged BLL, in many other already known subtype BLLs. So they occur as a secondary alteration, which gives the tumor a proliferative advantage, just like FLT3 does in AML. So we do not have a FLT3 mutated AML as a category, but we know it is very important to identify them for risk stratification and in FLT3's case for therapeutic significance. So something more. In this patient, not only has an IKZF deletion, she also has a CDKN2A, 2B deletion. So would it change the prognosis in any way, or you think this is IKZF deletion only? Is there any specific subset of BLL that is known with this? Yes? Somebody is asking for the mic, so I'm expecting answer. So if IKZF alteration is associated with other alterations in these few genes, it is known as something known as IKZF plus or IKZF1 plus, and they specifically have a very inferior outcome, at least according to the AIOP data. Although some of the recent data challenges and says that when you take into consideration the other genomic subset that you have just said, pH-like and so on, probably the difference is not so significant. But what we know so far is that IKZF1 plus may be even more important to identify than IKZF deletion because they have a particularly poor prognosis. So based on this, if we can just have a idea of flowchart, how to work up in a case of BLL in today's state in India. So what we do in our lab is the font is gone, so all these things are gone. But anyway, so typically we will do, as we have said, flow, cytogenetics, and ploidy, and FISH and karyotyping, right? So in flow, we have CRLF2. So if CRLF2 is overexpressed, we will straight away go for RNA sequencing and determine the exact partner. This will be a patient of BLL with BCR-ABL1 like with CRLF2 rearrangement. If they are negative for all this, so all the common ploidy and common fusions are negative, so then you can definitely go for targeted RNA and DNA sequencing. FISH can also complement this, but again, like I said, there are many caveats of doing FISH in such kind of situations. And with this, you can identify all this. So ABL class fusions, like what we have discussed, JAK-STAT pathway part of BCR-ABL like BLL, the PAX5 subgroups, and also the other fusions such as MEF2D, ZNF384, and all this. So with this, I think we will end this part now and we can go to the cases. So if any question at this point, we can take, I think right now. About the workup of BLL, yes.
I think we can take the questions later.
Okay, sure, sir. Sure.
So the both of you can answer.
Sure. I'll invite Dr. Nita then because right now we both will be here.
Just give us one more mic on the.
Yeah, here, both can be no problem.
Yeah, otherwise we'll do it like this. So we have quickly go through few cases. So this is a 9-year-old boy, BALL, ETV RNX1, CNS negative. He was treated at another center on icicle protocol, and he presented with a late isolated medullary relapse. So this we did an NGS at this point. So this is less to basically discuss how to read an NGS report. So this is how the report comes in. So so the questions are like, how should we read a report? What is read depth in that? And so maybe you take those two questions and then we discuss the rest.
Yeah, so I mean, in read depth in this particular context is of fusion. So this basically determines what is the fusion specific read depth in this case. So which is 140, which is very, very, I mean, usually you will have more than 20 is very good, even more than 10 is fine if it is a very important fusion. So that is what it is. It is completely different to what in DNA context, let's say you have a coverage or you have a read depth, that is different. So this is specific read, I mean, what is the fusion specific read that you have got? So in this case, it means that. About the viewers, should we take the viewers now or?
So read depth is different from VAF. VAF is like the percentage of cells which are positive in the entire.
That is mostly in the context of DNA. I mean, we're talking about DNA sequencing. Let's say we have C as our reference sequence, but in this case, it is C2T mutation has occurred. So how many T's by how many C? So that is what roughly is the concept of VAF. Whereas this is something different where you have just seen what is the ETBC Rangsuan fused copy number, fused read, how many reads we have got.
So when we read a report, when we get a read depth like this, what should we, so this you said is very good. So what if it
happens? So usually in fusion, it is specific. So I mean, a normal person will not have it. Normal person will not have.
यूरिन कितना किया?
Is there a
हाँ मैंने
Zoom
देखा सुबह 9 बजे के बाद अब तक यूरिन नहीं किया. देखो 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 प्रीति मैम से बात हुआ तुम्हारा? किसका बात हुआ है प्रीति मैम
I
से?
have a question.
Yes, sir, please.
Read
Preeti
depth, I
ma'am.
think, is still important.
Yes, please, sir.
Because
we wanted everybody to
yeah,
come.
because you do exon tiling
Yes.
for finding the fusion.
Yes.
And if the exons have not been covered adequately,
Yes.
your fusion probably can be a wrong call. So I think, though read depth may not matter in the sense that you are basically the number of reads that you see for a fusion.
Yes.
But I think read depth is very crucial for saying that the fusion has really come from extensive exon tiling or not.
Absolutely. Absolutely.
So that's number one.
Yeah.
Number two is, I think, I will never agree to the fact that you have 2 or 3 or 5 very well aligned reads for the split reads, which are going across the junction.
Yeah.
And you can call them positive.
Yeah.
I think there is a rule of a good 25 reads.
20 is what we also go for.
So if you have a LOD of 5% for reporting, then you shall have with a 500x 25 very good reads. Or if you're using the way you are using, I think you're using a copy of Archer,
Similar.
Flex,
Yeah.
isn't it
Yes.
something similar with
Yes.
2 GSPs and 1 common primer? Even here, I think you shall get at least 5 good spanning reads. And in case you have a good bioinformatic team, which can do tiling, local assembly, then 3 split reads.
Absolutely. We also go by 20. I completely agree with you.
So though this may appear, like that's what I want to say, that you may get a report which may say 3 reads have been seen of a fusion rearrangement.
Yes.
Be very skeptical about these 3 reads.
Yeah.
Ask them several questions. Well, how was the exon tiling done?
Yes.
Is it a split read? Is it a spanning read?
Yes.
So I think there are lots of nuances which are attached to read depths and the numbers of read for a fusion.
Yes. So I think what Sir said is very important. One more important point here is if you have less than 20, like what practice we follow is if like Sir said, spanning read, if it's less than 20, it is always good to have an orthogonal validation. So for fusion, it's very simple. You know, if you have an RNA sequencing, you know exactly what, sequence are fusing. So you can design a PCR primer and you can see if it is there or not. So if in these cases, if there is less than your confident level of read depth, you can always ask the lab to do an orthogonal validation. If it comes in, then it's very good. If it's validated by separate.
Limit of detection is 5 and about 20 is significant.
Confident, yes.
So for a clinician, 30, 300 is
Limit of detection,
same,
something
right?
again you have to establish each
My,
lab has to
sugge-
establish.
my suggestion will be the lab you are outsourcing to,
Talk to
ask
them.
them what will be the significant level and give me the reason.
Yes.
And keep that under your glass table.
Yes.
Hmm.
Because these are lab specific things. Yeah.
Yeah. So what is VUS in the leukemia genomics, this thing? And if you have something new which is coming up, how do you prove that it is pathogenic? Again, do you look at the VAF or the read depth, or how do you decide?
So I think we have some slides on this. So fasting. Yeah, right. So this is the problem that you were alluded to, that what happens in VUS. So, I mean, how to make sense of a report, right? You can get a report like this when you are doing, reading a report of NGS, and you will have this interpretation here and this annotation here. So many cases, what you will have a VUS, right? So this is a very important point I think we must keep in mind. So the question then becomes that, is it a pathogenic mutation or is it not? So that is a debate that can always raise in this space, especially in our cases where not that much, for example, in the BRCA1 space, there is a lot of literature. Maybe there is not too much literature, right? So there is some common principle to it. So first is that there is no lack of definitive data in many of these situations, and all tools and software can go wrong. This is something you must remember. Positive correlations are always preferentially reported. So do not trust anyone if somebody says this is a variant, this is pathogenic. What is the evidence? You must ask that question. Okay. So these are some of the reason why I'm telling you this. So if you look at, this is CleanVer. CleanVer is somewhere people submit their data. If they got some novel variant, then I think this is pathogenic. Somebody think this is benign, they will submit that data, right? So these are the entities where there are more than one submitted, so at least 2 submitted, and they looked at the concordance. This is 16,000 variant I'm talking about. So you can see almost 25% were actually discordant between 2 people calling it. Thankfully, the larger portion of it, which is 22%, was in a space of VUS versus benign, which may not be that clinically important. But still 3% is VUS versus pathogenic, which is clinically significant. And 3% of 16,000 is again not that simple. This is another example. You can see this is a allele which was initially reported as pathogenic on the basis of American data. You can see that in America, it's only T. It doesn't happen in population. But if you look at the population-based thing of all over the world, there's a lot of these yellows, which means that this is actually a allele which is present in the population at a minor level, may not be in the initial data set that it was diagnosed with, and therefore this mistake was happened. So there are a lot of these false positive associations that people have made too, and we must be aware of that. So the golden rule, the first and second rule of variant interpretation is that do not assume pathogenicity. So the default assumption is benign. We have to think this is a benign variant, and the pathogenicity, just like our legal system, the pathogenicity needs to be proved rather than looking at it in the otherwise. So this is how we do it. Like, this is just again, I mean, we cannot go into detail of this in this class, but this is like, there are some molecular evidences, like what type of mutation you're talking about. Clinical evidence there is very good. Like, has it been described in some studies, like case control linkage and so on? And is the variant present in general population? So this is the general approach to going to it. There are definite guidelines, SCMG guidelines, but again, I want to tell you, like, what does it mean to be likely pathogenic or likely benign? So when the guidelines were made, the idea was that likely pathogenic means that there is at least 90% chance of this being pathogenic. That's what likely pathogenic means. Similarly, likely benign means that there is less than 10% chance of this variant having been pathogenic. So the whole lot, that is 10 to 90%, is covered in VUS. So when something is VUS, it does not mean that this cannot be pathogenic, right? It means that it has a 10 to 90% chance of being pathogenic. We do not have adequate evidence to say the pathogenicity. So if there is strong clinical evidence, you think that patient has a specific phenotype, it is completely correlating, probably you should consider that as pathogenic. The golden thing to do would be a functional study, of course, but you still, on the basis of a strong clinical data, you can probably suspect that. And so this is the kind of approach that you should follow. Like, the variant annotation also depends on some of the HGFS or aware nomenclature. Interpretation, as I have showed you, you should follow all the guidelines. You should always take care of the clinical evidence. And finally, there should be molecular tumor boards, like, where you can discuss all this. So in my lab also, it's possible that Dr. Nikhil thinks it is pathogenic, I think it is benign. It's possible. So those things you should come together and discuss with your all of your colleagues. And the good thing is, another important thing is to share data. Just like I told you that ClinVer people submit, that when they get a novel data, they submit, this is what I think is pathogenic. As you build on these data, you then have a large pool of data on which other people can be, can use and can benefit from that. So yeah, I think that is all I want to say.
Just a practical question.
Yeah.
So we as clinicians, we've been doing NGS in quite a number of problems.
Yes.
So when it comes as a VUS, should we interpret or should we take a genetics person concerned?
You should
Because
take
we don't
consideration
need
of
to land
everyone.
The medical legal issue later
Yeah.
on. So
Yeah.
I want to understand from you, should a clinician, a pediatric oncologist be interpreting and writing his opinion?
It should always be in a tumor board. I think we should have all the cancer geneticists. The
Geneticists should be involved in.
Yes, for sure, for sure.
I think this message should put everyone over here.
Yes.
That if you see a BUS in your report, don't just assume that this is pathognomic or non-pathognomic.
Yes.
So, because there are quite a number of times we get patients from different institutes where they have been counseled that this is a pathognomic stuff.
Yes.
You should be taken the patient like a patient of aplastic anemia and you get a BUS and it's
Absolutely.
been written that this is a BUS and probably a united bone marrow failure syndrome. So you take the patient for a happy transplant.
Yes. Yes.
Alternative.
So as I've just
So
said,
that
the
you can-
tendency.
you can give them an option of ATG with cyclosporin to those patients. I think our geneticists should be involved in each and every case.
Absolutely. I think
So-
the tendency is, sorry, just 1 minute.
So after the due diligence has been done, and after the databases have been hunted, and you have found that there is a very little or no minor allele frequency reported, and this has not been shown to have strong associations, whatever, segregation studies, functional studies, then it is a VUS. And if it is a VUS, the clinicians are expected to sleep over it. The pathologist is expected to see after 6 months at some predetermined periodicity whether it has changed from VUS to pathogenic or not.
Sure.
And this, a good, astute physician will keep asking what has happened to my VUS if the patient still is alive. And a good pathologist will keep looking for any change. So I maintain a repository of my VUS and I periodically examine every 6 months. And if they have become benign, I send a congratulatory note to the patient or to the individual for whom we had done the testing. And if it has turned pathogenic, then we invite them to get the counseling and further testing done. So this is what you should do. This is not in your realm to decide what you should do.
Absolutely.
This is in the realm of the person, but he should be very, very careful once he converts a VUS in the database to pathogenic.
Yeah.
You should, that onus is on you and it should not be done very casually.
I think the bottom line that I wanted to give, as sir said, is that do not positively correlate with it just because you are getting something and you think this might be the pathogenic thing. So that is the tendency that people have, and that is what all these false positive correlations show. So that is something we must have.
So in a cancer setting, yes, ma'am.
What this abnormality has been reported as.
Yes.
The patient has been reported as. So I could not understand from the same lab, you said I may call it pathogenic and you may call it not pathogenic.
No, so yeah.
The database is the same. So how do you reach the difference?
So ma'am, this is only one part of it, as you can see from this chart. So this population data is only one part of the analysis. We have most of the, if we have a population data, if we have a literature on that, the job is very easy. In those cases, usually you do not have a problem calling it. But what about these molecular evidences? There are many tools to do it, right? So you can predict based on the protein structure, how the protein structure will be. You can predict based on something else, like is it in the hotspot of that gene or not? That will be gene specific as well. Some gene has more missense mutations. Some gene has more loss of function mutation. So in a particular variant can be pathogenic in one gene, but may not be pathogenic in some other gene. So there are many nuances to it. It's not only literature searching. Literature searching is in fact one of the easiest thing to do in this.
So Gaurav, if you are reporting, I think, unless you have done co-segregation, functional studies, and you can say with certain degree of
Yes.
confidence that it is pathogenic, you shall rather stick to what the databases are saying.
Yeah.
And I think ClinVar is a good database. You can look at the star rating of the ClinVar. So there are star ratings in ClinVar. So some are non-starred, that means they have just been added to the database. Some are single starred, some are 2-star, 3-star, 4-star. So those which are 4-star are absolutely certain. So there, if it is a VUS, it is always a VUS. If it's a 3-star, it is a VUS, it is a VUS. And then I think simultaneously, you can look at the OncoKB, which is a very good, very well developing database. And I have seen cases where the ClinVar has called it VUS and OncoKB has called it pathogenic.
Yes.
So then at least for my legal moorings, I have a database which is saying it is pathogenic.
That is the thing. Like, I mean, there are many variants which are not even reported in all those databases. So for that, you have to use software tools and they can always go wrong. So that's the main point, is discuss among everybody. Everybody should discuss together and do not assume pathogenicity. These are the two bottom lines I can give.
One quick question. When we say segregation and when we say functionality, how do you do it in a leukemia setting?
It's difficult. I mean, if you have to have that functional genomics component integrated in your lab as well. You can do it for one variant. You cannot do it for 100 variant. Like if you're getting a whole exome, you are doing it routinely. And every day you are having 10, 12 US variants. So it is very difficult to do that. In AML space, we are going to systematically look at it. In fact, in all pediatric malignancy space, I think Dr. Badira and Dr. Rajesh Sarin have a grant now. So they will look at it as well. So we'll look at it systematically as well. But then again, it's very difficult to, you can always choose your variant. You cannot do functional validation in all the
All the cases. Yeah, I know. So we'll go to the next two important questions. Interpreting VAF. So this is a 13-year-old girl relapsed. This is the two variants that have shown up. So what is VAF? And what is, when do you think this could be germline? So these are two things which come.
So again, from VAF, as I just said, so this is basically a rough, ratio of your altered read versus the read that was supposed to be as according to the reference genome, which was there. So the guideline, if you look at, again, you have to look at literature and gene, like is this gene reported in this context? So for example, if I'm getting SEPA in an AML, I am already, my suspicion index is high that this could be germline, right? So this is well reported. If you look at the guidelines, especially the British Society guidelines, they will recommend that in any gene that is known, they have a list as well, that 30% for SNVs and 20% for Indel. So that is the level you should be suspicious of. You should think that, yes, this could be germline. You should go for germline studies. Having said that, we have seen TP53 mutation with 7% VAF, which is actually germline. So that can happen because there is something known as somatic mosaicism. So this can also happen. So it all depends on the clinical index as well. But in our setting, what we mostly do is known genes. And if it is at more than 30% VAF, so we'll at least recommend germline testing. Ideally, it should be done systematically in all cases. Only then we'll be able to know what is the real germline incidence in our setting. As I've said that we are doing that as part of 2 projects now in the upcoming.
I would like to add something.
Yes, sir.
So if you should know the blast percentage or the abnormal cell percentage. In hematology, it is slightly difficult because in CML, the mature cells will also carry the same genome as the myeloblast will carry. So, but still, the VAF is dependent upon the abnormal cells from which the DNA has been drawn. And if it is more than 50%, that indicates that there is a likelihood of germline alteration. But remember, there is something called loss of heterozygosity, especially in TP53. One allele has been knocked off, so the percentage will be higher. And there is something called uniparental disomy, or what we call as copy neutral LOH, where again your percentages will go high without there being a germline. Yeah. So you can suggest germline if it is more than 50% of the abnormal cell population. But if it is less than 50% of the abnormal cell population, it is unlikely. Mosaicism is there, but mosaicism is somatic. It is not germline.
So the BCH guideline recommends 30% because of all those factors that Sir said, LOH and all that. So that is something you can have a suspicion if it is a known gene. One critical point which Sir has alluded to is that what is the germline tissue you're looking for? Because these are blood cancer patients you're talking about. So you cannot take peripheral blood as a sample. So in this case, this is one of the patient I'm showing you. In this, it was done in sorted T cell. The ideal way to do it will be from skin fibroblast culture. That is the best thing. But again, then you have to have that kind of setup in your lab that you can.
You're exceeding time.
Yeah.
Yes,
So I can do
after
culture.
it.
Yeah, sure.
I think last question to
Yeah.
you. So there is a kid who's like highly refractory to treatment, and you do an NGS. It's a young boy. You're suspecting something else, but then it comes out for return. A report is it comes out as negative. So what would you do in your lab? So currently we are limited by this report, and we palliate the patient. So what would you do?
Yeah, I mean, we know that BLL still exists. I mean, even if Senju data, you see in our setup, it is around 80% we can genomically characterize by doing a targeted DNA and RNA sequencing. In Senju data also, it's around 90%. So 10% BLL still do not have any driver mutation. So it's possible that it will be just biologically true. There are technical reasons as well. Like especially for doing whole exome, there is chance of missing is very high. Like what is the coverage of important genes you should look at. The BLL space, it is still slightly little different because here we are talking about structural changes and fusions. So you have to do RNA sequencing for sure in this patient. Like if RNA sequencing is negative, only then you can, I mean, DNA sequencing is something I will probably have rated after RNA in space of BLL because we are looking primarily for fusions, right? So there can be technical reason, but there can be true biologic reason as well. Like around 90% patients are only classified into one of these subtypes.
They may be driven by microRNA alteration. They may be driven by
Yes.
genetic alteration.
Sure. So I think it's just keep on.
Several things which are beyond genomics.
So I think we'll stop here.
We will.
Yeah.
So thank you so much. Okay, you want to give some take off?
Okay, thank you very much, Dr. Neeta, Dr. Gaurav. I think this was a really interesting session and a lot of learning in this. So I think a lot of residents are there. So I think what was really emphasized was that genomics, we've come a long way. I think a decade ago, we were, talking of this finances are not permitting. We were foregoing, NGS or various forms of genetic profiling, etc. But today it has become a necessity. I think most centers are not treating ALL without doing a NGS. And to give you an example, even if we start the way we started with iCycle 1 and now iCycle 2, it has become an integral part, and all this B others and IKZF plus, etc., you would very well know, all these have been incorporated into the iCycle protocol as well. So this just proves that how important it is for initial risk stratification, of course, response assessment, and of course, predicting relapse. So one or two questions were that I think which for the residents also and for us, what is a good sample? Is it blood or is it bone marrow always? And the other thing would be, as Sir pointed out, that lab specific. So do we need to always have a look at the panel that has been covered? So I think that is very important. Often you realize that you made your interpretation and the patient relapses, and when you go back and you see your ALL panel that was covered, that was incomplete. Actually, we've had these situations. So would you want to comment on that?
Well, the second part is easy. Of course, you must look at the panel as well as the median coverage. So what is the median coverage that has been used? Like whole exome, the coverage will be around 50, 60x or 100x. If you're doing targeted, it will be much higher. So you have to know what is the chance of my missing. Especially true for the secondary mutations. Like for example, in AML FLT3, we know that it is subclonal. It will happen in 15-20% only. So if the coverage is low, you might miss it, right? So that you must look at, that what is the gene that has been covered, what is the coverage that has been used. The lab will have this data of gene specific coverage also. If you are very doubtful, you can ask the lab as well that what is FLT3's coverage, please tell me. That is also possible, that it can also be done. For the blood, on the sample, I think for BLL, blood is fine if as long as enough blast is there. I mean, we don't mind taking blood at all. I mean, if the number of blast is adequate, we can, both bone marrow and blood will serve the same purpose for molecular analysis. No problem at all.
There's RNA sequencing. How early should the sample reach?
As early as possible. Yes, as early
has
as
to
possible,
be.
definitely, no doubt.
Early.
I mean, we would like to extract the RNA.
Yeah.
In our setting, we do it within the same day. I mean,
Yeah.
usually 4 to 6 hours is all it takes. Like most of our sample come from TMH to ACTRAC, which is like a 1.5 hour journey. So that journey is there, but after that we all usually extract. So in RNA, yes, if you're sending to a lab where the processing will be more than 1 day after, you should use specific biologic, transporters to do that.
And how important is clonal evolution in ALL? It's very clonal evolution, like for AML relapses, it's an absolute must, and it is very important. But in ALLs, if you have a full genomic, genomics, etc., you've done a full NGS thorough.
Less is known in this space as compared to AML because this is mostly a fusion dominated space. You will have that same fusion mostly. But then again, as I think Dr. Neeta has showed, there are some mutations like NT5C2, TP53, CREP, which are known to be enriched in relapse. But I don't think there is enough data in this space yet to recommend something from.
If you have done it at baseline, you don't need to do it at relapse, or you will need to do it.
There can be changes as well. I mean, you should definitely document that, especially in late relapses, for sure.
So I think you don't want to take some questions from the audience right now.
I think we are running out of time. So probably if we have any questions from the audience, we can either take it during lunch or they can be discussed during the coffee break.
Okay, thank you.
May I please request Janvi to please come forward and give away a small token of prize from us.
Dr. Neeta, because this was a combined session and she.
Thank you for all the pearls of wisdom.
May I please request Dr. Anurag Mehta to please, the stage. Please. May I also request Dr. Nida and the speaker to please be on the stage. Dr. Gaurav, please. Also, Dr. Rashna. Please, ma'am. Thank you. Thank you.
Good morning, everyone. Thank you so much, speakers and chairperson. That was definitely an insightful session and has added depth to our understanding. While going for the next talk, immunotherapy is rewriting the textbook of leukemia. From bispecific antibodies to CAR-T, the dreams of engineering a cure is becoming a reality. The panel for the next talk will discuss how these therapies are transforming the outcomes. And for that session, I would like to invite the chairpersons, Dr. Chandrika Verma and Dr. Ravi Shankar. Dr. Chandrika Verma, ma'am, is a senior consultant pediatric oncology at Max Healthcare, Noida. And Dr. Ravi Shankar is a consultant in pediatric hematology oncology and BMT unit at Yatharth Super Specialty Hospital, Noida. Sir, may I please request you to introduce the moderator?
Good morning, all. It's a pleasure and it's an honor to introduce Dr. Deepak Bansal. He actually needs no introduction. He's a distinguished pediatric hemato-oncologist, currently serving as the professor in the Department of Pediatric Hemato-Oncology at PGI Chandigarh. And he is one of the backbones of the pediatric hemato-oncology chapter. So I welcome Dr. Deepak Bansal to share this session.
You can sit over there. Chandrika, you can also come there. You know, from the previous session, I mean, I was just thinking that the gap between the knowledge of clinical people and the passion of the molecular pathologist is so vast. We really need a bridge between the two. So I think just to have a breathing space for clinical people, we'll talk more of a clinical topic, which is now challenging to learn. And so the panelists are Vikas from Fortis Gurgaon, Anshul from Medanta, Lucknow, Neha, Medanta, Gurgaon, Silky from ESI, Faridabad, and Priyanka Soni from Mahatma Gandhi, Jaipur. Yeah. So because time is limited and we've got a lot of questions, so we'll just start flowing. So I'll start with Vikas, you know, the basic Blina and its mechanism of action, Vikas.
So Blina, we call it as a BiTE therapy. It's a bispecific T cell engager. So it engages the T cells and the CD19 expressing B lymphoblast so that the T cells get activated and the enzymes perforin get released from the T cells, which can lead to apoptosis of the malignant cells which are expressing CD19.
Right. So thanks. So I don't want to be repeating all the answers, but it's basically it binds the 19 and it binds the CD3. So it makes the T cells kill its own the B lymphoblasts. So that's the way Blina works because it's a bispecific antibody. So Anshul, so what are the indications for Blina is now the standard of care component of regular treatment? And is it administered to most newly diagnosed adult children with ALL in the high income countries?
So in 2016, Blina got an approval for the treatment of relapsed refractory pediatric BALL, and pH negative BALL, and thereafter in 2018 it got an accelerated approval for MRD positive relapse BALL, and finally in 2024 it again got an accelerated approval for an upfront new patients of newly diagnosed cases of BALL as a consolidation therapy. So definitely it has now come as a standard of care, and in US and high income countries, definitely it is being promoted as a better approach for non-chemotherapy approach and immunotherapy approach for having less toxicity.
Right, right. So thanks, Anshul. So it's actually quite amazing that, during our lifetime, the treatment of ALL is actually changing in front of us. So Blina indications, as per this recent article few months ago, so most patients with relapsed refractory ALL need it, and majority of newly diagnosed pediatric and essentially all adult patients with BALL need it, including pH positive ALL and Down syndrome. So I mean, it's a big market out there for both pediatric and adult ALL for Blina. And if you read more into it, it's now recommended for all newly diagnosed BALL, except for a few with excellent outcome with chemo alone. So this includes a few standard risk patients, and these are the criteria which would make them not be candidates for Blina. That is, if they have favorable cytogenetics, CNS negative, like just 1 or 2, and MRD being negative even at these are the numbers. And there are a few high risk patients who are also not candidates for Blina. High risk would be more than 50,000, but if the age is less than 10, favorable cytogenetics, CNS1, and a good end of induction, MRD. So other than these patients, all new ALL patients should ideally be getting Blina. So, and just a few days ago, 5th of September, Blina has been added into the WHO model list of essential medicines for children in the WHO list. So this was the effort of resonance by Scott Harvard and a lot of other team, because of which this has happened. I'm not really sure what is the implication of this, but maybe one can put it better to the governments that it should be available. So Neha, something very difficult and which really hits us every day. So what is the cost of Blina for one cycle, let's say for a 20 kg child who's getting the standard dose for 4 weeks? Yeah.
Yes. So if we are coming to the second cycle and the dose is 15 microgram per meter square per day, approximately a 20 kg child would be around 0.8 to 0.9, and but the dose will be calculated like 0.76 ml of the vial. So earlier, what we were doing as per the Blina PDF which the company was providing, that a vial can, when you prepare a bag, it can be used only for 48 hours. So from one vial you can use only for 48 hours, means that you are going to need 14 vials, which will increase the cost. But I was just discussing with a few people who are using it under the MGAN program, where they are finding it free of cost. So in St. Jude's, I think they are using it for 4 days, 96 hours back they can prepare. And now if you are using it for 96 hours, then you will use only 7 vials and the cost will come down. And if the approximate cost is around 1.5 lakhs, then it will come down to 11 lakhs for the whole cycle of 28 days.
So does anybody else have any other experience with the cost? Like, is it 1.5 lakhs per vial or is it different?
So earlier it used to be cheaper, but now the cost has apparently increased.
Right. Yeah.
Dependent on where you are importing. Whether it is being imported from Turkey or from US, the cost is entirely different. It is from 1 lakh. US cost is higher.
Yeah.
US cost is 2.5 lakh per vial.
Right. So I did ask a few importers, and this is what I found out, that if you ask the importers, they are actually giving the price of one vial anything from 2.6 to 3.3 lakhs. Whereas if you ask a chemist, he said 1 lakh without bill and 1.5 lakhs with bill. So the cost is anything from, for one cycle, if you use 10 vials, is from 10 to 26 lakhs. And typically one has to give 2 cycles as per recommendation. So look at this cost. So so this is the main hitch where it is for the use of Blina. Anybody else wants to add anything on this? No. Okay. So now the question for Silky is it available free of cost through any NGO? And what is this Blina Humanitarian Access Program and its eligibility criteria? Yeah.
So, sir, although as you mentioned, we are talking about an essential drug now, but unfortunately, I don't think any NGO can provide such an expensive drug, for a simple reason, because it is too expensive.
So that is where comes the role of this blinatumomab humanitarian access program. And this is a combined initiative of MJN with St. Jude Global, and it is provided to certain qualified centers who are partners with St. Jude Global to children living in LMICs who wherein this drug is not commercially available. So this initiative was launched in 2021, and apart from the free of cost drug that they provide, they also provide some medical training for safe handling of the drug and for reporting of adverse effects. About the eligibility criteria, sir, can we ask somebody from RGCI like Sandeep sir or Gauri ma'am, because I think they are one of the major centers who have access to this program.
So actually it is indicated for patients in the upfront setting if after consolidation MRD is more than 0.1%. That means after 2 cycles of chemotherapy, induction and 1 consolidation, MRD should be more than 0.1%. Then the patient gets can be applied. We can apply for 2 cycles of blina for that patient, and also for any relapse patient who has medullary disease, we can apply for that.
Right.
And also should not have CNS disease or signs of GVHD or infection that's mentioned or
Right.
any
Yeah.
other.
So correct. So it's for 1 to 18 years of age. It's available only in 3 countries, and my understanding is that they have now stopped enrolling new cases, and the logistics is being provided by this third NGO called as the Direct Relief. And so these are the exactly what Sandeep said. So MRD more than 0.1% after like as they say, 2 blocks of induction, which is practically consolidation for us. And for relapsed refractory, so if it is a combined relapse, like it could be CNS with marrow, then it's eligible, but isolated CNS is not eligible, at least for this. So they are willing to give up to 1 to 2 cycles per patient, and even more if a discussion is held with them. So Priyanka, again, the treatment of infant ALL is completely changing. So what is the evidence of blina in infant ALL? And if one decides to use it, where exactly should the blina be incorporated in infant ALL protocol?
So the initial evidence of blina came from a paper which was published in April 2020, and it showed a retrospective evidence by European group where they have shown taken 11 patients, and they published that the almost all patients, 100% patient achieved MRD negativity. Then the landmark paper was published in NEJM in April 23, where they have, which was a study of 30 patients. So on the interferon backbone, interferon 06 backbone, they have included blinatumomab post-induction. So in that study, it was a dramatic change because DFS is improved from 49 to 82%, and overall survival improved from 66% to 93%. So in that particular trial, they have said that they've included it post-induction for 2 reasons. The first one was that the relapses in infant ALL were early relapses. So they wanted to include it during in an earlier time point. So it is post-induction. And when blina was used with a blast percentage of less than 50%, then it is more effective. So post-induction, when the disease burden is reduced, at that time they wanted to use. So that was where it was placed.
So that's great. I mean, so blina has completely changed infant ALL management also. So this study was really small. I mean, as Priyanka said, it was published in 2023, merely 30 infants. And the rest of the chemo was the same. So, it's not that it's going to be easy. I mean, that inter-infant 06 regimen is very hard to administer. So for right now, I mean, they were giving the same chemo. And a transplant is also done for the high-risk patients. And this is the way the high risk is defined. So it's not that by adding blina, they have reduced the chemo, or maybe, I mean, and these are the percentages that one can see, blina versus non-blina, which has really changed. So, and which has made it a standard component of therapy for infant ALL now. And it was a single cycle of blina. It was not 2 cycles as in older children. It's a single cycle of blina, which is added to infant ALL. So, because what about standard risk ALL? So should we consider adding blina to standard risk ALL, something that we are very proud of, that we are able to treat 80% of them? So should blina be added to standard risk ALL?
There is a publication, a phase 3 trial which got finished, and it's published in NEJM last year. It's a COG trial in which they have used blina upfront for patients who have got standard risk according to NCI. So what they have done is that they had around 1,400 patients. So they randomized into two groups. One group of around 700 patients just got chemotherapy, and another group of around 700 patients got Blina, 2 cycles of Blina with standard chemotherapy. And what they found is that the 3-year disease-free survival was better in those who got Blina with chemotherapy as compared to those who just had chemotherapy. So 96% versus 90% is what they have
So
reported.
because suppose is affording family comes to you today, would you offer them Blina for a standard risk ALL?
Absolutely. If somebody can afford Blina, why not? We can offer these patients a Blina-based therapy, provided we have sufficient time to import this medicine.
Right. And anybody else wants to say anything on Blina and everyday use of Blina in new ALLs?
So I feel there is a if you categorize the standard risk as it was done in the trial, COG trial. So what they did was a standard risk favorable, standard risk average, and standard risk high risk. So what they excluded the patient of a standard risk favorable with the patients who were showing MRD negativity at day 8 and end of induction and hyperdiploidy. So in that they excluded those patients and given chemo only, and those patients were showing an excellent result in itself. So that particular chunk of patients may be.
So that's a minority, but the large majority.
Yeah, but the large majority can be taken for that. So that chunk could be spared.
So Sandeep, what do you think about this Blina to all cases of ALL?
I think if you look at the COG protocol right now, 95% of standard risk BLL are getting that. That small chunk is just 5%. 95% are getting, and they have been able to improve outcome from 88 to 96%. So there is 8% survival advantage. So I think in US now this is standard of care. But in India, I know even if we have BHAP program, these patients won't be eligible for because they have to be 2 MRD positive. In that case, they are anyways not standard risk, and not more than 2-3% of our patient can afford Blina on their own. So practically, it is out of reach.
So Dr. Bansal, I think you said those who can afford.
Yeah.
Those who can
Yes,
afford.
yes, we should
We
offer-
know that treating relapse is still a challenge. And according to the trial, they have used Blina before and after the interim maintenance. So you have time. Somebody coming to you with all the money in the world and is saying that I'm ready to go to US. Doc, can you give Blina in your hospital? Then why not?
India is a very big country, and sometimes there are patients who don't even get treatment for ALL. On the other hand, we are talking of Blina, which is so expensive. So it's such a vast country, and you have to juggle between this extreme poverty and the extreme richness in the country. That Dr. Gauri, any like how does it hit you that is Blina business coming into
Blina.
everyday ALL?
The two things I will say, one is we don't know the late effects of Blina. We don't know how the immunity will pan out. Will they have more infections? I don't know. We have had 1 or 2 cases with problems. Second is, supposing we forget the cost, can we ask how many people would like to use Blina for their patients instead of aggressive chemo?
So instead of aggressive chemo is not established as yet.
What about subcutaneous weekly Blina? I mean, I would love my patients not to get chemo, not for them to get sick and go to the ICU. So definitely, if this kind of treatment comes, I would love it as an oncologist. I can sleep comfortably in the night. And I will tell you that with this BHAP program, for the last 6 months, we have fewer patients, touch wood, going to ICU. Our residents are also more comfortable. Otherwise, those HR blocks, they were like disasters. It was so. I would love a gentle treatment for my patients.
So for the standard risk, I mean, so if you look at the numbers, they are not overwhelmingly better. I mean, it's like 88 versus 96, but but the p-values are significant, the relapses are less. But one has to note this, that even in the US, they had a significantly higher non-fatal sepsis and catheter-related infections in the patients who got Blina versus who got chemo alone. This is for the standard risk ALL. And as was said, their stratification of standard risk is different. They call them average, high, and favorable. So favorable was not given, only the average and high risk were given. But in the average group, the sepsis was actually higher in the Blina group. So what about high risk ALL, Anshul? I mean, where are we with that and Blina?
Yeah, definitely. There is no doubt about it. High risk ALLs, the COG data has very vehemently suggested that it is the drug of choice for consolidation therapy, especially for MRD positive cases.
Right. So my understanding is that there was no trial done ever for NCI high risk ALL. It is just that in the standard risk high, from the COG, and in the adult trial with the younger adults, the outcome were so good that they just extrapolated the outcomes to the high risk. And they said that high risk too will probably benefit. And this is the cartoon that has come up in this publication. So outcome with and without Blina, and is Blina recommended? So infants, yes, this is the difference. For standard risk, yes, this is the difference. In high risk, they are saying because the evidence is there in other children, so this should be good as well. And for adults, again, there is evidence. So it's kind of a green tick everywhere in across the board. So, Neha, we really want to know this. When is the patent for Brina going to expire, and when are the generics possibly expected? So could you fish out some answer out of this? Yeah.
It is a very complex question because the drug is complex and they have protected it with many patents. So it was suspected that the primary patent was expired on in March 25, but they have already protected their drug with multiple other patents. The method of administration will expire in 27 September 27, and this pharmacology composition patent will expire in 2030. So I think only after that we can expect some biosimilars.
Right. Anyone else has any knowledge if anybody else is coming or making it in Gurgaon or somewhere else? Yeah. Yes, please. I can see. Yeah.
Reddy's is coming. Reddy's lab is.
The original company is giving a 18 vials free if you purchase a 10 vials in Singapore. So my 4 patients have gone to Singapore, had an infusion done. That is cheaper than getting in India. We had to pressurize the company to give the same scheme which they are giving in Singapore here. It's only we are not as a group able to reach them. So my 4 patients have gone to Singapore. If you buy 10 vials, you will get 18 vials free.
So that's very interesting to know. So, I asked ChatGPT and I asked, yeah, yes.
The drug gets licensed here, we have to stop. So, because once the drug is licensed in a country, the humanitarian access program is likely to stop. So,
it's giving drug to very limited volume. Yeah,
absolutely. What I meant is that if you get there, then probably temporarily, even if the innovator gets registered here, which is the original Blina, then all these centers will have to stop the access program and only buy. So,
I mean, I was communicating with Scott Howard on this, and he said that apparently Amgen is decided to market the drug in India commercially. So if that happens, then they cannot get it through WHO to India. So that is the other aspect of it, that Amgen is apparently going to market it in India commercially. So, Amgen is, so they are also trying to extend their patent by, like subcutaneous route, if they are able to establish, then that would get patent for another next several years. So, and then maybe the IV drug will stop because the subcutaneous has come in. So then the patent will get further extended. So as Neha said, it's really a complex topic of this patents. So, Silky, the basic things about Blina administration and this fear of cytokine release syndrome. So what are the clinical features, risk factors, and how do we prevent and manage CRS? Yeah.
Sir, it is like a long question given to me. So CRS, as Blina is an type of immunotherapy, so CRS is a known side effect resulting from Blina, which results from T cell activation, and the cytokine storm, which results from T cell activation. So in the clinical features, if we talk about, fever is the hallmark symptom. And there is a grading of CRS for Blina, grade 1 to 4. In grade 1, only fever happens. That can be associated with some constitutional features like myalgia, headache, nausea, vomiting, diarrhea. But then it can become more severe in the form of hypotension, pulmonary edema can happen, and life-threatening symptoms can happen with multi-organ failure. So that's about the clinical features. Then risk factors, if we talk about, the most important risk factor for CRS is the disease burden at the baseline when we are starting Blina. Higher the disease burden, higher are the chances of getting CRS and more severe CRS. Then the other risk factor is the dose of Blina that we start with. If we start with a higher dose, then obviously there are more chances of cytokine release. And the other thing is pre-medication with steroids.
So prevention, yes, prevention and management. Steroids are the mainstay for prevention and management of CRS resulting from blina, unlike CAR T cell therapy, where we are a little concerned about giving steroids because it may interfere with the cellular activity of CAR T. So in prevention, we should first we should try to reduce the disease burden as much as possible, either with chemotherapy or by using other drugs like inotuzumab, with which CRS doesn't happen. We should start with a lower dose of blinatumomab, like 5 microgram per meter square is the dose which is recommended for initial few days for a week.
Yeah, thanks, Silky. So has anybody experience with the tocilizumab in CRC? Like after giving blina, have you seen CRC which required tocilizumab? Anyone?
Only steroids.
CRS issues, but it improved with the patient of steroids.
One of my patients had ICANS. Probably that was probably we discussed also. So one patient had ICANS, severe ICANS, but he eventually improved, but not the life-threatening CRS, and we didn't require TOSI.
Sure. So it's a very frightening thing to read and think about, but it's thankfully uncommon. So just to add a few things, median time to onset is 2 days from the start of infusion. And so the more than grade 3 CRS was earlier about 6%, but now this frequency has reduced to about 2%, because as Silky said, that now because everybody has learned, so everybody wants to make the MRD as low as possible so that the incidence of CRC is less. And the management is with DEXA and tocilizumab if it really goes bad. So then, Priyanka, the word ICANS was mentioned. Again, we have to keep on learning new and new things every day. So, immune effector cell-associated neurotoxicity syndrome. So what is this thing in relevance to blina, and how does one manage and treat it? Yeah.
This is more commonly seen in the patient who also had CRS. Although the incidence in pediatric population is low, it is seen, the incidence is higher in adult patients. So the clinical features may range from mild, subtle neurological symptoms like headache, confusion, or tremors to severe like seizures and ataxia. For prevention, we need to, the risk factors is young age, patient with previous CNS disease, patient who are having Down syndrome, they are more prone to get ICANS. And for prevention, we need to take a good history, clinical exam history, so that we know is there any pre-existing feature, look at the medications which the child is already taking. And we should start slow, as for CRS also, we should start with a dose of 5 microgram per meter square, and we should pre-medicate with steroids. That is important for prevention. And to manage the toxicity, we need to stop the blina infusion if it is a mild toxicity, and if it is moderate to severe, we should start steroids. And maybe we can resume if the toxicity comes down to grade 1.
Right. So thank you, Priyanka. So another kind of a unique feature with blina, and so it can be fatal. So reported in about 7.5% in clinical trials, and can occur in the first 2 weeks of the infusion. So these are the early signs. So one should make them to check their handwriting and the speech. So change in handwriting and change in speech are the early signs of neurological toxicity with this. So it can be seen in up to 65% patients. So it's fairly common, although the features may be quite less significant in the beginning, and majority resolve after discontinuation. So the treatment is again with DEXA. And for all Down syndrome children, levetiracetam is started as prophylaxis, like a day before or a week before, depending on the protocol. So that's specific recommendations in children with Down syndrome to start tiracetam. So yeah, so so now the big question, if you start using
Can I just add one
please.
thing?
Yeah.
After blina, we do lumbar puncture and send CSF for analysis, and at least 4 of our patient had 15 to 20 cells post blina, and all of them were reactive. So this is the phenomena which we see, that after giving blina, we may have some reactive T cells in the CSF. So one should not think that it's a relapse or something like that. So
Better
that
to
is,
do on day 1.
yeah. Huh?
Better to do the lumbar puncture on day one.
We do it on day one also, and then at the end of the Blina also we do.
So my understanding is that when Blina is given, IT is done on day 15 and day 28.
Right. Yes.
So
we are doing on day 1 and day 28. For CNS positive, we are doing on day 15 also. But we have seen at least 4 patients who have CSF first cellular after giving Blina.
Right, right. So we move ahead because it's to be given over 28 days. So the question is, do we keep them admitted for 28 days or do we discharge them? And what kind of infusion pumps do we use? So Vikas, your comments on this?
Honestly, we don't have a experience of using outpatient Blina. We have just used Blina in 4 of our patients. But yes, there are reports, there are publications in which there are COG member centers who have used it as an outpatient basis. They admit the patient for initial 3 days at the time of first infusion, and then for subsequent infusion for 2 days, and then they call the patients every 72 to 96 hours just to change the infusions. And I'm not very sure about these balloon pumps. I think our adult oncology colleagues use it more often, so I don't have any personal experience with that.
Right. So the theory is that now outpatient infusion for most cycles is possible. And there are specific guidelines when the patient, for how long the patient is to be admitted and then sent to the outpatient. So, these are all those high income countries guidelines that if you have MRD positive, I mean, if that is the indication for which you are giving Blina, then in first cycle, you keep them in for 3 days, for second cycle for 2 days. But if it is relapsed refractory for which you are giving Blina, then for first cycle 9 days and second cycle 2 days. So these are the duration of inpatient. But that is only if you really have good facilities for outpatient care.
Sir, I have used it in one patient in infant ALL who had very low MRD, 0.05%. And I kept the child admitted for 4 days. There were no signs of CRS, and we sent her on a infusion pump. It's an ambulatory pump, must be around 10 into 15 centimeter in size. And it was very comfortable for the family actually. And they used to come every 96 hours to get the infusion.
So if I can just add to that, so what we are doing at Tata is for the first cycle, we are admitting them for a week.
1 week.
1 week, yes. And then we have these CAD pumps. So there is this company called CAD, CADD. The cassettes of the pump and the cassettes, they provide from the company. So every 48 hours, they come to the ward and they get it, they get the cassette changed.
Are they different from the regular ward infusion pumps?
They are a little different, yes.
So they are
They're specifically, yes, they're smaller, and the specifications for the cassette, and they both come from the same company. So now, initially we were admitting them for the first cycle for 28 days, but then now we have come down to 7 days for the first cycle. And for the second cycle, only 48 hours, and then we send them back.
Right. So in PJ experience is kind of similar. So we've given Blina to about 17 children, all relapsed ALL over the last 4.5 years. So self-financed in about 70% and 30% through this BHAP. And ambulatory we started using this for the last about a year, and we have given it in 7 patients. So after about a week of inpatient infusion, we send them to the outpatient. It was successful in about 70%. 2 kids got febrile neutropenia, so they had to be admitted. So for right now, we are just using the same infusion pump which is available in the ward, and we just send them out with the same pump, and they come every 2-3 days depending on when the bag finishes for the bag change. So these were the complications, and about 90% went into remission, and about significant of them, of course, had a transplant because these are all relapsed refractory patients, and Richa will be presenting this in PSYOP this year. So I came across this balloon pump. I think we can ask Dr. Dinesh Burhani, is he still here? Or the adult oncologist, if they are using these pumps, because I think they use it for 5 FU in adult oncology, but these are expensive and they don't need electricity battery. I mean, I just found it and I wondered whether is this an option, but of course it will add to the cost, but it's more portable. I guess when Blina is used more often, then one would know more about these. So any other tips, Anshul, that one should know while administering Blina?
So just wanted to highlight that when you are using Blina, so it's a 35 microgram vial, and you get an stabilizer solution also. So many think that probably that solution is for diluting the drug because it comes in a powdered form. So that should not be done, because the stabilizer solution is mainly meant that that drug doesn't stick to the bags or other thing. So you have to, it's a lyophilized powder, then you have to first dilute it with the sterile water, mix it, swill it, it doesn't get too much foamy. then then you have to first add the stabilizer solution into the normal saline before mixing the drug. And you have to prime the tubings with that, and then you have to add the drug into the normal saline. So that sequence has to be followed, and these are written in the instruction manual of the package insert also. And as far as the elastomer pumps are concerned, they have highlighted, the package insert has given no that these should not be used for administering Blina, but I don't know whether there's a scientific basis around that or not. But per se, the package insert says that it should not be used.
That's good to know. Okay, okay, fine. So yeah, I mean, the instructions to how to give Blina are so long, and this DAP people, they do 3-4 online classes, which you're supposed to attend. So, infusion reactions are common, but mild CRS is common. Fever is very common, and one may have to distinguish it from febrile neutropenia, and one might be tempted to start antibiotics, although most of them are not neutropenic. So typical is for 4 weeks followed by 2 weeks off. So one is supposed to do a neurological exam daily to look at, ICANS and toxicity. Fluid balance and weight again for CRC, because if they are gaining any fluid anywhere in their body cavities. Apparently OTPT, the liver enzymes can go up to 1000, which one is supposed to ignore. And as I said earlier, in Down syndrome, one is supposed to give levetiracetam prophylaxis. So, Silky, what about this Blina and it not working in the CNS? So, any comments on this? Yeah.
So, sir, as we all know, Brena has an excellent effect on the marrow disease, but this is not the case with the CNS, neither for the prevention of CNS disease and nor for the treatment of CNS disease. And there is enough evidence suggesting this, like from the COG ALL 1731 trial, wherein it was used in newly diagnosed BALL patients. The incidence of CNS relapse in patients who received Blina versus patients who received only chemo, it was very similar, around 1.5%. And when it comes to treatment of isolated CNS relapse, again, the disease-free survival there is no benefit to it when Blina is added. It remains
Yeah, fine. So, I mean, it's just that one should not be forgetting giving intrathecal methotrexate while Blina is going on, because it does not penetrate the...
Preferably, triple intrathecal should be given. It's said that.
Okay, so I guess whatever the protocol says. So, so the next big question is that, I mean, this is extremely attractive in LMICs, that if we start giving Blina, can we reduce the intensity of chemo? I mean, it has just come up for the last few years, so we really don't know, but is there any evidence for this?
So there's still, we are waiting for a big study to come, but there is one study, Chinese study, which was published in 24, in which they have reduced the intensity of induction to 3 drugs for 7 days, which include Windesson, Dexa, and idarubicin, and added Blina for 15 days. And those who still had MRD positivity, 15 more days were added. So in that study, they have tried to reduce and found significant result, but yet we are yet to have more studies to have reduced intensity of chemotherapy.
Right, right. Yeah, so, just for this panel discussion, I try to read this. So, in the infant ALL protocol, there is a study wherein they have removed 2 blocks and replaced it with 1 cycle Blina. So, which is very, very attractive, because in infant ALL, we really fear intensive chemos. And so they said that it is possible to de-escalate chemo, although it's a small study. So they replaced 2 blocks with 1 cycle of Blina. So small studies. And in June this year, the UK relapsed BLL guidelines were available on their CCLG website. So these are actually quite interesting. So in the high risk group, when we say high risk BALL relapse, it refers to very early or early relapse, or patients with high risk cytogenetics. So for reinduction, they have used only 3 drugs if it is less than 16 years. I mean, how commonly we use only 3 drugs for reinduction, and for more than 16 years, 4 drugs. And if the day 15 marrow blast was less than 5%, they have started Blina at day 15. So imagine a child getting only 3 drug induction for a relapsed ALL and just for 15 days. And on Blina, if the day 28 marrow is less than 0.01, they have taken for transplant without giving second Blina. So just 15 days induction with 3 drugs, followed by Blina. And if MRT continues to be negative, so transplant. So just within 3 to 4 months, a child with ALL relapse would be cured. And if it is not negative after one blina, they would continue to give it the second blina and then take up for transplant. And they've also said that if the MRD is more than 1% at the end of 4 weeks of induction, then CAR T is suggested rather than going ahead with blina and transplant. And for their standard risk relapse, what is the standard risk relapse? A patient who relapses more than 6 months off treatment and no high risk genetics. So just look at this treatment. It's unbelievable. Just 3 drugs induction for 2 weeks, followed by blina, 1 or 2 cycles, followed by DI, 1 cycle of delayed intensification and maintenance. So a child with late ALL relapse will actually get less treatment than a newly diagnosed ALL if blina is incorporated. So these are the things which are coming up. Let's see how the results are. But these are the guidelines which have been published on the CCLG website. And if the MRD, it's all based, one has to keep on doing the MRDs. If the day 15 MRD is more than 0.5, then it is a bit more intensive protocol, and they have given 4 cycles of blina, but no consolidation, methotrexate, escalating methotrexate with some DIs and maintenance with blina cycles in between. And they like to do this because the word which is used is the T cell exhaustion. They don't want to give blina continuously, and they want to interrupt it with other chemos. So I asked Ravisha, who is in Calgary, what is the current practice in Canada and US? So for newly diagnosed ALL, they are giving blina to all except very few, the so-called standard risk favorable, but with no reduction in chemo backbone and with 2 months less of maintenance. Although he said that he believes that the chemo could be reduced, but then of course there is no evidence. So this is the current practice in the high income countries. And another publication in the CCLG website in 2023, which is again very attractive for LMIC, is that let's say if you get fungus or a bad sepsis, and we just reduce the chemo after that because they just can't tolerate. So any serious toxicity, so they have replaced consolidation and interim maintenance with blina. So that too is very attractive. But of course, the big question is about the blina, the cost. So Neha, again a tough one. Can blina avoid the need for transplant?
Yes, sir. It is a tough one. Transplant, when introduced into the systematic treatment of patients with BLL, was with the thought process that alone chemotherapy is not able to remove all, is not able to control the cancer in a particular subset of patients, and the donor cells are going to give their effect with the graft versus leukemia effect. So till now, most of the guidelines have not changed their indications for transplant in very early or early, wherever they have placed in different protocols, they have different indications of transplant in upfront and in relapse setting. So most of the guidelines have not been changed, given that there are some data coming up with few studies. Like in adult, there is one E1901 study in which if you are MRD negative with the help of blina after consolidation, so they are not doing the transplant. And also I think in this study, this is like COG's ALL1731, which is the new one. I think in that also they are not doing the transplant if after consolidation with blina you are MRD negative.
Right. So
but most of the time it stands true for what it was in the past.
Yeah, thanks, Neha. I mean, we have limited time now. So I could not really get a clear-cut answer for this, but it's just that they believe that if you use blina, so the MRD negativity would be higher and less patients will end up with a transplant. It's not that it's being shown as a drug which can negate your transplant, but it's just that transplant will not be needed because less of them will relapse. I think, thank you so much. We'll end here because the time is short. Thank you all of the panelists for such an excellent preparation. Yeah, thank you so much.
Sir,
Yeah, thanks.
such a lucid and practical presentation where the day-to-day questions are handled seriously. So I would thank Deepak sir and all the experienced panelists for the same.
Answers to the blina could be used after relapse. Or what will depend on the dynamics of the family and their patient. Okay, good. One patient I think we've used for but I think for infants, I think this first, these are this group.
From the lab side, that if you are presenting the lab, those have been approached to MRD company. So that we are getting mark. That we need to be aware of, like the labs that we are sending it. Yes, that separate validation and that. So that is
on that he would like this to be extended to patients with Ph positive ALL and infant, and he has written to the team if it could be extended. These are the two subgroups where it will be really useful, infant and Ph positive ALL.
So I just had a question for everyone. There used to be a concept of sustained remission, ki though time points have Vikas sir, Anshul sir, and everybody who's doing transplant, I wanted to ask that if you've got a patient who you give this 3-drug induction, Dr. Deepak showed something really interesting. Ki 3-drug do, ek blina do, MRD is less than 0.01, transplant kar do. How comfortable are you thinking to give such a short thing? Because initial concept used to be give F1, F2, MRD, even if it is negative, you give R2, R1, R2, R1. Then even when immunotherapy pitched in, even then it was like you give some induction, give immunotherapy, probably 1 or 2 cycles. Just make sure that this remission is sustained before you hammer it with a transplant. So because this data, I think, sir, we don't have long-term results for this data. How comfortable would you be to Aya, and you just transplant?
एक तो पहले कौन बोलेगा? एक भी खोलोगे किसी का भी एक का।
We have financial constraints. But ALL, NGS, MRD, and then
Yeah, so Payal, just to come back to that, what we do for our relapsed ALLs, and I think the time is running out, is in the high risk ALLs, which means they are going to anyways need transplant. We know that upfront. We give them 3-drug induction. We remove the anthracycline. We give them 2 cycles blina, some more chemo, and then take for transplant. So that is what we are doing.
Exactly what we were following, but what I saw was really like seemed very exciting about just giving one, and so just thought can take everyone's views on
I
it.
think for the interest of time, we'll
I can just talk.
make other discussions over the cup of tea or for the lunch. Minimal residual disease or MRD is being hailed as the strongest predictor of relapse. So does that mean that cytogenetics, age, and early relapse no longer matter? For that, we have an upcoming debate, and I would like to request Dr. Pooja Diwan as the chairperson for the upcoming session. Diwan is a director and professor in the Department of Pediatric at UCMS and GTB Delhi, and she's also the chief editor of the Indian Pediatrics of Journal. Ma'am, kindly introduce the faculty for the debate.
So, good morning to all of you after such lively sessions. The last one was particularly really interesting because, as we said, that the first one went a little above me. So, for this session, this is going to be an interesting debate, and we have all evolved from using traditional tools for risk stratification to using MRD for our chemotherapy, guiding us to chemotherapy. So, for this debate, I would like to invite Dr. Satyendra Kateva. He is the director of BMT, head of Pediatric Hematology Oncology at Shalby Sanar International Hospital, Gurugram. He will be speaking for the topic. So, welcome, Dr. Kateva.
Thank you. Good afternoon, everyone. And few of the questions regarding what Payal just asked, we'd like to include in this. I don't think there is a debate about that because MRD is one of the, like leukemia is the story which we want to talk about. MRD in leukemia is the story which actually inspire all of us. And this we are not going to talk about that it is included in our decision making, because we know that this is included in our decision making. The question is how much we can rely on to MRD as a marker for taking decisions in leukemia patients. So that's how the story is. It was like 15, 20 years ago, just less than 5% was like morphological remission, so which means maybe 3-4 cells, cancer cell might be there. We still call it CR. Then the flow cytometric evaluation came up, and then we went up to with 4 to 6 colored, like 1 in 10,000. And then with 8 to 10 colors, we went up to 1 in 100,000. And then PCR was still 1 in 100,000. And then NGS MRD is the really game changer that has gone up to 1 in a million. So that the game has changed very rapidly, and it is changing. So from CR morphological remission, we have now come up to 1 in a million cells we can search for. Now, this is an important cartoon which tells us why MRD is necessary. And see, morphological remission, there is, you cannot see because there was a lot of subjective variance into that, but you could not see blast. But the moment you leave it, they come back. And that's why we say it is there, though it is not there. We can't see it. At that time, it was just morphological remission. And then this flow cytometric and everything came, and you see onto the red one that once you go after 10 minus 4, which is like 1 in 10,000, even after that, if you leave it there, the disease will again start coming up. With NGS, you can ensure up to 10 raised to power minus 6. And after that, I think really that is the deep remission. So if you are deciding your lot of decision based on just flow MRD, that's a question we should ask to ourselves, because the game has gone beyond the flow MRD to the PCR and now the NGS. That's the one question we should all be sure about. Here are the 3 papers, first from Borowitz and then Cantor, and then again there's kind of a review paper from Borowitz from 2008 to 2015. It almost established in B-cell ALL that yes, MRD is the most important marker which should be followed, and that decides the prognosis in the child. And then the meta-analysis came in 2017 by Donald A. Berry, and that clearly tells you that the difference between the patients who were negative MRD or zero MRD, so there is a difference between less than 0.01 and 0. And I focus it again and again. If something is saying less than 0.0% is not 0. And then if you have the PCRs or the NGS, then you can be very sure about that. Okay, the flow cytometric less than 0.01 is not actually 0. And once you go with NGS, that might be there, right? So whether it's the EFS or whether it's the OS, both are better if your patients were into the MRD negative. And this cartoon tells you that it is just that if your MRD at the end of induction was 1%, your curves are the lowermost. Between 1 to 0.1%, they are better, but still they are lower. 0.1 to 0.1, they are still better, and less than 0.01%, they are the best. So it is just note that magical number of 0.01%, as it keeps on increasing, the curves start coming down. So the disease load is the most important thing when it comes to the cure. And when the same thing comes on to the day 8 MRD, you see the game is changing so rapidly. Now day 8 MRD we are talking about, and everything goes up by 7 to 8%. So, and then end of induction as well. Sometimes there is a patient where end of induction MRD was positive, and then you go into the end of consolidation. Still, if you are negative by the end of consolidation and you don't want to change anything, there are a lot of patients, and almost 10 years ago, nobody was changing. The game is still on, and you can do that. So deeper the MRD, lesser the disease burden, and then the better outcome is there. Now, this is the role of pre-transplant, and again, a meta-analysis by Huang. And this clears, look at the diamond and all the studies. If you have high MRD, you are likely to relapse. And this is a well-established, whether it's just chemotherapy and then the remission or pre-transplant MRD, it has got implication. You want to keep it down and down and down and probably the out of the game. Now, again, I would re-emphasize, most of our centers somehow have managed to have flow cytometry in-house. And we do it by flow cytometry. Most of the centers are having 6-color flow cytometric machine. So the maximum you can get is 1 in 10,000. 1 in 10,000 from the NGS is like 1 in a million. There is a lot of gap. And that is what is deciding in the next few slides. So this, this has already been discussed, so will not be. So this is interferent blinatumomab, they added. So if a patient of interferent on interferent 6 protocol had MRD negative, why the outcome was just 49%? Biology of the disease, that's what I was, when I was doing my fellowship, was ingrained in my brain, that it is the biology which is not taking care, we are not taking care of the thing. Okay, I understand, came to 2A, but then the smarter guys are always there to sort out the problems. They introduced blinatumomab after the induction, and the patients were almost 60 to 70% are into the MRD 0.01% or negative. They still introduced blinatumomab, and the gap is significant. So how come the blinatumomab in a patient who is already MRD negative, how come it introduced? Because it brought down the disease. So our limitation is MRD, the way we are doing MRD. Flow cytometric, the baseline. I'm sorry to say, but we have to now move on. Molecular, PCR, yes, that was a good idea. But now the NGS, once you are sure that the MRD is negative by MGS, then you are in the game, and then you can say, now we are following the MRD more correctly. So that's what the blinatumomab did here. So that's what it is evolving. This paper I have taken from the Hematology, Charles Mulligan, and these are the risk factor where they say that these are the patients where it doesn't matter whether you do MRD negative, positive, whatever you do, the things are not going to be okay. And let me tell you, all these patients, which are less than 10%, have a very specific pathophysiology of the leukemia. There is a constant leukemogenesis, continuous proliferation of the cells and cell survival. So this is not it's very, very difficult thing, and we need to be smart enough. So what are these patients, 8 to 10% patients are doing? So let us understand this room as a blast. You throw in a bomb to kill the blast, but the blasts are so smart because of the molecular genetics, they throw the bomb out of the window. So the cells are super smart, and they don't respond to what we are giving because they are smarter than our planning. So what we need to do, we need to block this window. And that's where for these indication 8 to 10%, we need to have the targeted drugs which block these windows where the chemo can and the function. And here are the things, here are the options available. TCF3 HLA, you see there is now venetoclax. It is established in our other studies. MAF2D, yes, penobinostat is there. If you add it, everything, the MRD, the data clearly tells you MRD becomes deeper. AMP21, no, it is, we don't have a magic bullet, but you need to give asparaginase and methotrexate. Don't take it out because these are important things. And then blinatumomab is the answer. So essentially, what I want to say here is MRD is important, but the way we are doing is not okay. It should be PCR or NGS. And now this thing will clear everything up. So if you go by 10 raised to power 4 by the flow cytometric, you see how many graphs are there below? 3. And the green one, light green, will immediately relapse after some time. We call it late relapse. And then once you go by 10 raised to power minus 6, still 2 graphs are there. So the blue one, the first one will never come back. But the other one, the dark green, it will also come as a very late relapse. But we have gone up to 10 raised to minus 6. Now it's the time of quantum computers. They are doing the things, the better generation, the technological. So we need to go beyond 10 raised to power minus 6. And probably in next 3 to 4 years, we will have this available. And then we'll be very sure that, yes, this is the real MRD negativity from where we should be going. So the summary is MRD definitely is the best way to follow it up, but it should be NGS based. In 10% of the patient, just MRD is not a good idea. You probably need to have the additional information to add to your decision making. And we need the better things, the better drugs to make it sure. Even in our standard risk transplant patients, if we follow this MRD 10 raised to power minus 6 or better, our outcomes will be better even for the patients who have relapsed and who are not from these 10%. And with this, I would like to conclude that, better MRD means better things. For better MRD, we have to define. MRD is a very loose term. And that's our life is. You learn something. I always talk with Sandeep, about this thing. You learn something, and then there is some medical advancement. You establish something. Then you unlearn, and then you relearn, and then again unlearn, and then you relearn. That's our story. So please keep reading, keep evaluating yourself. And with this, I would conclude, yes, MRD is a tool we can rely. Maybe 8 to 10%, you need more help and better MRD. Thank you, guys.
So thank you. For the next half of this debate, I would invite Dr. Kirti Hegde. She is Associate Consultant of Pediatric Hemato-Oncology Department at Sri Children's Hospital, Mumbai.
Good morning, everybody. Shall I put up the slide? Somebody have you? Should I do it? Okay, till we set it up, I'd like to thank the organizers for putting me on the stage in front of the best minds of pediatric oncology, and also to put me on the stage to debate with my fellowship examiner. I know how impressive he is, and he can convince us that the earth is flat, but we'll go through some of the papers and try to see how MRD is not the only thing. There will be some things, like Sir said, yes, 10 to 15, but it could have a huge clinical implication. The next 10 minutes, how we will go with this talk is to look at particular scenarios with respect to subtypes, CNS disease, and genetic variations, and how they all play a role when we are evaluating MRD. Where are we currently? Where are we headed? And also, hopefully, we can all tie this together to show that absolutes are always illusional. Reality is more nuanced and somewhere in between. Now, what is the need for prognostic indicators? We know in the Western world, they've all achieved outcome of more than 90%. So the focus has now shifted for early identification of the good players and the bad players. So good players, you want to de-intensify treatment. And for the bad players, you want to intensify or find some particular targets which can then improve their outcome. This is what we traditionally include. So your favorable prognostic factors would be age, would be WBC count, some particular cytogenetic aberrations like your ETV6, RUNX1, or 1221, hyperdiploidy, which are favorable. And on the other end of the spectrum, you have your MLLs, you have your IAM21, hypodiploidy, all these other MLL rearrangements. And of course, the MRD at induction, and I think some protocols also mentioned at the end of consolidation. This is a very busy slide, just explaining the fact that, yes, we are talking about how we are moving towards just MRD-based treatment allocation. However, all the important protocols still utilize all of the risk factors that we just previously saw. Now, you need all of this because there have been some other trials which have been able to de-intensify or intensify treatment, like your Senju Total 15, where even for pH positive IAM20, pH positive ALL or hypodiploidy, it is not CR1 transplant, it is MRD-based guided treatment. Similarly, the BFM group has also shown IAM21, where we thought that they do really poorly and CR1 transplant. They're now moving towards MRD-based treatment allocation. So I'm not here to debate that MRD is not important. Yes, it is important. And the fact that, yes, there is an interplay of MRD with adverse your risk factors. So higher the MRD, you know that these are bad players. You probably have a bad genetic variation or a bad disease. And the converse is true as well. And this is what you see on the graph on the left. Again, published by the UK group, which basically shows. Can you see my cursor? Yeah. So basically, if you have a favorable cytogenetics, the log reduction of MRD is quicker as compared to the unfavorable cytogenetics. So one of the papers that Sir had quoted was one of this BFM group. This was the BFM 2000 study, which basically came out and said that MRD and MRD solely is what will determine your prognosis, whether it is in terms of your EFS, OS, or even relapse-free survival. So about 50% of the patients on this study at standard risk by BFM 95 criteria had a slower MRD clearance, and they did poorly. And conversely, if they cleared the MRD, even if they were medium risk, they had a better overall survival and event-free survival. Now, the high risk that was predetermined by a PPR, a poor prednisolone response, or a bulky disease, if they had an earlier clearance of MRD, they did well. But the caveat here is that even though they had an earlier MRD clearance, the same PPR group, they actually received high risk treatment. So that could have interplayed why they did so well. And also, this is the MRD was not done by flow, what we routinely use. Like we heard, they were doing PCR MRDs, which goes up to the depth of 1:10 raised to minus about 1 million. So now coming to, is subtype important? This was a paper published by the St. Jude group, again, using MRD at day 19 at the end of induction. So earlier clearance of MRD basically meant that this group is going to do well. But in particular subgroups like your ETV6 RUNX1 or hyperdiploidy or double trisomies, they did well irrespective of the clearance of the MRD as compared to the ones who had unfavorable cytogenetics. And on the other end of the spectrum was your high-risk group or your TALLs. Even if they were MRD negative, had an earlier clearance of MRD, they did poorly. And the same was true for the end of remission MRD, that if they were MRD positive at the end of the remission, so 46, they did poorly. And even if this was negative for the high-risk group, they did poorly. So this is the table that shows us the EFS, OS, and the relapse-free. Now, as you can see in the TALL and the NCI high-risk group, it did not matter what their MRD clearance was. They did poorly. Now, the other thing we include is your day 1 or day 8, depending on what protocol you're following, the CSF status. Now, this was again looked at by the COG group. So whether CNS1, CNS2, and CNS3, was there any difference in survival? It was quite stark that the CNS1, irrespective of their MRD, they did better than if they had CNS2 or CNS3 disease. So this also shows basically, so your B is your both combined relapses, and your C chart is the one that is showing isolated bone marrow, isolated CNS relapses. And this also was higher in children who had CNS2 or CNS3 disease. Now, this was again showed by the previous presenter that COG is one of the first groups that looked at the interplay of MRD with your other cytogenetics or other prognostic factors. This was out in Capital that MRD is important and is one of the strong prognostic factors. And we've seen those charts, so I'm not going to go back to it. But how did it sort of change the outcome in favorable and unfavorable group? So in the TEL-AML or the double trisomies of 4 and 10, if they had MRD positive, they did significantly better than the unfavorable group. Again, something that the St. Jude group had already shown. However, what was important here was what was the NCI risk group status. So if they were MRD negative, but NCI high risk, they were going to do slightly poorly. So when they did the multivariate analysis, other than the MRD, the other thing that came out important was what was the NCI risk status. This study also showed a particular group that had a very low risk of relapse, and their outcome was as high as 97%. And this was the group that cleared the MRD quickly, but also had TEL-AML, had all the other favorable risk factors. Again, this was another study that was published after the COG study by the UK group that basically looked at what happens with MRD, and if you put the genetic factors in to this mix as well. Now, what you see in this graph is the ETV6 and the hyperdiploides. Even if their MRD was in the intermediate risk, that was between 0.01 to 0.1%, they did better as compared to the high-risk cytogenetics or even the TALL. Now, why is all of this important? Because we've all heard in the LMICs especially, we are dealing with a lot of treatment-related mortalities. We are seeing a lot of induction deaths. Now, it would be really helpful if you're able to actually pick out a group that will do well with reduced treatment intensity. And this is what the Brazilians sort of did. They took this very, very low-risk group that we previously saw and decreased the intensity. And what they saw was the EFS and the relapse-free survival was actually equivalent. Now, where are we heading? What is the world doing out there? Are they just using MRD, whether it is PCR-based, whether it is high-throughput sequencing? No, you're actually trying to amalgamate, and you're also using MRD as a continuous variable, not just at one single time point, to predict the risk of relapse. So this was the UCAL group. They looked at their cohort. So what they've done here is in 2 phases. They did their validation cohort and their so they've done the validation cohort and the discovery cohort, UCAL 2003, and they looked at your NOFOs and all of that to actually see if this prognostic indicator works. And what you see here is the statistical formula that they used. And over here, they tried to put MRD as a continuous variable along with the WBC count. And other than that, your cytogenetics, whether it was a favorable risk or an unfavorable risk, and came out with a score which they called the PIUCAL score, that is the prognostic index. And what they saw was they could group all of these patients into 4 groups, whether it was a low risk, intermediate risk, or low risk, standard risk, or intermediate risk, or a high risk group. And in both the cohorts, that is their validation cohort and the discovery cohort, both the EFS and the OS was actually similar, and they could actually predict relapses more in the high risk group. So where you would have used your traditional risk factors or MRD, what they would do, what they saw is that the risk of relapse would be anywhere between 20 to 60% if they use the PIUCAL. So it was definitely more sensitive in predicting relapse.
Dr. Kriti, can we wind up, please?
Oh, it's already 10 minutes. Okay, so COG did the same and they called it the PICOG, but they also included CNS status and D8 MRDs. Now, we also looked that there are other ways of looking at MRD and not just flow. PCR is one such method, but it is costly, it is difficult to replicate. So high throughput sequencing was one of the ways of doing this. Now zooming, this is talking about what is happening in the world, but we have to zoom in and see what we can do. So this was a huge study that was published, very momentous, the ICICLE study. And here we were seeing that even things like MRD would vary between institutes. There is a lot of subject variation. So I think we have to come together before we say MRD is it. Until then, we have to put everything, add 1 + 1 to make it 2. So I think I've summarized that, yes, MRD is important, but not alone. You have the CNS status, you have the high-risk subtype that you all have to consider. So everything is relative, and only that is absolute, and so is MRD. MRD is not exception. Thank you.
Okay, thank you, Dr. Kriti and Dr. Satyendra, for this very important discussion. I think it was more difficult for Dr. Kriti to convince all of us. The easier job was given to Dr. Satyendra. So, but at the same time, I feel while I think it is not debatable that MRD is important for various reasons, but I also agree with Dr. Kriti's viewpoint because there are certain concerns with MRD besides what you said about sample, timing, technique, etc. I think MRD would also reflect more of a medullary, but with extramedullary disease, I think it may not be very reflective, particularly when we are faced with situations of relapse. Then the other thing would also be that even if there are certain early clearers, for example, you have hyperdiploidy, they would clear early, but then at the same time, maybe the outcomes would be poor. Also, I think you also mentioned that with certain cytogenetic aberrations like MLL, etc., those would, even if they are rearranged ones, even if the MRD is negative, they are likely to relapse, pH positive. So I think we don't have clear-cut answer. So I think and also the other factors indirectly help us. MRD, of course, helps you in real time. So I think both views are correct. And I think I don't think there's a clear-cut answer as to which is,
I'm very
which
proud of
outweighs.
Preeti, ma'am.
Yeah.
Very, very proud of her.
Yeah. So
I just wanted to make sure there is no debate about that because difficult patient, you
Absolutely.
need to go beyond. I just wanted to emphasize now flow days are over. We need
Absolutely.
to redefine MRD and then we will be good again. Because whatever these indications which are difficult, 50% are getting better, not getting better, because we are treating them pre-transplant at a very higher MRD. Most of centers are doing flow cytometry based, which is just 0.01, not even NGS based. Once we start doing that, transplant outcome will get better. But still, I'm very proud of Kriti. Thanks.
Yeah, thank you. Thank you very much.
No.
Thank you so much for such an interesting debate. The CAR T cells. Thank you so much. Thank you so much, Chairperson and expert. The CAR T cells are perhaps the boldest leap in the modern leukemia care, giving us hope when nothing else matters. But the promise comes with a cost. But the promise comes with limits, the cost, toxicity, and durability. And to take us through the lessons learned and the leap ahead, we have the next talk on the CAR T Chronicles in Pediatric BLL. And for chairing this session, I'm privileged to call upon stage Dr. Dinesh Bhurani. Sir is the Chief of Hematology, Oncology, and BMT unit at Rajiv Gandhi Cancer Hospital. And he is also India's first DM in hematology from CMC Vellore. To date, he has performed over 1,500 stem cell transplants, including the first haplo-identical BMT in North India, and has led major clinical trials across blood cancers. And also we have Dr. Sudhir Raval. Dr. Sudhir Raval, sir. Sir is the medical director and also the chief of genito-uro-oncology at Rajiv Gandhi Hospital. He is pioneer in the field of robotic surgery. Okay. And Dr. Arun Daneva. Sir is senior pediatric oncologist at Fortis Gurgaon. Sir, please introduce the speaker for the talk.
With this, thanks for inviting us. I'll introduce Dr. Akansha Chitra. She's going to talk on CAR T Chronicles in Pediatric ALL, lessons, limits, and leap ahead. So I think she has enough experience of using the CAR T. Her biggest introduction is she has worked with me. I had a chance to work with her. So pediatric hematologist and oncologist, 11 years of experience. She has worked in, she's RGCI's first PHO fellow also. So marking a significant milestone in her. Presently, she is associate professor. She doesn't see now towards me. She goes straight.
Thank you for the kind introduction, sir. So, right. So, I've got my phone so that I don't exceed the time. I know we are running a little late. And when Sandeep called me and told me he's giving me the CAR T talk, I was like, is Dr. Gaurav not in town? I'm not sure. But I will try to do justice. And I really like the topic, the way it has been phrased, lessons, limits, and the...
It's not Gaurav. We want our candidate, our student to be given the result. So you agree or not?
Right. So lessons, limits, and the leap ahead. And I have tried to kind of put my whole talk in these three subtopics. So I will start with the first one, which is lessons learned. And when I at least want to learn anything, I want to go through the entire evolution of what has happened with this particular product. It was somewhere in 2011, and we'll just go through quickly to the papers, the landmark papers, which taught us so much about this amazing therapy, which has now, come and is available to us as well. So this is where it all began. This was actually as old as 1993. This is a landmark paper by Zeglik Eshar. I hope I'm pronouncing this correctly. And this is where they first brought about that they could combine the variable region of an antibody with the constant region of a T cell receptor chain, which would result in this chimeric gene, which was able to endow the T lymphocytes with antibody type specificity, and it could potentially allow adoptive immunotherapy against tumors and against type of tumors where it was not previously possible. So this was the first one of the first papers for the CAR T construct, and this is how it began in 1993. So right now, we'll just focus initially on the CD19 CAR T trials. So chimeric antigen receptor T combines, like I said, an antigen recognition domain, which is typically a variable fragment of a monoclonal antibody. It combines it with an intracellular activation signal domain of a T cell. And in BALL, in pediatric BALL, CD19 was, is the most uniformly expressed markers, it is expressed in all the B cells. And hence that was the target which was initially thought to be of most importance, and the CAR T could be on this particular antibody. So it is the most widely used target for CAR T adoptive therapy. And as we go through the slides, we'll see that there are several generations of CAR designs or constructs which have come. They have added co-stimulatory domains. When you add one co-stimulatory domain, it is a second generation CAR. When you add two co-stimulatory domain, it's a third generation CAR. And the idea of adding these co-stimulatory domains to this basic construct is that you want more persistence and longer persistence of the CAR T in the body, so that you're able to, your disease remains in remission for a longer time, right? So there are various CAR T constructs that have come about right from the time initially in 2011, which was the first paper which came about. And you have now what are these conventional CARs, which I talked about, with the first generation, the second generation, the third, which has two co-stimulatory domains. And you have something which is called as the CAT CAR, where there the CAR Ts actually have a low affinity to CD19. And this is, some interesting work which has come out from United Kingdom. You have something which is called as armored CARs. So right now, there's a lot of literature available for many kinds of CARs, but this is how the designs have evolved over the years. So this was the first paper which came up in 2011. Actually, CAR-T was first used initially in CLL, or chronic lymphoid leukemia. And then the same construct was used for the first time in two pediatric BALL patients, where when initially, this was also in 2013, where when they used this construct, they found that the levels in the blood in these two patients were found to be 1,000 times as high as the initial engraftment level. That means not only was this T receptor persisting in the body, it was also expanding. They also found that the CAR-T was seen in the CNS for as long as almost 6 months in these patients. This was the first time when in these two patients, they found that both developed cytokine release syndrome and B-cell aplasia was seen in both. One patient actually had complete remission, and the second relapsed after around 11 months of treatment. So as the literature came about, we know now that the whole process of CAR-T actually involves 3 to 4 steps. You have to first start with the T cell collection. That is, you isolate the peripheral T cells from the patient via apheresis. We're talking about the autologous CAR-T right now. Then you transfect the T cells with a lentivirus, which contains gene for the CAR directed against the tumor target antigen. The binding of the virus happens to the T cell membrane here. There's fusion of the virus, integration, and then transcription and protein expression of this particular CAR gene. And then eventually this gets inserted in the CAR cell membrane. The patient is then given lymphodepleting conditioning. So initially it was tried with both, with and without lymphodepleting conditioning. And then once the CAR-T is infused after the lymphodepletion conditioning, the patient is monitored for various things like B-cell aplasia, disease, etc. This was the next important trial when I was going through the entire evolution of CAR-T, which was in 2014, where 30 children and adults, out of this almost I think 25 were children and 4 or 5 were adults, received this CAR, which was initially called as the CTL019, which later Novartis, when they partnered with the Pennsylvania University, went on to what we now know as Kymriah. What was seen here was that 90% of the patients, that is 27 of these 30, achieved CR at 1 month. And out of these patients who achieved CR, 15 were post-transplant relapses and 2 were patients who were Blina refractory. So this was a really relapsed refractory pediatric BLL subset that we were looking at. Right? Out of these 27 patients who went into CR, 19 remained in remission at a median follow-up of 7 months, and 15 went on to receive no further ALL targeted therapy. The 6-month EFS was 67%, the OS was 78%, the relapse-free B-cell aplasia percentage was 73%. So this was one of the largest data sets which came, which could actually show us that at 6 months, almost 50 to 60% of the patients were doing quite well. Severe CRS was seen in 27% of the patients, and what they found was that the ones who had higher tumor burden had a higher CRS. So very nicely, this initial 30 patient data set showed us that in patients where there was the loss, the B-cell aplasia was lost, they went on to relapse. with CD19 positive relapses. The other thing, it very clearly showed us that those patients who had severe CRS had very high IL-6 levels. So we now had an agent where we could target the IL-6. Earlier, steroids were used for cytokine release, but then this paper could show us that because the IL-6 was very high, there was an option of using tocilizumab. And also that very nicely, it showed that those who had a high burden disease had severe CRS, right? So these were all the things we were slowly and steadily learning as and when the papers came out. Now, this trial, I think all of us know about. This is the Eliana trial. This is when the Pennsylvania University had partnered with Novartis. So this was a phase 2 trial, 25 centers of the same CAR-T construct in pediatric and young adult patients who had CD19 positive, relapsed or refractory BALL. So 75 patients were taken. This cohort had 61 patients who were post-transplant relapses. They had an overall response rate of 81% at 3 months and EFS at 6 months of 73%. At 1 year, the EFS was 50%. And out of these patients, 13% underwent transplant after the CAR-T, right? So this was the data on the basis of which the FDA gave approval to CAR-T in 2000, I think 17 in US and I think 2018 in Europe. So this was how the development of the Kymria or the Novartis product of CD19 happened, which through all the, so initially it started from an academic institute and then the pharma industry partnered with them and took it to a much bigger platform. And now we have many types of CARs targeting different surface markers and for many other indications as well. So what are the very clear-cut indications for CAR-T? That is second or higher relapse or refractory disease of CD19 BALL in patients less than 25 years. Right now I'm talking about only the pediatric indications. And any relapse post-transplant, a patient who is relapsed post-transplant would be eligible to receive CAR-T. Right? And then this was followed, the Eliana trial was then followed up by 2 major publications. One was a real world data from CIBMTR where they took the experience from 130 centers who used this particular CAR-T construct. There were 255 patients of pediatric relapsed refractory ALL. And as you can see, unlike the initial trial, which had 60% patients who were post-transplant relapses, this cohort actually had only 28%. So this was a less advanced disease cohort, which was published. 15% patients in this cohort had received Blina prior to CAR-T, and 10% had received INO. Blina receival was actually an exclusion criteria in the Eliana trial. So again, this is some real world data coming up because now Blina, like we have heard during the day, is now coming in everything. We're talking about Blina even in standard risk ALL upfront, right? And here the real world data kind of reflected what the trial was also showing us, that the overall response rate was 86%, comparable to the initial trial. And in this cohort, about 15 to 16% underwent transplant after the CAR-T. What was interesting, and which is there in the supplementary also, is that 46% of patients who received Blina and 62% of the patients who received INO, respectively, experienced treatment failure, relapse, and or died of ALL treatment during a median of 10.9 months follow-up after CAR-T, right? So probably if you've given Blina and or INO to patients and then take them for CAR-T, not transplant, they may not do as well as patients who are Blina and INO naive, right? And we have now literature and data which says that INO does impact the T cell expansion, and probably that is the reason why this subset of patients may not do as well with CAR-T as the ones who are Blina or INO naive. Right? So this was the 3-year update from the same Eliana trial, and they kind of emphasized the fact that their initial trial, the 3-year update also showed that the estimated relapse-free survival at 3 years was about 52%, right? And so this kind of established that almost 50% of patients in this very high-risk subgroup, which means the relapsed refractory post-transplant relapse group, were doing quite well with CAR-T. So about 50% would not have any relapses post-CAR-T. Now, of course, this is what the Novartis product is, but there are many others which have come in. This was the Carpal trial, which was the low affinity CD19 CAR-T, which came out from the UK group. Then we have trials from the NCI where they have used this different co-stimulatory signal, which had a shorter persistence. So we have now many CD19 CAR-T products which have come about in the market. The other thing which kind of CAR-T taught us, so till now we learned that yes, about 50% would do very well even in this very, very poor subset of patients. We learned that if you take patients with high tumor burden, they are likely to have much more significant toxicities. The CRS is going to be much higher. Tocilizumab is one of the best drugs that we learned during the trials which came about. But we also came to slowly know that it's not a drug which is completely very easy to handle. People say that transplant is difficult and post-transplant is definitely difficult to manage, but it is not like CAR-T is a walk through or a breeze walk, right? So we now learn that CRS could be really difficult, ICANS, IEC, HS. These patients can land up in cytopenias. B-cell aplasia can lead to a lot of difficulties with repeated infections and sepsis, AKI. So there is a lot more to management of CAR-T patients than just the initial lymphodepletion and getting the construct right. So the toxicities actually can be divided into the acute, emerging, and late effects. The acute, I think most of us now understand about the CRS, etc. The emerging delayed toxicities include the infections and immune reconstitution, which I think are very, very important as we are seeing more and more patients getting CAR-T. And there is a whole subset of late effect consideration, which now we will now have to focus on because it's almost a decade since the initial CAR-T came about. So we have to look at how these patients are doing in terms of organ function, whether it has impacted their fertility, growth, and there is a lot of work now which is required and is ongoing in this area as well. So very quickly, what else did we learn through these trials, which, this very nice cartoon by Dr. Nirali Shah and group. So it taught us if you want your CAR-T to be more effective or if you want it to have better results, so apart from the design, like I said, what else should you be doing or looking at when you are treating patients with CAR-T? So we were able to identify certain pre-infusion and post-infusion risk factors. In the pre-infusion risk factors, patients who had more than equal to 5 blasts pre-infusion were at a higher risk of relapse. Blina non-response, again, higher risk of relapse. Potential risk factors could be those who were MLL rearranged, who had some amount of CD19 DIM expression, that means there was some CD19 clone there, and those who had non-CNS extramedullary disease, right? So these are the high risk where you need to watch out for because these patients may require transplant, right? So what about post-infusion risk factors? And what is very, very important is post-CAR monitoring. And they recommend NGS MRD, and we were talking about MRD and how NGS MRD is should now be the way to go forward. So very strict MRD monitoring, RQ-PCR monitoring, and very importantly, which I showed earlier, your persistence of B-cell aplasia, right? So what are the patients who receive CAR-T who are very high risk for relapse? Those who have day 28 MRD positivity at 3 months, and if there's a loss of B-cell aplasia, which is prior to 6 months after infusion of the CAR-T. So these are the patients where you should quickly work them up and consolidate with stem cell transplant. There is some literature on CAR-T cell reinfusions, but it's not really standard of care, neither has it been standardized. And then other experimental strategies, etc. So it is important to select your patients well. Do not take patients with high tumor burden. They will land up with more toxicities, whether it is immediate or even delayed. And of course, the risk that they will relapse post-CAR-T is going to be very, very high. So if I just have to summarize the lessons learned, is how the evolution of the CD19 CAR-T constructs. I think it's beautiful, all these constructs, the diagrams. I think, I don't think transplant papers look so beautiful like the CAR-T papers do. The importance of tumor burden prior to CAR-T, the importance of monitoring B-cell aplasia. We need to learn how to manage the toxicities better. We need to be very fast. If anyone has dealt with a bad CRS, you know that you have to act really fast to get it under control. And also, be aware of the risk factors pre and post infusion so that you're able to select the patients well for your CAR-T. To the second part of my talk, which was limitations. So does this therapy have limitations? Of course, any treatment has, some limitations which are going to be there. So the first limitation would probably be, it's a challenge sometimes in collecting the T cell. So the first step of the CAR-T, which was the pheresis of the autologous T cell, that itself can be challenging in certain patients, especially in very young patients where performing apheresis may be an issue. These patients are relapsed, refractory, undergone a lot of treatment, so they are lymphopenic, right? You need a minimum absolute lymphocyte count for collection of the T cells. Their lymphocyte fitness or functionality is not so good, right? So that is also very, very important in the eventual how your CAR-T is going to perform. They are, like I said, relapsed refractory, so a lot of them have a very rapid disease progression. So how do you manage the bridge therapy till you give the CAR-T? How do you get the tumor burden down to less than 5%? That's a challenge which is constantly there. And sometimes your CAR-T is also, your apheresis is contaminated with blasts. So how do you address it? Not very sure, but yeah, I will talk about later, in short, about allogenic CAR-Ts. Now there is data which is coming on allogenic CAR-Ts. That could possibly be one way forward because you are taking it from a healthy donor who has a normal lymphocyte count. The T cell functionality is much better. You can collect the donor in time, and the microenvironment of their cells is much more healthy than the patients themselves. So when I talk about the second limitation of CAR-T, of course, it is relapse.
Dr.
We have
Prangshu, could you just wind up,
I'm
please?
really
Yeah.
running. Okay.
Yeah.
So very quickly, about even 40 to 44% of the patients are still going to relapse post CAR-T. And we know that they have both CD19 and CD19 positive and negative relapses. So what are the risk factors for a high risk for CD19 relapse? Is those who have a high risk disease burden can escape. So you can get more CD19 relapses. And maybe prior blina exposure is one of the factors. High risk for CD19 positive relapse is loss of B-cell aplasia. Those are the patients who have a CD19 positive relapse. And this was really nicely kind of shown in these graphs by this paper, which was published in 2021. Right. What are the other limitations? We need to probably more work and more data on in CAR-T in these unique populations. CNS relapses initially were actually not included in most of the trials when the CAR-T trial started. Now we do CAR-T for patients who have had a CNS relapse but have cleared it. What about role in these difficult subgroups, which is the MLL rearranged, TP53, hypodiploid, the TCF3, HLH, infant ALLs, Down syndrome? These are the unique populations where we probably need to think of having CAR-T somewhere in their algorithm. What is the other very important limitation, which I feel is the economic impact, right? And this was this nice paper which showed the dark blue is where the maximum CAR-T trials are being done. So you can see that US and China contribute to 78% of the clinical trials in CAR-T at this point, right? And this is a linear curve which correlates between the number of clinical trials and the GDP of the country as compared in relation to CAR-T only I'm talking about right now. So of course, access to CAR-T, the economic impact is very important, and that is one of its huge, huge limitations. We were talking about blina earlier, CAR-T is also an expensive therapy. So very quickly, the leap ahead, I will quickly go through this because I'm also not sure what is the leap ahead. But yes, we are getting newer and newer constructs of CAR-T. Now you have 4th generation, 5th generation CAR-Ts which are coming about. You have CAR-Ts targeting other antigens. So they tried targeting CD22. There was some data, but this CAR-T does not persist for too long. So now what have they tried to do? This was a really nice publication which has come about where they are trying to give bispecific CAR-Ts. both CD19 and CD22, and they're trying to see what is the best way to give the CAR Ts. Do you co-infuse? Do you give one after the other? And this seems to be showing some really good results. Allogenic CAR T, like I showed earlier, to overcome the limitations of autologous CAR, which could be donor-derived off the shelves, and the CAR NK cells could be used for allogenic CAR. And then eventually, the leap ahead would be how do you manage the post-CAR T relapses? So that 40% which is going to relapse, so you can use your targeted agents if you have anything targeted to give. You can reinfuse, like I said, and many other things can be done, right? Right. So very quickly, I think this data set, I think most of you have seen. So this is the TMC work in CAR T. This was our publication for the phase 1 trial where we had 12 patients. And where we were doing a dose finding study, and this is what we found that the 3 to 5 million dose is what we have found the best. Now we have started our phase 2 trial, which is now stopped accruing. This was in our adult counterpart, more than 15 years of age, where the CAR T is now commercially approved and available. So if I have to say, the leap ahead is that CAR T cell therapy has become a really valued treatment in pediatric patients with relapsed and refractory ALL. So far, CD19 seems to be the best target antigen for CAR T cell therapy. There is a lot of work going on in identifying more suitable antigens to get novel CARs. The potency of the CARs and the safety needs to be improved. And what is very important is that strategies to reduce manufacturing cost, treatment cost, the secondary costs, giving immunoglobulin replacements for the longest time, have to be carefully addressed. And with that, I end my talk.
Okay, thank you very much, Dr. Akanksha. This, projecting the basics to the entire review of literature along with the future directions. I think there are a lot of residents and fellows here. Would you have some questions or some questions from the audience if we are?
Persistence. We often know that the B cell aplasia is taken as a surrogate marker of CAR T persistence, but Tata has got standardized the RT-PCR also for that.
Right.
So are you seeing a concordance between the CAR T cell persistence on RT-PCR vis-a-vis B cell aplasia? Is there a data?
No, there is no, the concordance is not exactly directly proportional. What we have actually seen that it is, if you see the CAR T, it is persisting for more than 6 months also. But having said that, the B cell aplasia actually is, I think, a much better marker than actually measuring the CAR T. And that is what we have seen in our trial, at least. Yeah.
Just one more question, Akanksha. Suppose we have a relapsed BLL patient. We give salvage chemo, MRD is negative. You have option of both matched sibling donor transplant versus CAR T. What will be your choice?
Yeah, I think at this
You have-
point.
you have availability of all the options.
Yes. So at this point, I would still say matched sibling donor transplant rather than CAR T. I think we still have data which is coming up with the CAR T that we are using, and we need some longer data for us to actually say that, it's going to replace transplant in the setting that you are talking about.
Akanksha, one or two small questions, like how long does the surveillance continue? At what frequency would you keep on monitoring response?
Yeah, so for the trial, ma'am, we were doing marrow MRDs at day 28, day 60, then day 90. And then after that, we do it 3 monthly till 1 year. So after 1 year, we are not doing any routine marrows for these patients. Till 1 year, we are following them up every monthly. We do immunoglobulin levels and, we check for the B cell aplasia. Yeah, so that's what we are doing.
Any comments for the chairperson, from the chairpersons? Any comment? I would also request Dr. Sudhir Rawal sir to give the comments.
Somebody has to pay out of pocket. What is the cost to the patient? Is insurance covering? Is anything available on compassionate grounds or research based?
So to the patient at Tata, it is coming out to be about 35 to 37 lakhs. A lot of NGOs are supporting it. So our biggest supporter in the NGOs, even for transplant, is Lady Tata Trust. they are now routinely giving, sanctions for CAR T. So the NGOs are definitely supporting it. The insurances are not very homogeneously kind of accepting it, but we've had patients where the insurance has also accepted it.
It's only for adult patients, not for.
So this is 15 years and above. But we have done a CAR-T and we are planning 1 or 2 more in subsets of less than 15 because we still don't have the DCGI approval. But if your ethics committee approves it, you can go ahead. So we've done one less than 15 commercial CAR-T also.
So at our place also, we are running a trial with Merrill for CAR T. We've done 10 patient adult and now we are phase 2 for pediatric. And we're also trying to set up our own GMP lab so that we can manufacture our own CAR T. And for this, I will invite our medical director, Dr. Sudhir Rawal, for his comments because he is keenly interested in getting CAR T in a big way at our center.
Thank you. Actually, I probably will speak when in my address, but then Dr. Gauri is helping me in establishing CAR-T here so that we can manufacture. And then we have worked with seeing the scene in the country because we have seen in Vellore, Dr. Maman Chandi had been my teacher also, like Dinesh Bhurani. And I talked to him, I took advice from him, he helped me, and then we had TMC example in front of us. So we are working on it, and I can elaborate when I give my talk, but definitely this is the very exciting thing, that CAR-T, which is, I think in the beginning of my career, when I finished my MCS from Vellore, I came to this place and the 2 news came, one was cloning, otherwise gene therapy. And looking at that, I went to US and in a molecular oncology lab, and then realized that probably surgery is better for me. So I came back, but still my interest is always there. When the CAR-T came, so I said, let us start this thing. I hope we can do that. Thank you.
Thank you, everyone. We now move on to the formal inauguration of this conference. And for that, may I please request Mr. D.S. Negi, sir, CEO of RGCI-RC, to please come up on the stage and say a few words.
Dr. Rawal, our medical director, Dr. Gauri, and the distinguished guests who have assembled here. As I always say, it's all Greek for me. Nevertheless, I think it's a very exciting moment for everybody, the researchers, the doctors, and especially the patients who are really in anticipation, waiting for something drastic to happen to cure the disease. As cancer, as all of you know, is one of the most traumatic, it gives a most traumatic experience to the patient. So everybody is very hopeful because I find that I think the doctors experience almost every day. Somebody has declared that, somebody is a stage 4 and there's no further treatment. All the line of treatments have exhausted. But still the hoping hope कि डॉक्टर साहब कुछ और हो सकता है कि नहीं. So, that anticipation. So I think these are very important, the new CAR T cell. I think we have really entered into a very exciting phase in cancer treatment. So as Dr. Rawal mentioned, we have also started Rajiv Gandhi. We never lack in research. We have done a lot of research work, especially clinical research. But I think this field, we have taken a really very good step as to how we can also produce the CAR T cell here in collaboration with others. So that experiment is going on. I'm sure in the next 1 year or so, we should be able to deliver something exciting to our patients who come here in large numbers. So with these words, once again, thank you very much for coming here. And I think the sharing of this information from Tata, very exciting, the data. I think it will go a long way in really meeting the needs of the cancer patients. So thank you very much, and God bless. Thank you.
May I now request Dr. Sudhir Rawal, the Medical Director of RGCI, to please say a few words.
CEO, Mr. D.S. Negi, our Medical Director, South Delhi Center, Niti Bagh, Dr. Gauri, Shalini, Payal, and all delegates. Pediatric is a different, is like alien for me. I never had my practice in pediatric surgery during my MS, and that lagged me so badly in my career that whenever kids come for operation to me, I'll be very nervous. And I used to involve Dr. Gauri in post-op because many time we do not have a pediatric surgeon like Dr. Shalini is here, because this post has been somehow we did not get some permanent pediatric surgeon. Whenever permanent pediatric surgeon is not there, the case they come to me for neuroblastoma and Wilms tumor. And managing fluid in them, I'm really not very confident. So I always involve Dr. Gauri in post-op. But then it's very exciting branch that these kids, they recover like anything. The sick kids, they recover within few days. Like they are either on this way or that way. They fall sick very soon and they recover very soon. And the event which Dr. Gauri has given the name is Advances in Pediatric Oncology. And I'm sure that you all will learn a lot from this event. And the talks which was going on by Dr. Akanksha, who was our first fellow also. Things have gone from chemotherapy to target therapy to immunotherapy to ADC and now CAR T. And after CAR T, I think there's miRNA CAR T and maybe vaccine, which Russia is jumping on. We don't know what is happening in that field, but definitely field of oncology or field of medical always is changing. Like in surgery also, we started from open surgery to lap, robotic, single port, and then maybe in future there's different type of robot will be there. And it is always that this is how the doctors they have to keep on learning. They can't lag in their career. And even if you are 60, 70, you can learn these things and you can do good for your patient. And these events are very important. I congratulate Dr. Gauri and her team to organize this event. This is a very brief and event and very focused event. And I can see the delegates who have come. They are definitely are for this. They are dedicated to this field of oncology. With that, I thank you all for coming here, joining us, and sharing your experiences and giving the talks. And I hope that in future also you will be doing these things and interacting with each other. Whenever you interact with each other, you do learn, and many times you get idea of doing research or maybe you share with your team, then you can come up with something novel idea. So these things are important, and this is how the things are. And I congratulate Gauri again, and thank you all for coming here.
And now may I request Dr. Gauri Kapoor to please say a few words.
So good afternoon, everyone, and welcome one and all to this conference on advances in pediatric oncology. It's a real privilege to welcome all of you to this session. And on behalf of Rajiv Gandhi Cancer Institute and the Department of Pediatric Hematology Oncology, I warmly welcome all of you to this event. As you know, we've been at, the sessions have started at 10:30, and right after the inauguration, we will be breaking for lunch. So as you know, in pediatric oncology, it's very close to our hearts. It's an area of immense importance, but it is also a very complex field. We have little children where we want to get excellent cure rates with a good quality of life. And as you know, cancer care for children has really dramatically changed over the past decade. Improvements not only in molecular diagnostics, but also new evolving understanding of biology of disease, getting immunotherapies, targeted drugs, ways of reducing toxicity. All this is happening along with the remarkable strides in survival, even in India, even in other LMICs. And so this session today is basically to keep all of us in the forefront of these advances. And we have in the last session, in the coming two sessions, we'll be diving down into these advances, not only in leukemias, but also for brain tumors and pediatric solid tumors. So thank you, our experts, for sharing your experiences. I hope there will be more interactions in the subsequent two sessions, and that our students, our PGs, they will go away learning many things. So don't lose this opportunity to interact and opportunity to learn, to get to know each other. And before I close and welcome you for the lamp lighting, I would also like to thank my team, Dr. Sandeep, Dr. Payal, Dr. Shalini, and all my other support staff, our nurses, our Ayushi, Khushi, Pooja, Nitin, Shikha, all of you, our nursing team. Thank you very much for all your support, because without you, we would not be able to make this event successful. So thank you very much. I hope you enjoy the program.
So as we move forward, I would now like to invite Sukriti and Moni to please come up on the stage for the prayer recitation. Sukriti and Moni are the pediatric oncology nurses from our department. And I would also like to request CEO sir, MD sir, and Dr. Gauri Kapoor to please come up for the lamp lighting ceremony. Also, Dr. Sandeep, Dr. Shalini, and Dr. Payal to please join in.
वक्रतुण्ड महाकाय
Dr. Rachna, Dr. Girish,
कोटि
Dr. Deepak.
समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
डॉक्टर रमनदीप कहीं छिपे हैं क्या एज यूजुअल कहीं? डॉक्टर रमनदीप डॉक्टर रमनदीप
हमारा चेहरा यहाँ पे नहीं पड़ता है।
Yeah. Thank you, Sukriti and Moni, for the very nice prayer recitation. There's a small video that we would like to play. The Department of Pediatric Hematology and Oncology at RGCIRC is a leading center for comprehensive cancer care in children and adolescents. Established in 1998 as India's first privately dedicated pediatric oncology unit, it has since become a national benchmark for pediatric cancer treatment. The department offers integrated treatment options including chemotherapy, surgery, and radiotherapy all under one roof, ensuring timely and coordinated care for young patients. The department is led by Dr. Gauri Kapoor, Director of Pediatric Hematology and Oncology, Dr. Sandeep Jain, Senior Consultant, and Dr. Payal Malhotra, Consultant, both of whom bring extensive experience in pediatric cancer care. Dr. Shalini Mishra, a dedicated pediatric surgeon specializing in the surgical management of pediatric solid tumors and complex oncology cases in children. We have a dedicated nursing team proficient in pediatric oncology that supports the department, ensuring high quality, compassionate care tailored to the unique needs of children. The department emphasizes treating the whole child, not just the disease. We have a dedicated psychologist and a child life specialist to provide psychosocial support through counseling services and educational activities. An exclusive playroom to maintain a sense of normalcy and joy during the treatment. A prayer and a meditation room for parents and family members to provide a quiet space for spiritual reflection. Physiotherapy and rehabilitation services form an integral part of holistic cancer care, particularly in the Pediatric Hematology Oncology department. The physiotherapy team conducts weekly physical therapy sessions to enhance physical function, minimize treatment-related complications, and improve the overall quality of life of young patients during and after cancer treatment. Recognizing the challenges faced by families traveling for treatment, the Department of Pediatric Hematology Oncology provides GRACE, a home-like accommodation near the hospital. This facility offers affordable lodging with essential amenities, easing the burden on families during prolonged treatment period. Through our 360-degree philanthropic support model, the Institute ensures that no child is denied treatment due to financial constraints. This includes partnership with government bodies, NGOs like Indian Cancer Society, UVCAN, and CSR initiatives to provide financial aid and support services. At RGCIRC,
The ACT clinic is a long-term follow-up clinic for children who have completed their cancer treatment. Its purpose is to monitor, detect, and manage late effects of therapy, ensure healthy development, and help survivors transition to a normal life post-treatment. The Department of Pediatric Hematology Oncology also contributes to the academic advancements through a 2-year fellowship program accredited by the National Board of Examination, fostering the next generation of pediatric oncology specialists. Celebrating Life is an annual survivorship program organized by the Pediatric Department to honor and support childhood cancer survivors, to uplift the recently diagnosed children and their families, and to foster awareness in the community about life after cancer treatment. It combines fun, education, emotional support, and community engagement. The work that we do is highly stressful and emotionally intense. We at our department do have birthday celebrations, small get-togethers, and other activities for the staff members to foster informal bonding, reduce burnout, and improve staff morale. As we move forward, our mission remains rooted in excellence, empathy, and equity, offering hope, healing, and a healthy future to every child who walks through our door. Thank you.
And we now proceed for lunch, and we hope to see you back by 2 p.m.
आप लोग थोड़ा सेंटर
Thank you. बहुत अच्छा हो गया। हाँ ये तो आप बोले आओगे।
आप यहाँ के जो
टैक्स की डेडलाइन बीट करें with 100% accuracy and maximum refund on clear tax. इधर नहीं तो किधर?
Welcome back. We now switch our gears from discussion to discussion. We now step into the fascinating world of neuro-oncology. Brain tissues in children are both common and complex, requiring multidisciplinary care and bold innovations. This session promises a mix of science, strategy, and stories from the clinic, and will walk us through the journey. For this session, it is with great honor and deep gratitude that we welcome our distinguished session expert, Dr. Santosh A. Upadhyay. We are especially thankful and humbled that despite being nearly 12,000 kilometers away, Sir has agreed to join us today at 4 a.m. local time. This extraordinary gesture is a testament to his unwavering commitment to education and to the unifying power of knowledge that transcends the zones, time zones, geographies, and boundaries. Dr. Upadhyay serves as a professor of pediatric oncology at Michigan University and is a highly respected faculty member and mentor in the neuro-oncology with St. Jude Global. He is also an expert faculty with the Global Alliance for Pediatric Neuro-Oncology Forum and has previously served with distinction as a faculty member at St. Jude Pediatric Oncology. Thank you, sir, for your experience, for your presence, your time, and above all, your willingness to share your immense expertise with us. Your guidance is invaluable, and we eagerly look forward to learning from you today and in the future. We sincerely hope to welcome you in person very soon and continue this journey of shared learning and collaboration.
No, he can create it. We have to do this. Someone else let him unmute. No, he can create it. He just someone else let him unmute. Where the control is here.
Okay. Okay. Forward with the first talk of this session. Low-grade gliomas may look simple on paper, but in the clinic, they test every bit of our judgment. Where does the clarity end and the complexity begin? To take us through this puzzle, we have the upcoming session with a panel of experts. Now I would like to welcome the chairperson for the upcoming session, Dr. Rajat Saha and Dr. Rohit Kapoor. Dr. Rajat Saha and Dr. Rohit Kapoor.
Good afternoon, everyone. I just want to make sure you can hear me.
Yes, sir.
Okay, great. Thank you. Thank you.
Okay, as we say that the oncology needs precision as well as patience. We'll wait for the speakers, for the chairperson, and we may go further with the talk of the session. Dr. Rajat Saha, sir, is senior medical oncologist and unit head at Rajiv Gandhi Cancer Hospital. Sir, can you please address the speaker?
So we'll be going ahead with the next session on pediatric gliomas, and we have a panel discussion which will be moderated by Dr. Girish Chinnaswamy. He's professor and head of pediatric oncology at EMH, and he's also the secretary of Neuro-Oncology Disease Management Group at ACTREC. He's a core member of the National Oncology Networks and PSYOPS ERC committee, and he has got an extensive academic rigor and is also involved in a lot of global collaboration.
Hello.
Yeah, it's
So I welcome Dr. Girish Chinnaswamy for starting the moderation.
Thank you, Dr. Saha. I'll just call the panelists on board. So there's going to be a panel discussion. So first I would like to call Dr. Kaviraj, who is the neurosurgeon from RGCI. Is Dr. Wazid Nazir here? Yeah, Dr. Wazid Nazir is also neurosurgeon from GB Pan. I would now like to call Dr. Aditya Gupta. Aditya is a pediatric oncologist from AIMS, Delhi. Amita should be coming shortly. I will ask Manas to join in till Dr. Amita comes and you can continue after that as well. And I would like radiation oncologist, of course, we need for this Dr. Renu from PGI Chandigarh will be joining as well. Payal, is there a point? Payal, is there a pointer at all? If it's otherwise, it's okay. No, you also said we'll put additional chair. That's completely okay. It's a panel discussion. All of you are panelists as well, but we will go in order we won't make it a disorderly panel. So we'll start from that. And we also have Dr. Santosh Upadhyay, who has joined from Michigan. So I must appreciate Santosh. At 4 a.m., you are wearing a tie. And I'm in jeans here at the moment in Delhi. So anyway, Santosh is a very close friend to many of us. And so it's good that he's on the panel and he's a neuro-oncologist for those of you who don't know him, pediatric neuro-oncologist. So today's topic is quite, I had to really think what we put here because when Payal gave this topic, I told her it should be a low-grade glioma. I told her what are the broad areas we should cover and not do medulloblastoma because that's done like thousands of times every year. We have done more medulloblastoma sessions than the number of children in India who are diagnosed. So so I told we should do that. And then, yeah. And then, but the topic she gave, the second component was a bit more complex, where clarity meets complexity. And I then now I had to really think how to actually take this forward. So, yeah. Right, so we've gone through the panelists and I also told Santosh is here. So pediatric low-grade glioma, there is no definite guidelines on how we actually manage. Generally, these are kind of broad directions on which we go. We go through resection if it's feasible. If you have completed the resection, complete resection, then you observe. If it is incomplete, you can decide whether to give any adjuvant treatment or no. If it is not possible to resect or it's sometimes you feel even it's an incomplete resection, you may decide to treat. Then you generally look whether it's a NF1 patient or a non-NF or any other syndromes which are there, for example, like tuberous sclerosis, etc. And then you actually decide whether we'll actually do observe, whether we'll do chemotherapy and radiotherapy after giving it a thought about surgery. Now, that's generally been the practice for many, many decades. And historically, this is how it's been done. As you can see, oops, it's the low-grade gliomas first. After surgery, you observe. If they progress, we ended up giving chemotherapy. And if they had further progression, you ended up giving radiotherapy. And the high grade we are discussing now, and that's something for the next panel who will be discussing. Now, the overall survival is excellent with this approach. You do surgery, radiation, or chemotherapy after that. You got 90% survival at 20 years. I mean, this is like a follow-up, not even at 5 years. We are talking of 5 years, 10 years survival. Here we have a 20 years survival of more than 4,000 patients from the US here database as well as from Canada as well. Now, if that is the case, then why is it complex? So outcome is so good. You just have to give simple chemotherapy. Radiation has to be done. Surgery where feasible. And what exactly is the problem? So which is why I think it's a interesting topic that how does clarity actually meet complexity in this situation and how do we actually make it really clear on how we should approach. And if we deep dive into the cases and what we are going to discuss now, we'll realize that all of you will have different opinions. And it is okay to have different opinions because nobody knows what's the right opinion in this situation to do. So I'll take a child to begin with, a 5.5-year-old male child who presented with vomiting, headaches, more in the morning, 2 months duration, raised intracranial pressure, pretty straightforward. That child needed a scan. And this is the scan which was done. This is a case recently, February 2025. And I just have few images only. I'm sorry, I don't have all the images, but what you can see is a posterior fossa mass, solid cystic mass, which is present in a 5.5-year-old. So I would like Dr. Wazid and Dr. Kaviraj to say, what would you do in this situation? What do you suspect and what would you do in this situation?
Good afternoon, everyone. Just before I dive into the case, just want, because we are basically discussing low-grade gliomas. We have evolved grossly, as sir was saying, 20 years of overall survival. From 5 years, 7 years, now we come to 20 years. So the dynamics and the perspective has changed. How we manage these patients has changed. No doubt, one thing has stayed same over the last 20 years. Surgery as the mainstay. There's no difference of opinion anywhere on this aspect. The only thing, the patient is asymptomatic. Had the patient been asymptomatic, he will not meet you. Once the patient is symptomatic, patient comes and there is something and we need to address it. Because now, since after 2016 and subsequently 2021 classification, everything has changed. The classification system has changed now to molecular. So we have realized earlier we used to say even glioblastomas. This patient passed away in 6 months, and this patient is followed for 6 years. How come so?
Yeah.
Because that time there was no molecular in early 21st.
Absolutely.
So now coming to this case, we say
yeah.
it's a straightforward, we have to operate. Surgery comes first.
And what do you think? You'll be able to get a maximum resection, gross total resection here?
Yes, we should be. Apart from those peduncular areas, peduncles,
Yeah.
which will be difficult because there'll be no demarcating line there. Apart from that, you should be able to take out gross total resection.
Sure.
Yes.
And Dr. Kaviraj, any thoughts, or you also agree that this is straightforward surgery, this is what you would do? Sure.
There is no clear-cut line, but yes, there is no much significant edema in the brainstem, so we should be able to take out much of the
disease. Okay.
But cannot say that 100%.
Sure. So this is, I think I need to click on it.
On surgical aspect, yes, it's a solid cystic lesion that makes it more difficult. Had
Right.
it been purely solid, that will be more
Sure.
easier.
Yeah.
The cystic component has to.
So the plan was to do, we saw the neurosurgeons first, the plan was to operate. So underwent a third ventriculostomy because from the time that scan was done till we saw the child also had significant worsening headache with hydrocephalus. So on 23rd, 3rd and 24th, we took for a craniotomy and a near total resection of the tumor was done. Histopathology was pilocytic astrocytoma, which is grade 1. So now I would like to ask Aditya and Manas and then come to Renu. 5.5-year-old child, pretty much completely excised. What would you do next? Pilocytic astrocytoma. This is the information we have as of now.
Again, we can observe and wait and watch.
Okay.
And just so most of them do well with resection.
Yeah.
So surgery is often the only treatment that is required.
Yeah.
In 50 to 60%.
Sure. Manas, you agree with that as well?
Yeah. It's near total excision of a posterior fossa pilocytic astrocytoma. I'll be just happy to observe.
Okay. So Renu, I guess you also, do you want to add anything to that?
Observation and follow-up imaging.
Follow-up with scans, which is what we did. So where to click this again? 3 months, patient was asymptomatic. There was some residue left behind, but good excision done. Pilocytic, we continue to watch. We said we'll continue to see the child. Now we'll do a scan after 1 year. And then actually child came back 6 months, that is 6 months from surgery, 3 more months later. This was in August last month with mild ataxia and headache, and the solid component had increased and the cysts had also increased. So now the question is, what would you do? First to Manas and then to Renu. 5.5-year-old child who has had a recurrence and symptoms which are there.
So I would just like to go back and look at the histology previously.
Pilocytic, clear cut. There's absolutely no doubt on that.
Absolutely no doubt. So again, talk to the neurosurgeon and ask for resurgery if this tumor can be removed. Study the molecular typing and all. and then consider, because it's a recurrent pilocytic astrocytoma, I would like to treat something because it has shown the potential to regrow like malignant tumors. So I would, like to give some form of a adjuvant therapy for this child. It's a young child, low-grade glioma. Chemotherapy would be one option that I would consider, vincristine, carboplatin.
So even if surgery is done fully, you would think we should give chemotherapy. Would anybody differ on that?
So
Let's
again,
say we'll
if
operate
you are
and wait.
completely resected, low-grade glioma, you can observe, but because there is a potential to regrow, I think I would be inclined to give some adjuvant treatment for this child.
Sure, agreed. So that is partly what people felt in our group as well, that the recurrence was too quick. And symptom was too quick. So even if you get a decent surgery, maybe you should go and do some therapy which needs to be done. And so the choices that time were resurgery and observe, or resurgery and chemotherapy, which we discussed, chemotherapy alone, or do radiotherapy. And Renu, anything you wanted to add to this?
So after, if the neurosurgeon is able to resect the entire disease or partial disease and patient received chemotherapy, he's stable after chemotherapy, both imaging wise and symptomatically, then radiotherapy is probably not indicated.
Sure.
But in case of progression, either symptomatically or on imaging, then there is a role of radiotherapy.
So the parents refused surgery. So the discussion was with them. They said, we've already been through one surgery. Child was in hospital for so long. What I did not tell you for on purpose was, post-op, there was 3 weeks of fever. And we couldn't decipher whether it is meningitis or not meningitis. Ended up getting antibiotic for so long. The parents were very clear, we don't want any resurgery. So now the question was, what do we do? And they come from an area where the father is the only earning member of the family. And we told treatment is chemotherapy for 1 year. So now the complexity of the question, what she comes here now. They said, we cannot stay here for 1 year, but the treatment, we told chemotherapy is for 1 year since you don't want surgery. And they are very caring, of course, but the whole thing is about displacement to a city, which is Mumbai here. Even though treatment, accommodation, all was provided, the whole thing was what they do with the rest of the family. They brought the other child also into the hospital and all that. So now tell me what to consider. Now I want Renu and pediatric.
These are extraordinary, like circumstances for this particular family that, they don't want resurgery. See, chemotherapy also would work better in a low-grade glioma if maximal tumor resection we have achieved. That would really, work well, the chemotherapy. Having said that, some of the optic pathway tumors we are not able to remove and we just give chemotherapy alone. Now, in this case, you are saying even chemotherapy is not possible. So in that case, and, we don't know whether affordability for a targeted therapy is there or not. Radiotherapy would probably be one go answer for a posterior fossa tumor, not affect the IQ cognition as much as a craniospinal irradiation would. So, in such a circumstance, although it does not come that early in the algorithm of LGG, because the scenario you are giving, it may be possible that, we may just give RT.
Okay, so Renu, what's your thought? If the family says they can't stay, now the question is radiotherapy is for 6 weeks, done and dusted, home.
Yeah.
This is for 1 year. It's definitely not dusted. It is chemo is done. That I can tell you from chemotherapy, the impact is far less than radiation. And I would like Santosh to opine what he would do in this situation after Renu has.
Obviously, first option would be adjuvant chemotherapy, which they are not able to take because of their logistic region. Then child is 5.5 years old. So with the modern techniques of radiotherapy, limited radiotherapy volumes, advanced radiotherapy techniques, we can definitely reduce the side effects which were earlier supposed to be the common side effect of radiotherapy. So yes, I would like to give radiotherapy in this case.
Yeah, so I can tell you we went through multiple rounds of counseling on this to actually convince them for chemotherapy. Okay, Santosh, any comments on where there is logistics issues to deliver chemotherapy, how justified it is to do radiotherapy, which has got an excellent progression-free survival, in a situation like this where they come from interior of Maharashtra and they would not want any treatment?
Yeah, thanks, Girish. I hope you all can hear me because I muted myself and I was not able to unmute. Then I had to ask the host to unmute me. So sorry about that. And thank you for the organizers. Thank you, Dr. Pal and Girish. I don't know. I'm wearing a tie, but you don't know if I'm not wearing jeans. So let's leave it at that. No, very interesting case, isn't it? It's
Amita.
definitely unusual for this pilocytic astrocytoma in a posterior fossa which has been completely resected to grow this fast, right? To grow back this fast. Typically when you look at low-grade gliomas, the rate of regrowth is about 5 to 7 millimeters a year. That is the typical pilocytic astrocytomas, and so it's very unusual. I'll answer the question in two parts. One, what I would do in the setting where you have complete access to every resource and compliance is not an issue. One of the things you probably want to do is, and you may have already done this, Girish, you may be just holding on to your cards, the molecular analysis, right? Is this the classic BRAF fused pilocytic astrocytoma, or is this a BRAF V600E altered, which has coexisting, CDK and 2A alterations, right? And those tumors tend to behave a little bit more uglier than the classic BRAF fusion, and there is data from the SICKITS and other groups to suggest that CDK and 2A alteration is generally, more prognostic in these patients, although not studied in a prospective fashion. So that's one thing. And the reason I ask that is it may also feed into what treatment decisions I would make, especially if repeat surgery is not an option. I would agree. I think even with a 6-month interval of regrowth, maybe consider resurgery. But granted that the family is not agreeing to that, so your options are limited to chemotherapy, radiation, and targeted therapies. And when we come to targeted therapies, the MEK inhibitors tend to act a little bit slower than the BRAF V600E inhibitors. So if you have dabrafenib or vemurafenib, in the presence of a V600E alteration, as we know, you can't use dabrafenib or vemurafenib if there is no V600E alteration. Do not use it if it's a BRAF fused tumor. Now, these BRAF V600E inhibitors, they're fairly well tolerated. Their compliance is not so bad. And having seen that low-grade gliomas with V600E alterations do not respond very well to chemotherapy, they will respond. It's not like they don't respond. The practice here has moved towards starting these patients on targeted therapy from the beginning. Now, coming to radiation and compliance, I think it's a key point, isn't it? You're telling us that this family may not return, or they may have problems staying for a year or 15 months and coming back for treatment. So unless you're able to arrange for chemotherapy locally, your logistical issues are going to be really challenging. And you said it rightly that in the beginning itself, that these patients have a 90% chance of living beyond 20 years, 25 years, right? And so what is your conundrum is exposing them to radiation at this point. But if it's a decision between, hey, they're going to come back or may not come back, and this kid might be just very is at risk of this tumor growing back again and hydrocephalus and all the complications, versus are you going to do radiation just so that make sure that there is some treatment provided. I would lean towards that fact. I think that would be the probably the only reason at this age you would consider radiation in a low-grade glioma. But you want to just, as you have rightly done, you've exhausted all other options and then kind of consider that. But I think the molecular information will be very crucial in this patient.
Yeah. So the discussion also came up because there was an option of giving proton for this child if he had to do radiation, whether that would actually decrease any long-term effect. But nevertheless, by then we did obviously have a molecular testing as well. And as Santosh rightly said, we got the BRAF V600E mutation was negative, but the BRAF fusion was actually positive. An NGS has been sent, but because the growth was too fast, and we will know whether CDKN2A and other coexisting are there, but the BRAF V600 is negative, so it should be fine.
Girish, may I ask one other question?
Yeah, added. Yeah.
So, I'm sure this is your TMH case, and I'm sure Dr. Sridhar has done a fantastic job of everything. But just one other point, in the so-called sometimes pilocytics and other midline tumors, just be very careful about ruling out the histone mutations, because these can have sometimes H3K27M mutations. So I think that would be very important, especially in a case where the tumor has grown back so quickly.
So fast. No, absolutely. So finally, we decided that this patient, though cannot stay with us, that the best option for this child, if we had to avoid the long-term effects of radiotherapy, was actually to give MEK inhibitor. And so we started the child just now on MEK inhibitor for about 3 weeks back. And we had to arrange the funding, all that, which took some time. But we started the child because that is what practically for this child works best. The parents have to come only once in 3 months to us. Hopefully they're compliant enough because they seem to be very caring for the child, and all that thing was definitely there. And that's what we have done. So just to tell you that what was a simple, what we thought should be surgery. First time we told them it's surgery and you'll be done and you don't have to worry anymore. The tumor has come out, then it has recurred, then we can't, they're not agreeing for chemo. RT was an option, but finally we have put the child on MEK inhibitor and we will see. They will come back after 3 months, then every 3 months, and we'll see how the tumor goes. So that was just to set the stage on that component about how low-grade glioma, which are supposedly relatively benign tumors, how complex they can sometimes be. And then in this situation, a targeted therapy. So what is complex about pediatric low-grade glioma? As Dr. Wazid said, surgery is the first shot to do. And surgery, whenever feasible, should be done. And what data is very clear that if you actually done good surgery, then the recurrence rate is far less where you have not done good surgery. So if you achieved a GTR or achieved a near total resection, or even the majority of the tumor or substantial part of the tumor is taken out and it is low grade, then the chances of those patients needing further therapy are less than what we do. But the problem is the tumor is not just there. The tumor is not always in the cerebellum. The tumor is not always in the cortex. It's many times in areas in area where cortical temporal lobe, it may not be always there. Many times in areas in the hypothalamic optic pathway where surgery is not feasible. So in that situation, now surgery actually becomes kind of not really the therapy of choice for treatment, though it may be required for understanding the disease pathology and the biology which needs to be done. So my question to Kaviraj is, in a low-grade gliomas what come to you in pediatric, what proportion are so-called amenable to substantial surgery? And because it's a low-grade glioma and there are adjuvant treatments which may control the disease, do you actually shy off from doing what I call substantial surgery because you can do other therapies and still keep the child going with such a good outcome on the long run?
So, sir, it always depends on the location of the tumor and the patient condition, means clinical what he is having right now. So, if the patient, location of the disease is very much like in posterior fossa operable tumor or some in lobar location, we should always try for the maximal resection. But if the tumor is in like optic pathway or hypothalamic, then definitely surgery would be questionable. And in such cases, we try to just keep away from the surgery. And maximum we do is biopsy in such cases.
Right.
But if the tumor mass is very big and it is giving a mass effect in the form patient is being coming as a drowsy or neurological deficit, then in that those cases still surgery is an idea.
Surgery.
Yeah.
Okay, so we'll move on. So now coming to in this same child, so I just want to ask, when you decide any adjuvant treatment, both for Renu, Amita, and Aditya, when you're deciding adjuvant treatment for a pediatric low-grade glioma, what are the factors you take into account? When would you decide therapy is required or not required? What are the factors you take into account to say adjuvant therapy is required or not? Or what is the choice of therapy? So what are the factors you take into account?
First is age of the patient,
Yeah.
then location, size of the tumor, symptoms, extent of surgery, obviously, molecular markers. Parents are able to afford the therapy, targeted therapy or not.
So by age-wise, Aditya, what would be your, say, cutoff? Do you have a cutoff for chemotherapy for low-grade glioma? Or should there be a cutoff for chemotherapy for low-grade glioma?
I think there's no cutoff. So, I mean, if it's an infant with a large cellular hypothalamic mass, which then I think that would need some form of adjuvant treatment. So if there's a risk of progression of the disease and that leads to any neurological deterioration, if there's that risk, so even with a very small tumor, we'd go ahead and give treatment.
Absolutely.
Yeah.
So I think that's a very important point when deciding how we actually treat. The volume of disease is not a same parameter at all sites of the brain. So there are sites of the brain where if the tumor grows back, the neurological complication or damage would be significant. In that situation, even if 80% of the tumor is removed and we are worried that the tumor growing back will cause significant damage, then you would go ahead and give adjuvant therapy. Whereas there are many sites in the brain where 80% of tumor would be removed and we are okay to leave that 20% because the tumor growing back may not cause any neurological damage. So it's quite a individualized decision. So the other than the disease size and the site disease itself, it's the site of the tumor which actually is a critical component in deciding how we actually further proceed with therapy. So in what sites, Renu, would you hesitate to give radiation? Or in what sites would be comfortable to give radiation in a low-grade glioma?
So I would hesitate in supracellular location. This is the main site where I would be a little reluctant to give radiotherapy in a young child, but otherwise, for the lesion situated peripherally or infratentorial lesion,
You would be comfortable to give.
we will be.
So we must always remember that these children go on to lead normal lives, and more than 90% are alive at even 20, 30 years. So in that situation, what you don't want to do is create an endocrine issue if you can avoid it, because that may be a bigger problem than the low-grade glioma tumor itself. Because lifelong support which is required for a panhypopituitarism is much more complex and probably quite expensive to actually deal with. So on which is exactly what in low grade. So we'll move on. So now coming to the difference between impact of radiation and chemotherapy. Now that is a significant factor which we take into account. And as you can see in the graph in the left, 90%, if you actually give radiation, the event-free survival is about 80%. That means progression-free survival is 80%. That means only 20% after radiation would actually recur. So radiotherapy works beautifully for low-grade glioma in preventing progression or recurrence. And the graphs on the right are of chemotherapy, two different regimens which have been tried, and you can see that only 40% of children who receive chemotherapy actually get away with no further treatment. That means 60% of them need second, third line treatment as well. Now, this is an important aspect to keep in mind and not just the survival, and I'll come to that. So if RT has lesser chances of recurrence, then why do chemotherapy, especially in older children, which we already discussed, and that the reason would be actually because these children are surviving for 20 years and there are long-term effects which are there. Critically, there were cerebrovascular events, secondary brain tumors, endocrine dysfunctions, which were reported even in children who had received radiotherapy later on, because they were going to live for a long period of time, and you could actually see that. And this is a very important outcome of the study on the SEER, which was shown, that at 20 years, we saw 90% survived. But if we actually divided them to children who received radiation and children who did not receive radiation, children who received radiation had a far more death than children who did not. So that means there was a gap of about 20% survival at 20 years on children who received radiation and then children who did not, irrespective of the extent of resection done. So that means the deaths were occurring due to stroke, the deaths were occurring due to vascular malformations, and deaths were occurring due to second malignancies. Now that means you give radiation, you may actually in a short term for 10 years, 15 years control the disease well, but you're actually compromising long-term survival. Now, keeping all this in mind, there has been a shift in how we actually approach low-grade gliomas, and that's what I want to discuss. So, talking about the chemotherapy itself, I want Amita to comment on. So, what's your experience when you give chemotherapy for low-grade glioma? What do you tell the family, and what do you actually get out of the chemotherapy?
So I think first thing is for them to accept that unlike anything else in oncology, we are here dealing with a chronic disease. So I don't know when do we call them a survivor, because till they are adults, they are on follow-up. So they need to accept that this is going to be a long-term journey. And because the biggest aspect of the chemotherapy is the prolonged course. So many of the protocols, they will go up to 80 weeks. Even if we use just vinblastine as a single agent, still the chemotherapy is over a year. So like you said, they need to be ready to be coming. But in the long term, if there is a symptomatic, unresectable low-grade glioma, we would like to give them chemotherapy and defer the radiation for as long as possible, especially in patients with NF1, because their chances of developing second neoplasms as well as the vasculopathies is far more than non-NF1 patients. So most would accept chemotherapy. Only problem is the distance and the other challenge.
That's right. But on chemotherapy, you also have multiple hospital visits, multiple blood tests to be done, infections, transfusions, all those issues which are there. On radiation, of course, long-term toxicity is there, but of course, the treatment is shorter. So now, same therapeutic approach, which we said may not be applicable in all contexts, as we discussed in the first case, especially LMICs. And then there were discussed the situation where we feel radiotherapy would be better. Even if you look at the guidelines which have come out globally, like the ARIA guidelines, they let you decide based on the situation, which part of the world you are, whether you actually observe a case which somewhere else you would have treated, or give radiotherapy to case where somewhere else you would have given chemotherapy. And it is all to do with what is actually feasible and what is practical in that situation. So there has been a change in approach in low and middle income countries as well, though it is occurring at different paces. So we were giving radiation previously to all more than 5 to 7 years of age, chemotherapy in the younger ones. Then we moved to chemotherapy first, and then only on progression radiation. That means the age was removed. And subsequently, because the long-term effect, these other papers and data came out, chemotherapy was given not once, but more than once, and only after that, the radiation. By doing that, you delay the radiation to as late as possible. So as Amita said, it's a chronic disease. And now, what is the implication of prolonged systemic therapy? What do you tell the family? For in the context where there's a modest benefit, in the context of India, while we do this, as we discussed in the first case, and for the child and family. So Aditya and Amita, what do you tell the family there?
So we tell that, we are not going to cure the disease with this chemotherapy. Our aim is really to maybe avoid or defer radiation for as long as possible, and that will be better
So
for the child.
what's the implication on the child and the family of doing this treatment?
So there is a lot of impact, and I must say that in our clinical practice, we do end up, and the parents do choose radiation in a significant proportion of patients, because this is just not, this regime is not feasible. One option is to do it on a shared care basis. So we cut down the distance. It's a relatively, short of hypersensitivity. It is manageable in a shared care setting. So that is a kind of a middle path that we sometimes.
So these were statements by one parent and one child. So one was parental fatigue is very high in low-grade glioma because they need multiple times chemotherapy and you keep on calling them for years to hospital. And that too, they come every week to take the chemotherapy. The other one is what we call is loss of childhood, which occurs very commonly with low-grade glioma. So one parent said after spending 18 months in Mumbai, the tumor still needs further treatment. So the whole effort has gone waste. You should have done radiotherapy upfront in our child. Then we would have finished and we have gone home. Because after this, we advised radiotherapy to them. And then we told them, now the child will be very well cured. They said, आप पहले क्यों नहीं बताया फिर? अभी 2 साल के बाद बता रहे. So that is what we said. Then the other one was a child who has received 2 lines of chemotherapy and then underwent 2 surgeries. That kid refused to go back to school. He said, I missed school for so long. My friends have moved on. I'm taller. All this was in Hindi. This is my English, by the way. I'm taller, but left with very young kids to study. I don't want to go to school. So child who finished 2 lines of chemotherapy. That means he had missed 2-3 years of wind blast, 1 year of wind blast in 1 year of ink carboplatin. So that's where the complexity of dealing with a low-grade glioma comes, because the collateral damage of your treatment is not just on the, we should just not focus on the toxicity of therapy. Yes, Sunday, but still they need transfusion and all of that. So childhood is affected because of all these reasons, long therapy schedules, they miss normal childhood activities, it affects growth and development. And of course, there's a significant impact. They go through for only a 50% progression-free survival. So the overall survival itself is not a good thing to do, as we all discussed, and that is not a parameter at all. You should never say 100% of my low-grade gliomas are surviving, that they would have survived without you probably. So you need to actually tell them how many of them you got back to school, how many of them did not have any progression or anything like that. So the purpose of therapy. So I would like to come back to Renu as well, and after Kaviraj as well. What do you think is the purpose of therapy? What do you want to achieve in this low-grade glioma treatment?
So, because the overall survival is very good in these patients. So, purpose of the disease is probably to keep the child disease free or progression free as long as possible, and to minimize the side effect of the treatment, be it chemotherapy or radiation therapy.
Absolutely. I think the long-term functional outcome of the child from all facets is what we actually need to maintain. I think the slides. No, somebody else is controlling it. I'm not controlling. Okay. So now we discussed that radiotherapy has late effects. Chemotherapy has significant impact on child and family. So then what are the options in front of us next? Manas, you want to take this since you're looking on the phone and not listening.
I can go back and tell everything that I said. Yeah. So multitasking at the moment. But yes, I think you're pointing towards a possibility of targeted therapy as one of the options for these patients, because chemotherapy, it has to be given intravenously and then hospital visits and all that. Although blood transfusions and all the point that you mentioned, it doesn't happen very often with low-grade gliomas. But yes, if you can just pop in a tablet, why not? So targeted therapy is an attractive option. And I think that will probably have a larger role than chemotherapy if the results are almost, similar.
Sure. So I think we're probably running out of time, right? Yeah. So I'll just close here because Vasu will continue anyway where I stopped because his talk is actually on targeted therapy, which he'll be covering. But I'll end with just showing this case whom we are treating from 2019. This is the same boy who refused to go to school. He's actually with us for 7 years now, or 6.5 years plus. He has undergone surgery first, 2 times chemotherapy done. After 2 times of chemotherapy, again grew back, did surgery again in Feb 2022. And then that he had seizures and altered sensorium. But he was still about 8 years old. So we said we will not, 9 years old, we will not give him radiation. So we did a repeat surgery. Then we finally started him on trametinib. And now he's still on trametinib about 3 years plus. Continues to have some toxicity, but very well managed, but still refuses to go to school. So he comes happy, plays everything, but he just I know, absolutely. Yeah. So I think I'll stop here. Santosh, you want to add any comments at this point?
No, I think, this is a very important topic, isn't it? One of the things we tell our residents and fellows is that treatment of low-grade gliomas is probably the most challenging aspect of a neuro-oncologist's career. And as rightly you and the rest of the panelists have pointed out, it is just a very judicious, individualized treatment, and you can't give specific guidelines. The targeted therapies obviously are changing the paradigm a little bit, but it also is we have to keep in mind that we're talking about targeted therapies in comparison to chemotherapy and radiation, where we know what the long-term side effects are. The problem with targeted therapies is we don't know what the long-term adverse effects of these medications are and when to stop them. That is part of the problem. And so a judicious use of these agents and the right timing for radiation, I think those are the key things for managing low-grade gliomas that are not surgically resectable. Completely agree with the first statement. Wherever possible, surgically resectable and debulking sometimes is enough, and that will push out the treatment requirements by months, sometimes by several years. So, yeah.
Great. So thank you all. Serena, you want to make a comment? Yeah, please go ahead.
Have shown statements from 2 parents whose disease progressed after 2 lines of chemotherapy. So in these patients, when they come to us for radiation therapy, then the radiotherapy target volume is actually very large. Compared to if the child was treated after progression after first line of chemotherapy or early during the progression of the disease. So I think the decision for radiotherapy should be considered early during the progression of the
No, I couldn't agree with you more. I mean, just to avoid radiotherapy, by theoretically avoiding radiotherapy, we should not create more damage by increasing the radiotherapy field so much that which could have been done much earlier. No, I completely agree. That's why it's a very complex decision. Every child, we don't know, every case is such a big discussion which goes on. I would only say the only take-home clarity will come as you do more and more MDT meetings. This has to be an MDT decision individualized to each family. So you have to bring that whole family perspective in this and keep discussing again and again, and some clarity and some direction will come. So otherwise, the clarity will never meet the complexity. Yes, Payal has put here. It's not easy at all.
Girish, may a quick closing comment from my end. So just on that paper on radiation therapy, right, where you showed the difference in survival and radiation, the kids who got radiation actually, had a lower survival. I think we have to just keep in mind
They are more aggressive tumors.
timing of radiation is important, right? Now, if you're taking a group of patients where you have radiated after several rounds of chemotherapy, then you have obviously there is a selection bias there. You probably selected a group of patients who are going to do bad anyways, right? And then you end up blaming the radiation for it. So I think the timing is key. And also keep in mind that radiation, the only concern with radiation, long-term concern, is how many of them get transformed or there is a radiation-induced chance of glioma. So all this goes into the consideration. So it's the same challenges we face here as well. So I think it's a universal challenge. So it's a good topic that has been chosen. So
Great. Great. So thank you all for that.
I thank Dr. Girish and a huge round of congratulations to you for actually kind of dealing with it on a OPD kind of a basis, rather than not too much of scientific jargon here, but really have led us through the next 20 years of the thing. And a special hands up to Dr. Santosh. Dr. Santosh.
Yeah, yes.
Morning. Excellent job.
No, I was just going to say there is a comment or a question. What is the chance of malignant transformation in the chat box? And I think the answer to that is it's pretty low. In pediatric low-grade gliomas, the chance is very low. I think it's in the long term, if you look at it, it's probably less than 5%. And so this is unlike adult low-grade gliomas where most of them transform into high grades. Pediatric low grades do not generally transform, with some exceptions, whether it's radiation induced or otherwise. But the chances are very low.
So moving on to the next talk. The topic is the glioma tumor board, where every case tells a story. Tumor boards are where real life medicines unfold, no textbook answers, just real dilemmas. In gliomas, each case truly tells a story. To chair this session, I would like to invite Dr. J.P. Meena, Additional Professor, Pediatric Hematology Oncology at AIIMS Delhi, and Dr. Rohit Kapoor, Pediatric Oncologist Consultant at BLK Max Hospital. And to moderate the session, I would like to invite Dr. Payal Malhotra, who is a dedicated pediatric hematologist oncologist at our institute. And very recently, she has been awarded with a prestigious fellowship in pediatric neuro-oncology by the St. Jude Global Alliance. She is recognized for her commitment to advancing cancer care for children with brain and CNS tumors. Beyond all the accolades, Dr. Payal is deeply respected for the empathy and connection she brings to her work, so much so that she has been honored with the Best Rapport with Pediatric Patients Award. We welcome you, ma'am.
Yeah, good afternoon, everyone. So as we have seen that glioma has a very heterogeneous disease. For every patient, we need a multidisciplinary meeting, which consists of pathologist, oncologist, surgical oncologist, and some neurosurgeon and radiotherapist. Glioma may behave like we may have to watch only, we have to keep only observation. Some patients may require surgery, some patients may require surgery plus radiotherapy, some patients require all types of sorts of therapy, like surgery, radiation, as well as chemotherapy. So I invite Dr. Payal to discuss this topic, that glioma tumor board, where every case tells a story. Now hand over to Dr. Payal.
Thank you very much. Before I start, I once again want to thank Dr. Santosh. It is 4:30 a.m., sir, and you look absolutely really good in your red tie. And thank you for joining us. May I please? So the topic for today is the glioma tumor board, where every case tells a story, and I'm sure I'll be telling many stories today. And my slides are not moving, so sorry. Okay. So we have many brains to solve today's stories. First is the diagnostic brain, Dr. Rupinder Baweja, who is the senior consultant in Department of Radiology. He's a neuroradiologist at RGC and RC. Then we have the cutting edge brain, Dr. Ajay Chaudhary. He is the neurosurgeon at RML Hospital. The brain behind, inside, and beyond the microscope, Dr. Anila Sharma. She is neuropathologist at RGC and RC. And Dr. Sapna Manocha, she is the radiating brain. So she is a senior consultant in Apollo Hospital. The healing and the treating brain, Dr. Kriti Hegde. She is senior consultant pediatric oncologist at SRCC. And Dr. Santosh, once again, we welcome you. Now that you're settled, we'll start with the first case. This is a 14-year-old female who presented to our hospital with headache for 2 months and impaired vision. There was no history of vomiting, seizure, focal neurological deficits, any gait or behavioral abnormality. This child, because had headache and vision abnormalities, was taken to an ophthalmologist who on perimetry found to have a left hemianopsia with temporal field of vision on the left side lost and nasal on the right side with bilateral papilloedema. So guys, what are we thinking? We're already thinking there is something intracranial that's happening, and therefore the ophthalmologist told to get an MRI done. So Dr. Rupinder, could you please quickly tell us what do we see in this MRI?
So these are the contrast enhanced images. We have axial images. First is the T1, which is without contrast, and the corresponding post contrast is in the end. So what we can see here is there is a heterogeneous tumor. So it has an enhancing component. Can I have a pointer? Okay. Okay.
Yeah.
ठीक. Okay. This is the, yes. So this is a number one heterogeneous tumor. We have enhancing component as well as the non-enhancing component. Now, this is very important. The tumor is not only localized here in the enhancing component. This T2 flare, hyperintensity, this also is the tumorous component. So this is an enhancing tumor which has some, if you see, there are nodular enhancements. Yes, yes, yes. So this has a enhancing as well as non-enhancing component, which are both tumorous.
Yeah. Thank you, sir. And so this is there's probably one satellite lesion also which is seen in this tumor, which is so temporoparietal mass. Just simplifying it for the non-radiologist here, a temporoparietal mass with another satellite lesion which is seen here. And I just put this diagram for my residents. So this child had like a left hemianopsia. This is because probably the mass was sorry. So the mass was here in the temporoparietal lesion, which probably was an optic radiation, and therefore the child had a left hemianopsia as the crossover takes place at optic chiasma. So the symptoms were actually telling us where the mass would be. So now that you've described the MRI, I just wanted to ask you something that's really talked of is a T2 flare mismatch. What do we mean by a T2 flare mismatch? Do you want me to go to the images, sir?
T2 flare is actually a radiogenomic signature of IDH mutant. So this sign is usually used when you have a homogeneous T2 hyperintense mass which suppresses incompletely on flare. So this is called as mismatch. Like this, there is a homogeneous T.
Sir,
Go to
I can
images,
show.
please.
I can show. I can show. I can show. Yeah.
Next image. Next image. Next image. Next. Haruki. Like this here. So the tumor has to be homogeneously T2 hyperintense, like we are seeing here. And it shows.
I can show it, sir. I can show.
Please.
That's okay. T2 intense, that's homogeneous here.
Yes, it is homogeneous. And as we go on the flare imaging, there is incomplete suppression and there is a rim of enhancement. A rim of hyperintensity on the
Right.
flare images. So this sign is, although radiogenomic signature of IDH mutant, but it is present only in 43% of cases.
So rightly said. So just flare images are fluid attenuated images where your fluid is suppressed, the CSF signal gets suppressed. And here you see there is an incomplete suppression with rim enhancement. This is likely due to, so in astrocytomas, you may have microcystic changes or fluid accumulation in the extracellular space because of which this sign exists. And sir rightly said that it exists in only 40%. That means sensitivity is 40%. But let me tell you, the specificity reported for this particular sign is 95 to 100%. 95 to 100% that you are able to relate the radiology to the genomics. So, yeah. And there was actually, yeah, we can just go ahead. Dr. Santosh, where are you? We can't see you.
Yeah.
So,
Yeah.
you're there. Thank you so much.
Yes, I'm here.
So, what findings, sir, as a pediatric oncologist, when this patient walks in your OPD, make you think that this is a high-grade glioma? I mean, the radiologist has said his version, but what makes you think this is high-grade? And I've seen you in gap note discussions routinely asking for flare images. I mean, what excites you in that? And also, what more sequences or studies would you obtain to differentiate between low grade and a high grade on imaging?
Yeah. Thank you. I can take that question. So, obviously, when we are in the clinic, sometimes we don't have a ready access to the neuroradiologist. So sometimes we have to make some decisions right away before we can sit down with the neuroradiologist and go through the images. So I'm going to take this opportunity to go through what, as a clinician, I find it useful to have these images so that at least at the initial diagnosis, whether the patient is in the emergency room or casualty or whatever you call it, that I can make a decision and talk to the families. And I'm going to use this RAPNO criteria. So for those of you all, the trainees that are not familiar with RAPNO criteria, this is response-based assessment in pediatric neuro-oncology, which is a standardized way of looking at images so that across the world people use the same parameters for assessing response and diagnosis in brain tumors. Every brain tumor has its own RAPNO criteria, like low grades, high grades, ependymomas, and all the different types, although not all of them have that. And so in high grades and low grade gliomas, I've put the pictures on top are the high grade ones and at the bottom are the low grade gliomas. And what you will see is there are at least 4 basic type of images that you would like to have. One is the T1 pre and post contrast, as Dr. Baveja pointed out in the beginning, the T2 and the T2 flare images, and then of the diffusion weighted images, right? And each one of it has its own importance. As you will see, the T1 post-contrast images are particularly useful in high-grade gliomas because they tend to enhance with contrast a lot. This is primarily because they're very vascular tumors and they're very leaky tumors because the vascularity is so intense that the contrast can leak and it's not a well-formed vascularity, and that's what is driving some of the contrast enhancement there. Now, the importance of T2 flare, as Dr. Pal suggested, what happens in flare is it is slightly a better version of the T2 for us as clinicians, because in flare images, you're suppressing the CSF signals. As you will see there, the ventricular signal, the CSF in the ventricle is completely dark there. So that CSF has been suppressed, signal has been suppressed. Why do we do that? Because the tumor edema and the tumor infiltration stands out nicely, and especially leptomeningeal metastasis, which generally tends to coat the brain. And those are the reasons why we have to use T2 flare images in our practice, and I find it particularly useful because, as you see, compared to the T1 post contrast, the T2 flare images are really enhancing the peritumoral edema in the high grade glioma, whereas in low grade gliomas in the lower bottom in the lower half, you're not seeing any enhancement both on the post contrast images as well as on the flare. So that is one of the first signs for you that you're dealing with probably a tumor that is either low grade or high grade, depending upon how it appears on the flare images. Now, you will see these findings in T2 also, but what happens in T2, the plain T2 images, is that because the CSF signal is already there, everything looks a little bit bright. And that's where I think the flare images are really important. And the Rapno criteria insists on flare images being done for all patients. And then on the left two panels, you have the diffusion weighted images and the apparent diffusion coefficient. Now, they essentially are giving you the same information, and I'm gonna just focus on the apparent diffusion coefficient images. So what are these images? These are generally measure the restriction of water molecules, the movement of the water molecules. So that is what it is. That's what it means by restricting diffusion. So when you have a very highly cellular tumor, the tumor is very compact. There is not a lot of movement of water molecules between the cells, and highly cellular tumor goes along with high-grade gliomas. And what you're seeing on the apparent diffusion coefficient is that the areas which are highly cellular, they are not allowing they are restricting the diffusion of water molecules, and that's why you're seeing the dark signals there, and that is important. The way I remember, I'm not a radiologist, so the way I remember is apparent diffusion coefficient, ADC, D. D stands for dark, and so your highly cellular tumor is going to appear dark, whereas in the lower bottom, in the lower half, you'll see that the low-grade gliomas, which are not so cellular, nothing is dark, nothing is restricting diffusion there. So it's a loosely placed tumor. There is a free movement of water molecules, and that are not restricting diffusion. So restriction of diffusion goes along with higher grade tumors, highly cellular tumors. Now, there are caveats to this, as I'm sure Dr. Baveja will probably say, but you have to correlate all these images to answer the questions on the previous slide. What images are helpful and how would you differentiate a low grade and high grade on imaging? I think you need to put in all the images together and say, hey, is it enhancing with contrast? Is there peritumoral edema or is there infiltration on the T2 flare? That is again more in favor of a high grade. And then finally, on the ADC map, is it restricting diffusion? Is it when it is restricting diffusion, it suggests a highly cellular tumor or a very compact tumor? So these go in favor of a high grade glioma, whereas the opposite, the converse, goes in favor of a low grade glioma. So any of the trainees who are interested in knowing the basics of radiology that is important for your practice, just refer to these two articles. They are really very well explained, and it'll tell you what are the images you need for differentiating these two as a clinician. So.
Thank you so much. Thank you so much. That was exhaustive and comprehensive both at the same time. So, our surgeon planned for a surgery here and they got an MR tractography with speed study. I wrote all this from the patient's file and was wondering what all is this, and then read about it, that what is neuronavigation, came to know that our hospital has neuronavigation, MR tractography, speed study, all this. We are doing great work, what we are doing. And then I was interested to know Why did they do that? I mean, how does it help in planning the surgery, and does it assist or preclude a GTR? Because the information that I read, to my understanding, I felt that it may actually preclude a GTR and not really assist in GTR. So I've just put some pics for reference, the 6 fasciculars or fibers main that we have in the brain, if you want to comment. Dr. Ajay, yeah.
Yeah. So the most important goal of glioma surgery is maximum safe resection and functional preservation, that is quality survival. So in this case, this tractography is very important tool to make a decision regarding surgical approach and the corridor. So in these cases, we find that there is either infiltration or disruption of tract, or there is displacement of tract. So if there is disruption or infiltration, we consider it to be a sign of to go ahead with more resection. And in case of displacement, we need to be little conservative, and then this will help in GTR, and definitely we need to get tractography along with neuronavigation. And in brain, what happens during surgery, it is a dynamic placement of the lesion, because once a certain amount of lesion is resected, then the position is changed.
Absolutely.
So that is one issue.
Absolutely, sir. So what I tried to see for myself and the residents was that these are various fibers or fasciculars that are seen in the brain, and these are your vertical wala corticospinal fibers, and the enlightened areas that you see are actually the motor areas. So, when you do MR tractography, you can do speech study, make the person speech, and you can actually plot the speech areas or plot the motor areas. Because if you do a GTR with a vegetative patient, it's as good as, not really operating on this patient. You want to have a patient with a quality of life. And this particular image that you see here, so you can see there is a tumor here, and it is actually displacing the fibers posteriorly. So probably in front, the neurosurgeon may want to go a little with a radical, with a radical approach, because there are no fibers that are seen infiltrative or displaced. But posteriorly, the surgeon is going to be very, very careful, and you cannot see these fibers with naked eyes. So you need neuronavigation and MR tractography for the same. Thank you so much, sir. So histopathology, Dr. Anila. There are very less pathologists. So when you describe these images, please make it easy for us. This is the first one that we have. The surgery was done, and this is the slide that we saw. Yeah.
Yeah. Thanks, Maya. Dr. Santosh, hello.
Hi, yes. Good to
Didn't
see you.
want to miss the
Although I can't
chance.
see most of the panelists, it's like, it's a distant, but I
That's okay,
still
sir.
can
You can
recognize
hear
people.
me. So this is the low power of the histopathology slide. What we see in pink and purple, that is called HNE. Yeah, I can focus. And
I can point for you if
yeah,
that's okay.
first one.
Yeah, the first one. Yeah, highly cellular.
This is a very cellular tumor, and there are small spaces in between, which are called the microcysts when we write in our reports. And why it is very cellular? Because normally in brain, the cells are very far apart. And there is a lot of fibrillary matrix in between to separate those cells.
Yeah.
But here, what we see, it's like, there is such a mishmash of so many cells together. So that's why I'm saying it is a very cellular tumor. And in the next slide, what we have put circles on, these are mitosis. This appear like caterpillars. And so the number of mitosis only in one field is 3. So this is enough for me to call it a grade 3 glioma because of the presence of the cellularity as well as the mitosis. So the first stain is, I can't see from here.
67.
Ki-67, which is 60% in the tumor cells. So Ki-67 is a proliferation index, and it is looked in the nucleus of the cell. So the cell has a cytoplasm, and the purple colored thing is the nucleus, and the cytoplasm is pink.
And the KI was very high in this case. The next is, I think,
P53.
P53. And P53 is literally staining all the tumor cells. So it is around 90 to 100% positive. So we write it as P53 mutant or P53 wild type when it is negative.
Yeah, so likely till now it looks like at least a grade 3 one with mitosis,
yeah.
very cellular
see-
P53
Yeah.
mutated.
Yeah.
And this is the IDH, Dr. Neela.
Yeah. And because I'm not seeing microvascular proliferation, I'm not able to call it 4.
Grade 4,
And I
yeah.
don't have necrosis. Otherwise, straight away, I would have called it a grade,
Grade 4,
4
correct.
glioma. So this is IDH, which was negative on IHC, but this is specific for IDH1R132H. So we didn't pick any IDH on IHC.
So it
stain.
looks like it is IDH wild. But
Wild
because
on
we
IHC.
saw that it was cellular, we saw that there were so many mitosis. So we were actually suspecting that could be actually IDH mutant. And we went ahead and did an NGS. And Dr. Neela, here is the NGS.
So what happened when we requested our surgical team to get an NGS done, and they were kind enough, always they get the NGS done whenever we request them to do. So the thing is that though IDH R132H was negative, but the other IDH, I think
IDH2. IDH2.
2 came
Yeah.
positive,
Yeah.
which can be the case because the IHC is not meant to pick up IDH2. It is
Correct.
only there to pick up IDH1.
Correct.
So here I need to emphasize the role of molecular, which is there in brain tumors now. And I think Dr. Santosh will totally agree. All the brain tumors should undergo molecular testing in present times because a lot of low-grade tumor will become high-grade.
Absolutely.
And sometimes I might think it is a high-grade tumor, but molecularly it might
Absolutely.
be a
I think I would reiterate the fact by saying that on NGS, what we picked up was a CDKN2A2B loss. And in addition, and actually, just to specify, even on histology, you see all low-grade features. It is not cellular. You don't see mitosis. Even if it is a low-grade on histology, but you have a CDKN2A2B loss, it becomes straightforward high-grade. You can call it grade 4, even with histology being low-grade. So it is that important if you have a CDKN2A2B loss in the current WHO classification. We also got a methylation study for that, and it was non-methylated.
Dr.
So,
Pal.
Dr. Anila, I saw a report.
Sorry, Dr. Pal, can I ask a question for Dr. Anila, please? Because on the
Yes,
previous
yes,
slide.
yes, please.
So I think
Previous slide.
it's a really good point, Dr. Anila, that I think at least in our setting, we do sequencing on all the patients, but it sometimes financially becomes cumbersome for in LMIC, isn't it? So what prompted you to get the IDH mutation on this patient? Was there something on the histology or
Yeah,
in the
sir. That's
clinical
what
case?
even same question came from Payal. Sir, the tumor was very cellular, and I was not satisfied that it would. I mean, the morphology of the tumor, somehow I thought it should be an IDH mutant tumor. And that just comes with experience. Sir. Don't ask me
Yeah. No. I
how
think it's a good point, right? I think that's what I was wanting to hear because, for us as clinicians, of course, as an oncologist, I feel sometimes I'm just writing chemotherapy and targeted therapies, but the people who are actually making the difference is the surgeon and the radiologist, and of course, most importantly, the pathologist, right? And so for me, it's very important to understand how the pathologist's mind works and what prompted you to get that testing. And I think it's a good point that you're saying that histology, that's what I was trying to highlight. And I'm glad you said that histology and an experienced histopathologist is probably your best friend. For a clinician at least, so that they can direct us to do what investigations we need, especially when it comes to sequencing, because even in our setting, sometimes we can't do all the molecular testing. And so we rely on the pathologist to tell us, hey, what next? What did you see on the histology? And Manas was on the discussion yesterday. I'm not going to prolong this too much, but just to point out, Manas was on one of the discussions yesterday in GAPNO, and that case really highlighted how histology actually is still directing what molecular testing we should use. So that's why I was curious what prompted you to get the IDH mutation. So thank you.
So Dr. Santosh, so Dr. Anila is my new best friend. Yeah.
Plus one more point.
Just hold on. Just hold on to her because the pathologists are always your best friend. They should be your best friend.
So Dr. Anila, another question for you. We have 2 more cases. I really want to finish that as well. CDKN2A2B, I saw a report which said that on fish is negative. How do you infer that? What does CDKN2A2B negative on fish mean?
See, basically, CDKN2AB, we look out for some fusion, like, homozygous deletion in this case, sorry.
Yeah.
I'm confusing with Kia. So you look out for deletion, but it has to be a homozygous deletion. And probably the signals were not seen or whatever. So that is how they interpreted it. And one thing I wanted to add, in pediatric gliomas, usually I ask for NGS. Sir was saying it's not just my histology, but in pediatric gliomas, I think molecular is the answer, because most of them have some molecular alteration which can be targeted. So that's why in pediatric gliomas, I have a hunch towards asking for
Absolutely.
molecular.
So CDKN2A to be on fish is negative, means the deletion is not detected. It doesn't mean that there's a deletion. And Dr. Kriti, as a clinician, I wanted to ask you, if she gives you all this information, CDKN2A, 2B, whatever, what do you do with this information, and is it clinically relevant anywhere? Yeah.
So while I think this high-grade glioma that is not midline in pediatric high-grade glioma is very, very rare. So whatever data is there, it is just basically all the adult data. So
Yeah.
this IDH mutated, CDKN2A, 2B, all of this is just from the adult world. We don't know its implication in pediatrics. I do agree that we do NGS, but what is its implication again in pediatric high-grade gliomas? Not sure. I'd like to phone a friend, so hopefully Dr. Santosh can answer that. But again, we do know that the 2A, 2B deletion confers poor prognosis. So IDH1, 2 typically in adults would mean better, but with CDKN 2A, 2B, homozygous deletion, they will do poorly.
Absolutely. So diffuse astrocytoma with the CDKN2A to be deleted, you can see clear cut that the EFS and OS between the two groups is significant. It is almost dismal if somebody has a CDKN2A to be. Anyways, there's this one question, Dr. Anila or Dr. Santosh, anybody wants to take it. I was just reading a couple of days back about the latest classification, WHO classification of CNS tumors, and I just saw they've done another change. Diffuse grade 4 astrocytomas were actually synonymous with glioblastomas, and now suddenly they have made it different. And they say that you can call it a glioblastoma only if you have a IDH wild type. My question, Dr. Anila or Dr. Santosh, is why was a grade 4 diffuse astrocytoma put separately? Because to me, whether it is glioblastoma or diffuse grade 4 astrocytoma, both have got a poor biology, poor outcome. I understand all these TERT and these mutations are associated with glioblastoma, but both are bad in terms of outcome and biology. So why were they really separated, if you want to take that? Yeah. Can you switch on your mic?
Actually, the thing is, see, most of the astrocytomas, why, first of all, they are called astrocytoma, that I should have an IDH mutation to call it astrocytoma. If I don't have an IDH mutation, I will call it a glioblastoma. Okay. Now, when I say IDH mutation is there, then the clinician and the family, they know that the prognosis is a little better. Okay. And the other thing is there is a target against IDH. So it's better to delineate the two now. It's high time. And the prognosis is better. I mean, I think that Dr. Santosh would be better on this aspect than a GBM in an IDH mutated tumor.
I don't know. Diffuse astrocytoma grade 4 has better prognosis. Dr. Santosh, do you want to comment on this?
Yeah, I think to Dr. Kriti's point, right, these are rare tumors in pediatrics. I mean, the youngest age where you probably see this tumors is probably about 10, 11 years. Even some of the clinical trials for IDH mutated tumors that are now ongoing, they don't even include kids in under 10 years of age. So, so it's a very rare tumor, and a lot of the data is coming from the adult population. Having said that, there are a couple of pediatric focus papers that have come out recently. But again, we are relying a lot on the adult data. You know, I like this patient group of patients called as the AYA, which is the adolescents and the young adults, right? I mean, and there's a big movement towards including them in a lot of the pediatric trials, because some of these tumors tend to overlap. Like so, IDH mutation is one of them. They tend to happen in adolescents more than in young kids and adults. Obviously, IDH mutation, as Dr. Anila pointed out, they tend to have better prognosis. What does better prognosis mean? IDH mutation, if it's IDH mutant astrocytoma, depending upon the histology, whether it's grade 2, 3, or 4, you can have a correspondingly better prognosis with grade 2 astrocytomas. Now, grade 4 astrocytoma, like this patient, even though it's IDH mutated, you really have to wonder whether they have the same good prognosis as the grade 2 or the grade 3s. And the role of CDKN2A and 2B, which are tumor suppressor genes, just like P53, right? And so when they're deleted, it is exactly like my ex-boss, Dr. Amar Gajar, used to say. It's like you're driving on the interstate. We call interstate here, right? you're running, you're driving at 100 miles an hour and your brakes are not working. So you can imagine what happens, right? And so that's what happens with these tumors. When these tumor suppressor genes are deleted, they tend to have really very high proliferative potential. And any of these tumors, when they have CDKN2AB homozygous deletion, they automatically get upgraded to grade 4 astrocytomas, even with IDH mutation, and they tend to have relatively poor prognosis. But somewhere, because these tumors are still so rare, we have not delineated how poor they are as compared to the actual glioblastomas, which are IDH wild type. So there's a lot of things which are evolving, but generally, as this plot says, if there is no CDKN2A alteration, which means the fish does not pick up the CDKN2B deletion, that means your patient at least has a prognosis that is beyond 10 or 15 years. But it is, if the histology, again, going back to the histology, this is one of those tumors where histology matters. So grade 3 and grade 4, even with IDH mutation, tend to have correspondingly poor prognosis, as you have shown in the survival curve in the previous slide.
Thank you. Dr. Kriti had a comment, please.
So I said one, but I have two questions.
Okay.
So
Say two.
in the histopathology, would you then look at the MMR and all of that? Because since it is such a rare case and a high-grade glioma, would we routinely look at it? One. Two, and in this whole chart, because we see epithelioid GBMs more in children, and they are BRAF mutated, which again would mean we have something to target there. Where would that fit in all of this?
See, MMR IHC, though it has been indicated for pediatric tumors, so I have not been doing, so I don't have much of experience of my own to speak of. So I will answer the second question. MMR, maybe Dr. Santosh can answer for me. The second question is epithelioid GBM has a classical epithelioid morphology, and that we pick up because usually the cells are blue in brain tumors, but in an epithelioid GBM, the cells are pink and they have a lot of cytoplasm. So we can make out that they are epithelioid, and then further I do BRAF for that. But one more thing, all said and done, though BRAF doesn't come so commonly in all the brain tumors, but I do run BRAF on my pediatric gliomas, because at least if my BRAF staining is coming, then I have less things to think of. Otherwise I have a plethora of tumors to classify.
Yeah, absolutely. So the final diagnosis was made as grade 4 astrocytoma IDH mutant with CDKN2A2B loss. And we give focal RT 60 grain 30 fractions. We also gave temozolomide for whatever benefit we thought. Treatment was completed in June 2024, kept on regular follow-up with MRI brain, remained disease-free, asymptomatic. TF5 was about 14 months, so about 1 year and 2 months. And now this is the MRI that we have. Dr. Rupinder, quickly, we'll go a little rapid fire now. So what can you see in this particular MRI?
You can see here is a peripherally enhancing lesion appearing in the right side of corpus callosum. This is probably better appreciated on these coronal images. And we have these flare images which show the hyper intensity. As this was out of the radiation field, so we classified it as a next slide. Okay, this was the post-operative gliosis, and also we can appreciate probably there is some enhancement appearing along the region.
Yeah. So importantly, the corpus callosum area where we were suspecting a recurrence is not the area of the primary tumor where we had disease initially. And in the next images, this was actually the post-op area. And there also we saw one enhancing lesion, likely. So this was a recurrence. So neurosurgeons at our team denied the possibility of resurgery without risking significant neurological damage. Child is well preserved, talking, walking, smiling, everything okay and asymptomatic. Key questions for discussion. This is rapid fire, guys, so we'll go a little fast. What to counsel the family? I want to know from Dr. Kriti, who stays in an LMIC, and Dr. Santosh, who's in USA, the perspective that whether this is palliative here and there both. Quickly. Palliative or you think this is curative?
I mean, to begin with, only the survival would have been in, close to 1 to 2 digit, probably less than 20%. But just going back, because we mentioned the RAPNO criteria, it also, does it actually fit the RAPNO criteria for progression? I'm not so sure, but will I offer something? Probably it is a discussion with the family. I don't know if those drugs are available. Probably yes, probably no, depends on that whole situation, economically, socially. Would I want to? Yes, I would want to offer.
Okay. Okay. Dr. Santosh, is this
Yeah,
palliative for you or is this curative? Like
I think
just very briefly.
Yeah. It's we are not in a curative situation here. This is not a curable situation, right?
Not a curable situation.
It's not a curable situation, especially when the relapse is so quickly. Now, you could say there is always going to be outliers who will say, okay, I survived a non-curable cancer, and that's possible. But in general, statistically, this is not a curable cancer. So you're just going to curable situation. So you're going to see how to palliate and improve survival. And I'm going to stick to the chemotherapy question since my name is coming up later as well, so that we are going fast,
Yeah.
right?
Yeah.
You know,
Absolutely.
you could use alkylating agents, but they're all going to be after maybe consideration of a re-radiation. Is there an option for re-radiation? And then could you give something like a CCNU? Bevacizumab is another thing which has been tried in high-grade gliomas. The role of targeted therapy in higher grade IDH mutated astrocytoma is still evolving, but at best you can offer both with vorasidenib. I don't think there's much of data with the PARP inhibitors, but with IDH inhibitor vorasidenib, there is some data that's coming that you can increase the survival maybe by a few months, 6 months to up to a year. But ultimately, I think this is a situation that you have to have the families, you sit down with the family and say, what are your goals of care? I cannot cure your child. I may be able to prolong survival, and that's what the focus has to be on.
Right. I absolutely agree. Can I go back to the slides? The slides? Yeah. So utility of rebiopsy here, like Dr. Kriti mentioned that I don't even know if this is a 2 progression. So what do you have to say about it? So would you want to rebiopsy this? Is this
I
rebiopsyable?
don't think rebiopsy will help the patient because it is intrinsically appearing some enhancement, and basal systems are clear. There is no mass effect, and grade 4 is already diagnosed.
Absolutely, sir. Grade 4 CDK and 2A to be deleted enhancement. We are thinking of recurrence only. Chemotherapy, any role? I think Dr. Santosh took that question. Role of targeted therapy. What do you say about that? Yeah, he covered that as well. Now we come to our radiation perspective. Like we have a Pandora of questions for you, actually. All these questions are for you. So could this be pseudo progression? So diffuse astrocytoma, 1 year of therapy, could this be a pseudo progression? I mean, when do you call this is post radiation pseudo progression?
The recurrence rates in all the gliomas, they are always a query if they're post radiation, because normally pseudoprogression is within 3 to 6 months. But if it is coming after a year, it is stage 4. We already knew it is grade 4. So it has to be a recurrence only, and it is out of the field of radiation.
Absolutely. I think that was an important point. It is out of the field for radiation. Is this a suitable candidate for re-irradiation? TFI is 1 year, 2 months.
I think yes. From my point of view, I'll definitely try because she's 14 years.
14
so
years.
yeah, so she's young adolescent, and plus we can do SRS boost. We can do photon. We can do photon and SRS boost, or we can do a proton also if it is affordable. Definitely, it is expensive, but it's corpus callosal area. It's a small area, tiny area.
Can I just interrupt you and ask you that do they say that proton has more risk of radiation necrosis than photon? I mean, how true is that? Specifically in the brainstem area, that's kind of a lot of data about proton causing more radiation necrosis than photon. Is that true?
Yeah. What happens? The proton, it has a Bragg peak, so it steeps off immediately. So as such, there is no as such role of, because high dose is limited. High dose will be the same for all, whether it's photon or proton. So I don't anticipate that radiation necrosis as per se it increases, but miss can be there because you're not taking much of margins to that. Photon, you take less margins. Same is the case of SRS also. You know, fractionated SRS, or it is stereotactic radiosurgery in single or 2 sessions. So the radionecrosis is a little more as compared to conventional. Photon is like only the Bragg peak is different. Doses we have to decide.
Okay. And recently, European guidelines for neuro-oncology 2025, they have written that for re-irradiation, one may actually do a PET MRI because it can differentiate between the tumor edema, between the...
MRI.
Yeah,
PET
yeah.
MRI is definitely...
What is the role of that? They have put it in guidelines, one must do that. We don't have it here as such, but do you...
We normally do. We have in Apollo, yeah. So what happens, the DOPA PET is like FDG doesn't tell you much. DOPA tells you about it's a high DOPA intense area, so it is a more of progression. So as compared to if it is a recurrence, the DOPA avidity will be less. It's the same like FDG, but the isotope is different. That's the only thing. And plus it is covering the perfusion images also. So the perfusion images will tell about the RCBV and everything. That is just to differentiate between pseudoprogression and a recurrence, and we can delineate that area.
Absolutely. So for pseudoprogression, you want to plan radiation, then all this can be done. But if you're planning nothing, then nothing is needed for this patient. Just one comment that when we are talking pseudoprogression,
You can do it with a routine PET scan itself. You don't need an MRI to do a pseudo progression.
CT?
PET CT. We are doing routinely on top of PET CT.
CT and MRI.
Yeah.
Yeah.
So if
Because
someone doesn't have a PET
CT
MRI, they can just do with a PET CT. You
Yeah,
can do that
CT also.
routinely in adults.
Yeah, Dopa PET CT and MRI perfusion is also a good combination.
Yeah. So just for pseudoprogression, the take-home message is that in low-grade glioma, you may have pseudoprogression even after 1 year up to 18 months. But in high-grade glioma, the cutoff is probably 6 months. After 6 months, you would not really label it pseudoprogression. Again, we've done this questions. Key messages for this patient. T2 flare mismatch sign on MRI is highly specific for IDH mutant grade 2 astrocytoma. They often lack contrast enhancement, notable for grade 3 and grade 4. In suspected cases of IDH mutant astrocytoma, but absent IDHR, one targeted sequencing is indicated to look for non-canonical rare IDH2 mutations, like in our case. Prognosis of grade 4 astrocytoma with homozygous loss of CDK and 2A2B is dismal despite whatever you do. Case 2, we just have 5 minutes. So probably we'll rush through this case. No, we have 5 minutes, ma'am. No, 5 minutes, 5 minutes. So 4-year-old male who presented to us with headache, no other, we'll just go to the images quickly. Dr. Rupinder, you have like 5 seconds.
I think it is similar.
Dr. Pal, what is the duration of symptoms in this case?
Yeah. Duration of symptom is 1 to 2 months. Yeah.
Okay.
Itna hi time tha. Yeah. Okay, so importantly, this is a lesion in the pons, which is causing the pons to expand. So expansile lesion, which is not enhancing on post contrast, right? Okay, so possibilities of surgery in this area, sir, yes or no?
This is involving anterior segment also.
Yeah.
But biopsy is, I think, needed because it is a loose tumor. So biopsy can be.
Absolutely, sir. I think we would want to do biopsy because we want to see what are we dealing with. Absolutely, because I think there was a dictum that in brainstem you have is high-grade gliomas, but that's not true. We know that there are low-grade gliomas in brainstem as well. So neurosurgery team at RGCS said resection was not feasible, and parents actually refused biopsy when they were explained the risk. So it was a midline pontine lesion. Role of liquid biopsy, Dr. Anila. Are we doing it at RGCI? We're not doing. Dr. Santosh, a quick comment on liquid biopsy in this lesion because we
just a
cannot
couple of-
biopsy this. Yeah.
Just a couple of quick comments. I know we are short of time. I couldn't hear all of the panelists speaking for some reason. The sound was not coming through to me. But let me just say quickly something as a clinician. That imaging for me is the big differential is a DIPG. And as you pointed out, if it's not DIPG, is it a lower grade glioma? And that's where the symptom duration is important. If it's not possible that a surgery can be done, which I don't see that possibility happening. But I thought I heard the surgeon say that you can do a biopsy. I think the biopsy is crucial here to get a diagnosis and to confirm if it is a DIPG or not, given the symptomatology is not very clear. Now, it's not always possible to do biopsies, and there are families who will refuse biopsies, and so that's where the liquid biopsy is evolving very quickly. The role of liquid biopsy is still evolving. It is still not standard of care even here. And we do have access. This paper is actually from our University of Michigan, Dr. Koshman, but it lists out all the different papers that have come out. The teams that have really pioneered this is the Memorial Sloan Kettering Hospital in New York. And for DMGs and DIPGs, the sensitivity rate is almost close to 100%. That is, you can pick out all this diagnosis, even if you're not doing a biopsy. So I think we are going to see a lot of this in the future. It is only the question of how you can fine tune the procedure, the highlighted area. The nested PCR is supposedly the best right now, but I think there are people moving towards more like a sequencing of the CSF to see if we can capture all the diagnosis. But it does have a big role in DMG and DIPG, but that role will become clear in the future.
Absolutely. I think Dr. Jalali in Chennai is doing that. Are we doing that TMH, sir, liquid biopsies?
No, no,
But Dr. Jalali, I know, is doing at Chennai liquid biopsies. Yeah. So differentiating from a low grade and high grade things which were favoring low grade was that subtle signs. The child actually didn't have any sign. This child came with mild headache. There was nothing that was visible. It was a well circumscribed. Yes, ma'am. Yeah, okay. So minimal post-contrast enhancement was there, and then MRS, we had to rush through because of 5 seconds. The MRS was actually favoring a low-grade glioma. The findings were exactly opposite. Something that favored high-grade glioma was a minimal post-contrast enhancement and encasement of basilar artery. I just want to show these two images. If you see here, this is the basilar artery, which is not encased, and the tumor is not involving the ventral pons, right? And I just wanted to go back to our images. So if you see here, the basilar artery is encased here, right? And it is involving the entire pons and it's an expensile region. So probably high grade versus low grade. When MRS came, we were a little confused. What are we dealing with? Key questions for discussion. Can the presence, okay, I'm just leaving this. MRS helps in grading the lesion. Dr. Rupinder, yes or no? Yeah, I agree. It is a radiologist's fancy. Actually, there are findings, but it really does not help us. Can the presence of minimal symptoms and MRI picture help us to label it as low grade, sir, Dr. Ajay? It can, it can. So yeah, so MRS and MRI, we were confused whether this is low grade or high grade and how should we manage this case? Dr. Sapna and Dr. Kriti, quickly, do you want to observe? You want to give radiation? You want to combine temozolomide? Refer. Absolutely. Same answer. Refer. Dr. Sapna.
Use pontine glioma, radiation is the standard role of care, and without temozolomide.
Absolutely. So without temozolomide, Dr. Santosh, one quick question. ONC 201, which is like the new chat GPT, which is like the new fashion, which is like the new thing that ONC 201 is something which is going to cure DIPGs. Is that true? And how true is
No,
that?
I think the role is pretty limited.
I don't know. FDA grants accelerated approval to ONC 201 for H3K27 mutant DIPGs. This is August 7, 2025. Comment, sir.
It's a recent
We have
development.
no time.
Yeah, it's a recent development. If you can skip over to the next slide, I think that's where the data is. So it was given approval out of very limited data that's available. And just on the FDA approval is the bar is very low. Anything that increases survival by even by a month, 2 months, 3 months, they will approve it just so that it becomes available for patients in a very devastating disease like DIPG and DMG. But more importantly, there is a randomized study that's going on between post-radiation observation versus post-radiation maintenance on 201. I think that will give us the more definitive data, but it is supposed to improve survival by a few months. That's all it is. It's not curative.
So ONC 201 increases survival only by a few months. I don't know.
You can see the survival curve
this
there.
paper looked like it is like a game changer, but I'm sure it is not. Key messages: children with DIPG and pontine DMG, when presenting with typical imaging and clinical features, can be treated without a biopsy confirmation. However, beware of DIPG mimics and atypical imaging or clinical features, which includes brainstem low-grade glioma that may warrant a biopsy for diagnosis and treatment. Radiation therapy remains the only known treatment that may produce palliation of symptoms, with definitive role of ONC 201, which is still being explored. Liquid biopsy in the form of CSF is emerging as a promising tool for diagnosis of pontine DMG. Infant high-grade gliomas, Dr. Kriti, I've included this on your suggestion. Dr. Kriti is like, इतना depressive बनाया है आपने, पूरा मर जा रहे हैं सारे end में. So infant high-grade gliomas, particularly those in early infancy, they have a very good prognosis. Dr. Santosh was kind enough to share this case that he saw in St. Jude. Sir, do you just want to say
Very
what
quickly.
was it?
I think very quickly, it's an important message, right? As you said, high-grade gliomas tend to have such poor prognosis, and so I should credit Dr. Kriti with just highlighting the importance of infant high-grade gliomas here. Very quickly, infant high-grade gliomas tend to have much better prognosis as compared to older kids with high-grade gliomas. And this is a case of a 5-week-old who came to us from St. Jude, from New York to St. Jude, and essentially was sent home on palliative care, but they came to us for a second opinion. We started the child with conventional chemotherapy, just the standard vincristine, cisplatin, cyclophosphamide with IV methotrexate. And as you'll see, the diagnosis imaging on the left, the second imaging is after 2 cycles of chemotherapy. It's always a partial resection, partial response. The surgeon went in and took the remaining tumor out after the 2 cycles, got almost a complete resection. We consolidated with 4 more cycles of chemotherapy. And when I left a few years ago, she was about 3 years out from diagnosis, and now she is 6 years of age. she's essentially doing well with some mild upper extremity weakness, and the family is just keep sending me pictures every year. So keep in mind, there is a paper from St. Jude which came out recently. I would recommend the trainees read that paper in Neuro-Oncology by Jason Chang and Aditi Bagchi, the two co-first authors. It's a really good paper, and the reason being, next slide, please. Or the previous slide. Next slide.
राहुल 5 सेकंड है, उसमें भी तुमने 5 सेकंड लगा दिया आने में, जल्दी करो.
Okay, basically the reason being that these are not histone-driven tumors, histone-mutated tumors. They are fusion-driven tumors like NTRK and ALK. There it is. Sorry, this slide. Sorry, I should have said previous slide. Sorry about that. ALK and NTRK and ROS. These are the key mutations. And any infant who's in an infant meaning less than 3 years of age, there is a suspicion of high-grade glioma. I think we should do all these mutations. They are receptor tyrosine kinase mutations. And on the left, you will see the survival curve, where they are essentially the infant high grades are having survivals similar to desmoplastic infantile gangliogliomas and desmoplastic infantile astrocytomas, which are just low-grade glioma. So they do have really good prognosis. Do not give up on these patients. Having said that, not all of them are curable, but just have an open mind, even if it's an infant. Just go with an open mind and make a diagnosis and see if you can cure these tumors.
I think that's because they don't have that histone methylation, that H3K27 methylation, and they have different biology with ALK and NTRK, and therefore they really do well. Thank you, and thank you, Gauri ma'am, for allowing all these, to present the. And thank you, my panelists. I think all of you have been amazing to answer in 5 seconds. Yeah, thank you. Dr. Santosh, screen can we have, please? Santosh sir, we are trying to take you in the pic.
I don't know. I haven't done anything. I think it's the tech folks. I'm at their mercy.
Yeah. Can we? He's also here. Can you have Dr. Santosh? He's behind the stage.
From targeted therapies to molecular stratification, the glioma playbook is being rewritten in front of our eyes. For this very insightful talk about the new frontier therapies in the glioma treatment, I would like to welcome Dr. Kanwaljit Kaur as the chairperson for the next talk. Dr. Kanwaljit Kaur. Ma'am is a senior consultant pediatric hematology oncology at ESI Basai Darapur, Delhi. Ma'am, please introduce the speakers.
Hello. Good evening, everybody. So I invite Dr. Vasudev Bhatt. Currently, he is serving as Associate Professor and in charge, Head of Division of Pediatric Hematology Oncology, as well as Deputy Coordinator of the Manipal Comprehensive Cancer Care Center at Kasturba Medical College, Manipal. Dr. Bhatt holds the distinction of being the first in India to be awarded prestigious Neuro-Oncology Fellowship from St. Jude Global. So I welcome Dr. Vasudev.
So, good afternoon, everyone. And at the outset, I would like to thank the organizers for calling me. So I think most of my work is already done in these two sessions, and I will quickly summarize whatever is being discussed. So mostly, yeah, this is the one. Yeah. Yeah, thank you. So we'll be just discussing briefly about gliomas, the PLGG, the high-grade gliomas, some advances, and just to summarize. So as we all know that brain tumors are the most commonest solid tumors that we see in children, and amongst all the solid tumors, gliomas are the most commonest one. So diving straight to the systemic therapy and what has changed. So Dr. Girish presented this slide. So it looks very nice. The overall survival is like 90%, in the reported literature. But again, this is, it depends upon a lot of things. Again, this is discussed in the panel. What modality of treatment is required, again, depends upon what is the age of the child, what is the site, whether it's a posterior fossa, whether it's suprasellar, whether there is any syndrome association, for example, a neurofibromatosis, then you would probably tend to avoid radiation in these patients. What is the general condition of the child? Many times we see this diencephalic syndrome who come in a very bad shape. What is the molecular type? And I will be discussing about this in detail. And our goal always is to prevent the late effects when it comes to brain tumors. And the newer criteria basically look at affordability to therapy as well for the targeted therapy, and again, the quality of life. So again, a few of the slides are the same what Dr. Girish had put, but what I wanted to highlight here is that if you do radiation in low-grade gliomas, the outcomes are as high as 90%, but when you give chemotherapy, probably the event-free survival is about 45 to 50%. And with radiation, there are a lot of side effects that come in, like cerebrovascular accidents, secondary malignancies, endocrine dysfunction, etc. And again, what has changed over the last 20 years is that previously we were giving radiation to those who were slightly older, maybe 5 years of age, and chemo to the younger ones. But now chemotherapy, first line followed by second line, and then delaying RT to as much as possible. And what has changed now is the introduction of targeted therapy. So for some reason, these slides are a bit distorted, probably of the, I don't know, yeah, technology transfer from one device to the other. But there are various options when it comes to giving chemotherapy. So vincristine and carboplatin is the commonest regimen that is used. And the event-free survival, again, is about 50 to 60% in various published literature. You could also do single-agent carboplatin, or you could also do vinblastine as well. There are other protocols like carboplatin, vincristine, and this study has compared it with regimens like carboplatin, vincristine versus thioguanine, procarbazine, lomustine, vincristine. Again, the outcomes are almost ranging between 40 to 50% when it comes to event-free survival. In sick kids, there is this paper published where use of vinblastine in patients with neurofibromatosis type 1 has shown better outcomes in terms of PFS compared to those who did not have NF1. But what chemo has caused, again, is it causes these children to miss school. Families have to stay near the hospital for almost, if you're doing a vincristine carboplatin, almost for a year. And again, this affects the growth and the development of the child. And what has changed is the understanding, the pathology of low-grade gliomas. And we all know that BRAF is the most commonly altered gene in PLGG. Very important to remember, we all know this BRAF-MEK-ERK pathway, but when we say BRAF, sometimes we confuse. What is important to know is that there are two things that happen. So the BRAF KIA1549 fusion or the BRAF V600E mutation. So why this is important to know is that the agents that are used are different. So for understanding, sometimes it is better to use anti-BRAF, which means BRAF V600E agents, anti-BRAF V600E agents, which is dabrafenib, and BRAF fusion inhibitors, which is trametinib. So again, this is just showing the interplay between NF1 and tuberous sclerosis eventually goes through the same pathway. Now, why is this important? And this has been highlighted in the previous two talks. Whenever BRAF V600E is positive, it generally confers a poorer outcome. Again, when we look at BRAF V600E with gross total resection and no gross total resection, whenever gross total resection is possible, the outcomes are better. And again, we discussed about the presence of CDKN2A. If the CDKN2A is deleted, the outcomes are inferior even in a low-grade glioma. So there are various papers which have been published regarding the use of these targeted therapies. So this is one on single agent dabrafenib or vemurafenib, which was used in about 67 patients, of which 56 were low-grade gliomas. And this is a retrospective study. So basically what this showed is that there was a response. So compared to historical data in the V600E, where the OR here is the reduction in the tumor size and the ORR is the overall response rate, it was much better with the BRAF inhibition. That was about 70 and 42% compared to the chemotherapy alone arm. That means that when these agents are used, there is a response which is seen. And this response usually comes in after a particular duration. That means after about 3 months of use. And if you use it for more than 10 months, there is a sustained response which is seen, and the PFS was better when it was used in those more than 10 months. And this is in comparison to chemotherapy only arm. So it was very promising to see that there was a response to these agents, and there was more prospective data which were required. So going ahead, there were studies where BRAF V600E with trametinib as monotherapy or combination was tried. To summarize this, with the combination, the response rate was much better compared to the trametinib alone arm. And this was again in comparison to chemotherapy only. And when it came to the side effect profile, again, the side effects were significantly lower in the combination compared to using the single agent trametinib. So the conclusion of this study in 2022 was that this combination will provide improved efficacy and safety over the MEK inhibitor monotherapy for the BRAF V600E. And then this paper, which was published in 2023 by Dr. Eric Buffet, which is dabrafenib plus trametinib in pediatric glioma with V600E mutation. So why a combination? Already we know that dabrafenib is quite expensive, and then you're combining it with trametinib and you're just increasing the cost. But the thought actually came from patients, adults, where the combination was used, especially in the non-small cell lung carcinomas and advanced melanomas. And the thought there was that the resistance to these BRAF inhibitors will cause a paradoxical reactivation of MAPK pathway. That is why these two agents need to be combined together. So combination will prevent the development of resistance. So in this study, the PFS was significantly better with the combination compared to the chemotherapy alone arm. So the PFS was about 20 months compared to 7.5 months with the chemotherapy. So this is the same compared to the chemotherapy, but what was important was the quality of life. So you can see here that with the combination dabrafenib and trametinib, there was an improvement in the quality of life compared to worsening, which was seen with the chemotherapy alone. So what is this shift that has happened now is with the detection of these mutations or fusions. Uh, the first line therapy probably is, especially for the BRAF V600E, is probably the combination therapy. For the BRAF fusions, again, it depends upon the context, and like we discussed a case where if it is feasible to give and possible affordable, then probably you should consider that. And chemotherapy then could be kept at progression, or again, it depends from patient to patient. And this is a slide which I have borrowed from Dr. Ram Mohan. All these targeted therapy again can cause side effects, but these are generally reversible, and most of the times stopping these medications and reducing the dose can solve the problem. And the toxicities are mainly to do with the skin and the mucosal. So what is the applicability in real world? So if we see for a 30 kg child with BRAF fusion, so trametinib comes to about 45 to 50,000 per month, and we know that it has to be used at least for a 2-year duration. And for a child with a V600E mutation who needs dabrafenib, it's about 1 lakh, and we are not sure how long to give it. So combination would be about 1.5 lakhs per month. And again, we don't know till how long we need to give it. Probably one option in low middle income countries may be to look at whether it is resectable at some time and then try to operate it. So from the low grades, I will move to the high grades, and it is quite disappointing to see the survival curves when it comes to that. But there are some silver linings as well. So here, again, you can see that the outcomes. So this is an integrated molecular meta-analysis of 1,000 odd pediatric high-grade gliomas, including the DIPG. The outcomes again have been below 20% itself. But when we kind of split this into histone and non-histone mutant groups, so all the H3Ks, H3.3 K27 or H3.1 K27 or the G34R, the outcomes have been inferior compared to the BRAF V600D, which is seen in the high-grade gliomas. So you can use a lot of regimens here, like for example, you can come post-surgery and radiation, you can add temozolomide or temozolomide with CCNU, but again, the outcomes have not improved. And whether presence of MGMT methylation improves outcome, what is seen in adults, again, children, it has not been seen. And again, the outcomes remain dismal in this group. What has changed is the identification of certain subtypes which are targetable. And again, based upon the mutation or the histone, there are certain therapies which are available, but whether it is promising or not, only time will tell us. For the H3 mutant, we discussed about ONC201. For IDH mutant, there is vorasidenib, which is available currently. There are certain other mutations, again, like the BRAF V600D, where vemurafenib or the combination can be used. And some PDGFRA and MET amplifications where dasatinib is also being used. So two important points about the PHGG. So one is the BRAF mutated high-grade gliomas. Here, again, the outcomes have been better compared to the other high-grade gliomas, and the median survival 12 months and 24 months have been much better compared to those who do not have these mutations. That is, provided you have started these patients on the combination therapy. There is this doubt whether it can be used in upfront, whether it should be combined with radiation, or it can be just a monotherapy or a combination has to be given. This only time will tell us. These are just phase 2 studies. And the infantile hemispheric PHGG, where we briefly discussed, this is a very important aspect, and I'll take some time because we rushed through in the previous slide. So like Dr. Santosh mentioned, that these are different in nature, and it is predominantly due to the translocations which are seen with ALK, NTRK, and the ROS1. So these again are targetable. And if you have an infant with high-grade glioma features, it is worth to do these and identify these mutations. And these could also be targetable. So we have larotrectinib, which is used for NTRK gene fusion, lorlatinib, which is used for ALK gene rearrangements, entrectinib, which is used for NTRK, ROS1, and ALK mutations. And this is the paper by Aditi Bagchi from St. Jude, which again, she has shown how with the use of lorlatinib, this tumor, the high-grade glioma, actually had resolved. And once it was stopped, there was a recurrence. And again, when these agents were restarted, there was a resolution. So it is promising, but again, it comes at a cost. The second one is the histone mutant one, where again we discussed about the ONC201, which has again shown only a modest improvement in survival in just in days in children, as well as in adults, but it has got FDA approval. There is some data again for the anti-GD2 CAR for the H3K27 diffuse midline gliomas, but again, it has not been promising, and more studies needs to be done in this topic. And the last part I want to highlight about is the replication repair deficiency with the high-grade gliomas. Previously, it was called as a mismatch repair deficiency. It has now been changed into RRD1, that is replication repair deficiency 1, where you have more than 100 mutations per MB and 10 to 100 or 10 to 50. And again, various studies are being done where you just do immune checkpoint inhibitors, or you try doing surgery followed by immune checkpoint inhibitors, or you just do the anti-PD-1 along with the IDH inhibitors, where there is a mutant IDH also present. And this is a paper which is published by Anirban in 2023, which again tells us how can you approach a high-grade glioma in an infant. So you basically test for these mutations where there is a target which may be available. For an older child, you see whether it's a midline or a non-midline, and for the midline, you can just do the H3K27 and just radiation maybe, and no temozolomide for, especially when it comes to a DIPG. The non-midline ones, you can again process and look for these targets. If it is there, like for example, if the V600E, you do find it, then you could consider the targeted therapy post-radiation, and same for the IDH mutants. So just one last slide about the implications and availability. So I briefly mentioned about this. The V600E, the combination, it costs about 1.5 lakhs per month and about 18 lakhs per year, and it is available in India. For the larotrectinib, it's about 60,000 per month, so about 7.5 lakhs, but it is available. ALK fusion again is about 2 lakhs per month, so about 24 lakhs for a duration of 2 years. But these are currently available in India. And like I mentioned, just a slide about the advances in radiation. Nothing much has changed. So proton has kind of helped us to reduce the radiation dose to the developing brain. So like ma'am in the previous panel had mentioned that there is a Bragg-Pitt effect which causes less spillover of the radiation. So definitely it has reduced the late effects probably in these patients. When it comes to the high-grade gliomas, whatever studies are there have shown lesser toxicity, but has not shown any improvement in the event-free survival or the overall survival. So just to summarize, the historically low-grade and high-grade gliomas were managed in a different way. When we see the right-hand side now, it is two distinct entities, and in each entity there are various uh, targets which are available, and the treatment actually depends upon a lot of factors like I had already mentioned. And I think it's important now that we look at these targets and see whether how best we can actually treat these children by providing these targeted therapies. So, and if there are any questions, I'll be happy to take, and I'll take this opportunity to inform you all that FOCON this time is in Manipal. And if you want to see Santosh is in person rather than seeing in the screen, then it is a good opportunity to meet him during the neuro-oncology workshop over here. Thank you.
Thank you, Dr. Vasudev. So any questions from the students, residents at the back? If you don't ask, then I will ask. So, okay.
Please go.
Yeah. So we have heard of BRAF inhibitors, like we are talking since afternoon. So can you tell me what are two types of BRAF inhibitors? BRAF inhibitors, what are the two types and what is the difference? And sir also mentioned it in passing. So for chairing this session, I had to read. So I read, and actually BRAF inhibitors, we talk about so commonly, vemurafenib, dabrafenib. So what it can cause is, it is a type 1 RAF inhibitor. It stabilizes RAF in active conformation so that it doesn't do further damage downstream. When we have this kind of blockage, sometimes they can dimerize, and then once they dimerize, they can still continue the pathway downwards. So this is called as paradoxical pathway activation. So vemurafenib, dabrafenib, and corafenib, these are type 1 BRAF inhibitors, which may have paradoxical pathway activation. You may lose control of the disease after having some initial response. To overcome that, the options are to add MEK inhibitor, which is there at the downstream. So tramatinib would be like we can add it. I mean, this is how I understand it. So as sir mentioned about his case, they had to choose one in the glioma patient, one inhibitor. So they chose MEK inhibitor, tramatinib, because it is further downstream And there is no chance of paradoxical pathway activation because that happens at BRAF level, at a higher level. So, and the cost is also less. The type 2 inhibitor, tovorafenib, is newer molecule which does not require trametinib to be added to it, but it has got more side effects. So that is, I thought I will add to the presentation.
Yeah, yeah. He's
Vasu,
controlling it
can
from
I
the.
make a quick comment?
Yes, yes.
Do we have time? Do we have time?
Yeah, go ahead, go ahead.
Yes, so just and Girish also, I think it's great. This is great, isn't it? I mean, the role of targeted therapies, it's kind of, even here it's just evolving, and I just think that if there is region-specific data that comes out, especially given all the limitations that you have pointed out, Vasu, about the duration and the cost and other things, I think it would be very, very helpful. And so the point that I'm trying to make is that you mentioned maybe during duration doing the dabrafenib or the vemurafenib for a certain amount of time, and then reapproaching and seeing if this tumor is resectable. I don't know how much that is already a practice, but that's really good thought, because then you might be able to reduce the duration of treatment and the cost implications. Granted that a lot of these tumors are in a location that are not maybe surgically resectable, but it's an important consideration that you treat for maybe 6 months or 9 months and see if you can get another resection. Unfortunately, when there is a substantial tumor bulk, when you stop these medications, there is almost always a rebound growth. And you will see that the long-term data that is coming out from these targeted therapies are also quite along the lines of chemotherapy, that by 5 years from stopping treatment or initiation of treatment, you will see that about 50% of them will eventually recur and will need another line of treatment. So I think it's a good point that you brought up, Vasu, that maybe have this treatment for a certain amount of duration, reapproach, and see if it's surgically resectable, and maybe even look at it in a larger clinical trial context. I don't know if you have already discussed about that and other things, but you could look at it in a larger clinical trial context. And just quickly, second point, there are a lot of us who are still not sold on the combination therapy of dabrafenib and trametinib for V600E mutated tumors, because of the same things that you have highlighted, the cost factor and the duration of treatment and the toxicities. But most importantly, I think you had a very good slide in the beginning that the responses with single agents are still quite substantial and comparable to combination. So that is one thing we have not automatically gone and done combination therapies. I have patients who are still using single agent dabrafenib. And the last point, because there are trainees, please remember, as Dr. Vasudev pointed out, there are two different mutations. BRAF V600E is different from the BRAF fusion to the KIA 1549. And while you can use MEK inhibitors like trametinib for any of those tumors, you cannot use BRAF V600E inhibitors like dabrafenib and vemurafenib if that specific mutation is not there. It will cause paradoxical activation and growth of the tumor, at least theoretically. So just keep that in mind. I'll stop.
Okay, Santosh.
Hello, Dr. Santosh, I have a question for you.
Yeah.
So
go ahead.
I didn't realize that you were with us. Sorry, I missed it initially. So I wanted to ask you, is it theoretical that there is a paradoxical pathway activation, because we use vemurafenib for other diseases like LCH and Rosai-Dorfman disease also, who symptomatic patients, or is it theoretical?
Yeah, I think,
how often do you see it?
Right. So because of that possible, so just to clarify, the LCH also has BRAF V600E mutation, right? So that's why dabrafenib or vemurafenib is used in those patients. Just to clarify, what I meant was the paradoxical activation and growth happens if you try to use vemurafenib or dabrafenib in the presence of a BRAF KIA 1549 fusion. So that's not a drug for the BRAF KIA 1549 fusion. It's a specific drug for BRAF V600E mutation. Now, regarding the paradoxical activation, there are two different things here. One, treatment resistance. And when we use BRAF V600E inhibitors for a long time, some of these tumors can become resistant to this drug for some of the mechanisms that has been pointed out, paradoxical activation or drug resistance itself, which is why I think the thought of adding trametinib and saying let's overcome that resistance. This is again still very theoretical. It has not been shown in a clinical trial, and that's why nobody has even attempted to look at that, right? But most of that data, as Vasu pointed out, comes from melanoma studies. Now, melanoma is not the same as low-grade glioma. Melanoma is a much more aggressive disease, and that is why in adults with melanoma, they've all gone to combination of dabrafenib and trametinib. I think in low-grade gliomas, I think we should just have a little bit of a slower approach. I don't think till we have more data to suggest that the combination is better than single agent, we shouldn't, at least I don't feel compelled to do combination. But again, in the last slide, Vasu pointed out about high-grade gliomas. I think there you can make a case that in the presence of high-grade gliomas with BRAF V600E, because the tumors are so aggressive, just go for a combination of dabrafenib and trametinib. I think that's perfectly reasonable. But paradoxical activation, at least it is described in papers, preclinical papers, but not in clinical studies. That has not been shown. But drug resistance, that the tumors start growing back up after a year or 2 years of treatment of dabrafenib or vemurafenib, that is becoming more and more apparent that they could develop drug resistance. But my case is that if that happens, you can always add trametinib at that point, because we still don't know what the long-term toxicities of these agents are. So I hope that answers that question.
Thank you so much. You actually, I guess we thank you a lot for your inputs. We really needed your inputs in the case. Thank you so much.
Thank you, Santosh.
Yep, thank you. Yep. Yes, please register. Come to Manipal. That's my alma mater as well. That's my native town. So please come.
Thank you, Chairperson and speakers. Next, we have a debate about the re-irradiation in gliomas, if it is actually a clever comeback or just a wishful thinking. For that, I would like to call the chairpersons. Dr. I.C. Prem Sagar, sir. He has more than 40 years of experience in brain and spine oncosurgery, currently heading the Department of Neuro and Spine Oncology Services at Rajiv Gandhi Hospital. And Dr. Munish Gairola, sir, with over 30 years of experience, he's the Director of Radiation Oncology Services at Rajiv Gandhi Hospital. So kindly introduce the speakers.
Good afternoon. I welcome you in this very interesting session on, it's a debate actually, and this is on re-radiation in glioma, fruitful versus futile. So in general, re-radiation at any point of time, any site is a really challenging thing, and of course, much more in brain. So without wasting time, I would call Dr. Anjali. Dr. Anjali is a senior consultant at Rajiv Gandhi, and she is in charge for pediatric oncology, radiation side. So she'll be for re-radiation. Dr.
Thank you, sir. Good afternoon, everyone. And I thank the Pediatric Hemato-Oncology Department to give me an opportunity to present my perspective on re-irradiation in pediatric brain tumors. When we were doing our post-graduation, there was, you can say, a general opinion that pediatric brain should not be irradiated. In fact, children used to get operated and the neurosurgeon would just keep the patients on follow-up. So thankfully, we have moved on. We are much beyond that. We are not debating on whether we should irradiate a pediatric brain. Here we are to debate whether we can re-irradiate a pediatric brain or not. And we are going to split it into issues like, can we do it? That is, whether we have physiological and radiological backing to do it. Should we do it? How do we do it? And how can we improve upon it? So just a slide to take you through the basics, the physiology of radiation in brain. Physiologically, we divide the brain into gray matter and white matter. Gray matter is all about cell bodies, and the growth of the gray matter is in the form of a U-shaped curve, peaking around the age of 1 year and then slowly declining across the lifespan. White matter is all myelinated axons, which increase almost linearly through the childhood and adolescence, peaking somewhere in the 20s. So there's a remarkable balance between overproduction and pruning of these cells, which is the core of neurocognitive development and learning. There's a protracted period of production and pruning that leads to neurocognition development. In vivo and in vitro studies have shown that it is oxidative stress caused by radiation that may lead to reduced neuronal proliferation, altered neurogenesis, and neuroinflammation, and eventually leading to something known, it's an umbrella term, neurocognitive late effects, which means a developmental plateau or decline in age expected cognitive development observed as early as 1 year post treatment. Now, re-irradiation, as per EORTC definition, is classified into two types. Type 1 is where a new course of radiation therapy is directed towards a previously irradiated volume. And type 2 irradiation is where the second course of radiation does not overlap with the previous radiation field, but the cumulative dose to the normal structures in the vicinity does raise a concern of toxicity. Now, what supports a radiation oncologist in thinking about re-radiation is that almost 50% recovery may occur within 1 to 2 years after initial treatment if the doses to the normal structures have been kept below their tolerance limit, or at least till the tolerance limit. And second, very important aspect is that it is not just radiation that leads to neurocognitive sequelae. It is the direct impact of the tumor, hydrocephalus and shunt revisions, posterior fossa syndrome, prolonged absence from school, and psychosocial changes or background that also affect the neurocognition in a child. So we have ample evidence in specific case scenarios. There were a plethora of studies that have been published since 2012. To begin with, these studies had a mixed cohort of patients, small number of patients, some with a short follow-up, some with a longer follow-up. Then there was an attempt to divide the cohort into two groups: diffuse intrinsic pontine glioma group and the non-DIPG group. And it was seen that re-irradiation in a non-DIPG cohort can give us a survival benefit of nearly 50%. Coming to specific tumor groups, some of the most important ones are ependymoma and medulloblastoma. So, a number of studies have been published. We are not going to give much importance to the number of patients because brain tumors in general have a good prognosis. So we cannot expect large number of children relapsing and coming for irradiation. So the number of patients is going to remain small. However, one study published in 2017 had 101 patients, and the risk of radionecrosis after re-irradiation for ependymoma was found to be around 8% only. The conclusion of all these studies has been that local treatment with maximal surgical resection and adjuvant radiotherapy offers cure even in relapse setting. There is benefit in both overall survival as well as disease-free survival. The aim of our re-irradiation should be to reach a dose more than 45 grays. It is better if we plan the child with craniospinal irradiation in a relapsed ependymoma. We all know that in the first course of treatment for ependymoma, we give only focal treatment, unless CSF is positive for malignant cells. But in the setting of a relapse, CSI gives better overall survival and relapse-free survival when we are re-irradiating. The most recent study on ependymoma has shown a 70% 1-year survival and 48% at 3 years. Of course, it also showed that without surgery, the survivals can still be dismal. So maximal safe resection should be done before taking up for re-irradiation. These Swedish work group guidelines will be popping up after every group of tumors that I show. The stress is not on showing you the guidelines. Here we are not here to discuss the guidelines, but this is just to show you that how even re-radiation is not an abstract idea anymore. It is gaining the status of a standard of care, and how guidelines are being worked out to establish a uniformity and in its how we plan it and how we report it. Stereotaxy can also be attempted, and in fact, there is a phase 2 clinical trial going on. They are, according to the results of this phase 2 trial, we should try not to give more than 115 cumulative dose to the entire brain. Medulloblastoma is again a group of tumors which can be considered for irradiation. A good group of patients who are suitable candidates for irradiation are those with limited tumor burden and patients who have been treated for a low or standard risk medulloblastoma. Children who have sonic hedgehog pathway positive medulloblastoma, or the recurrences after a treatment for high risk medulloblastoma, may not benefit much from re-radiation. So again, here we have to select wisely. Intracranial germinomas are highly radiosensitive, and it has been shown that the cohort that received craniospinal irradiation in the relapse setting did much better than those who did not receive CSI or did not receive radiation at all. So again, this is the Swedish work group guidelines on intracranial germinomas. Diffuse intrinsic pontine glioma, not a very gratifying condition, and re-radiation here largely plays a palliative role, may increase survival by few months. There's a case report here on 3 patients where one of the patients could achieve a survival of about 2 years by getting radiation 3 times. But it was largely a palliative measure. The organs at risk which are defined, which we really need to be careful about when treating a child with re-radiation, are brainstem and spinal cord. Cerebellum has also been, it is being implicated in neurocognition.
Dr. Anjali,
Yes, sir.
time is,
Yes, sir.
is only 10 minutes. Huh?
So,
Sorry.
though we do not have any dose constraints for cerebellum, but we try to keep the dose as less as possible. A general checklist for deciding volume, dose fractionation for re-radiation are age of the child, toxicity after prior radiotherapy, and time between 2 courses of radiation. So what I am trying to stress upon at the end of all this is that just relegating re-radiation to a no-no for a pediatric age group is not the right way to go. We should document what we are doing, document, follow up, and document the late effects, if any. And only then we will improve upon our technique as well as the selection criteria. So re-radiation has become an increasingly considered treatment option, made possible by advances in precision and technology and high tumor localization. However, it requires a careful consideration to balance efficacy with the potential risk of side effects. Thank you.
Thank you, Dr. Anjali. And now we invite Dr. Indu Bansal. She is a Group Director and Head of Department Radiation Oncology at Paras Hospital, Gurugram, with over 25 years of experience. And I know her because she has organized ISNO 2 years back.
Yes.
So welcome, madam.
Thank you.
So you are talking against the irradiation in these tumors.
Okay.
So you need to rebut whatever she has said.
Yes. So before I begin my talk, let me start with a sad story. A 12-year-old girl who was diagnosed with pilocytic astrocytoma underwent subtotal resection and received vinblastine-based chemotherapy. But unfortunately, 5 years later, she recurred and she received radiation with nothing but proton treatment, 52.2 gray, She had improvement in imaging and she had good radiographic local control. But unfortunately, even after 8 years, the child continues to have challenges with headaches, visual and auditory concerns. She had stroke like symptoms, and she could not pursue her higher education. With this background, sorry. इसमें कहाँ से होता है? अच्छा, वहाँ से, I'm sorry. Yeah. So with this background, I will now start my talk on re-radiation for pediatric brain tumors. Is it actually fruitful, as my worthy colleague Dr. Anjali just said, or is it futile? Please remember, I'm not here to debate. I am here to give the best treatment to all my patients, and I want just my patients to win. So we know that the survival of brain tumor patients, of pediatric patients, has improved. And overall, 5-year overall survival is around 60% and even up to the tune of 80%. And 10, even the 20 years, we have good 20-year survivors also. But is that the same for recurrent brain tumors? So the patients with low-grade tumors, medulloblastomas, ependymiomas, and non-malignant tumors, they will survive longer. And these are the patients I'm concerned about, because whatever you might do for high-grade gliomas, that is, they are very difficult to salvage. Now, till earlier, we used to extrapolate everything from adult patients till these Pentec guidelines came in. And even from them, they said that cure rates of pediatric cancers has improved to 80%. But note that still age gap between survivors and age-matched controls is 9 years. So we need to understand the debilitating and sometimes fatal adverse effects of therapy, which is responsible for this gap. In North American childhood cancer survivors study, the 30-year cumulative mortality for 5-year survivors was 18%. And please note that those who received radiation had more than twofold increased risk of mortality versus the patients who did not receive radiation. And overall, 60 to 90% of childhood survivors will develop one or more chronic health conditions. 20 to 80% will experience severe or life-threatening complications from treatment. So I want everyone in the audience to please be very careful when we are deciding for re-radiation. And as said before, it has to be an MDT decision. So why is the role of radiation in pediatric tumors? Because in most cases of residual, recurrent, or unresectable disease, we know that systemic therapy is not curative, and it is mainly used as a radiotherapy deferral strategy. Although I know that an avoid radiotherapy until absolutely necessary strategy may not serve all the patients well, because radiation cannot reverse the pre-existing toxicity deficits which have incurred due to prolonged chemotherapy which has been given for a long time. But at the same time, I don't want my patients to survive and keep on carrying the load of the toxicities of treatment given. So, what are the non-nuisance toxicities of radiation? I think we keep on talking in all the meetings, which were not at all talked about by Dr. Anjali in the previous talk. So, just to mention a few, these patients have retardation of neurocognitive functions. They have impairment of social adjustment, neuroendocrine disorders, growth impairment, musculoskeletal hypoplasia. They develop acoustic disturbances, endocrine dysfunctions, vascular disorders, second cancers, and it leads to poor quality of life. And it leads to most of the patients being unmarried, disabled, unemployed, or they are just left to their caregivers. And mind you, these things are still mentioned in the papers. But what is not mentioned, that is what I want to point out here. What are the issues of a cancer survivor? They always have fatigue. They have a loss of a physical part. They need to take time off from appointments. They have difficulty thinking, remembering things. They have financial stress. And these people, even if they get a job, they are left out of decision-making opportunities. They are being demoted, overlooked for new positions, and they have difficulty in coping with co-workers. So even if they survive, they are living a very bad quality of life. So till date, we did not have anything to talk about re-radiation till this beautiful paper came in, which was mentioned by Dr. Anjali also. So now we have to decide whether we are giving a type 1 radiation, type 2 radiation, is it a repeat organ radiation or it is a repeat radiation? So I think we have to be very clear in our minds what does all these terms mean. For this, you have to read the papers. And also these papers say that if you are doing re-radiation, please document all this. So there are at least 50 points which have to be documented. But tell me, my dear friends, is it possible to do it routinely? How many of us can do it in our routine clinics? It may be possible in US, but not in India, I think. Now, following this paper, 2023 Astro Education paper, this came in. And by 2000 to 2020, there were 493 papers which were addressing re-radiation. But out of these, only 15% were prospective. There were no randomized trials. The variability in reporting was significant. There was lack of established reporting standards. So this was me, after searching the net, looking for one quality paper which talked about re-radiation. So do we have sufficient data for re-radiation? So the paper numbers have gone up, but the problem is, or in none of these papers there is, or I would say in all the papers, there is limited understanding of radiobiological effects in re-radiation. Papers don't talk about fraction size effects. They don't talk about normal tissue tolerances. What is the actual time to an extent of normal tissue delivery? How can we identify beforehand which patients will respond to radiation, which patients will respond to systemic treatment? There is lack of accompanying tissue or blood sampling. So there is limited translational work being done, and you never get any funding for re-radiation trials. You get a lot for targeted drugs, but not for re-radiation. And whole of the radiation is based on calculations of alpha and beta. But we don't know whether to use alpha beta value of 2 or 3 while calculating these doses. So, फिर मुझे बड़ी खुशी हुई. I got at least one paper, re-radiation in pediatric tumors, and these were the Swedish guidelines. So this group was established in 2002. It consisted of 1 to 3 radiation oncologists from 6 centers in Sweden. They meet only twice a year, but they do weekly meetings, okay? But the interesting part was, in pediatric brain tumors, the guidelines get published without talking a word about toxicity. Are we talking about pediatric brain tumor patients? I'm really surprised with this. So I'm at all not happy about the rest of the brain tumors. And in fact, they said that the data on re-radiation are not fully matured, and it is finding very difficult to find reliable cumulative dose constraints. So, and they talked only about 4 things: brainstem glioma, ependymoma, germinomas, medulloblastoma. बाकी ट्यूमर का क्या करें, इनको भी नहीं पता, हमें भी नहीं पता. And they did not talk about toxicities. But still we are very happy, चलो कुछ तो है. So now, after implementing those guidelines, one more paper was published. It was a very good paper. It was a very good paper because it has 31 patients. So I said, chalo, theek hai. Median follow-up after re-radiation was 8.5 months. Median overall survival was 11.4 months. But can you believe it? In these 31 patients, only 9 patients were of re-radiation. So, and these were the outcomes presented. So on this side, you can see the 31 patients who had varying dose schedules, and they were mixed together. And on that side, there were 9 patients of re-radiation, just में CSI भी included था. So I don't know how to interpret this paper. So there is a lot of noise. Definitely there is a lot of noise, but that's just noise. There is no evidence till date, till re-radiation. So what are the issues with re-radiation studies? One is the data is retrospective and heterogeneous, very limited number of patients. These studies are subject to selection bias. There are conflicting reports of efficacy and toxicities, inconsistent approaches to planning, evaluation, and reporting. There are a lot of image registration uncertainties, so we don't know whether we are treating a radiation necrosis or treating a tumor. And there is a post-ad hoc approach to summation of cumulative doses, and there is no spatial dose cumulation. Apart from that, we don't know how to calculate the doses because earlier they were handwritten, hand-based calculations. So we don't know where to calculate, what to calculate. The calculations are done on a single reference point, and we assume that the dose is going to a uniform area. The dose estimates outside the field penumbra, they are different, and they are extrapolating IMRT to 3D CRT to proton. I don't know how to do that. And they are not adding toxicities of FSRS or radiobiologicals, and there is no mention about patient-specific genetic predispositions. So ideally, whenever we are doing summations, what we are doing is that we calculate the D maximum dose of the organ at risk from the previous radiation and how much dose will it get now. And the people in the radiation would understand that we do EQD2 calculations and BD, but we don't know exactly point by point कि आप एक के ऊपर एक रख दो कि exactly कितना dose कहाँ पे जा रहा है, that we don't know. So there is this paper Strider support tool for re-RT decisions. which calculates per voxel biological dose summation. So till that is done, I would not be very comfortable to give re-radiation. So in 2018, there was this editorial, the re-radiation, a last hope, but with greatly feared consequences. And my colleague also talked about this study of 100 patients from Sang et al. Definitely there was an improvement. Radiation necrosis risk 8%. But if you see about this paper on DIPG, 85 patients, 7 countries. So of course there would be different planning criteria and everything. And in that paper, 67 patients, a lot of heterogeneous patients, so I don't know how to interpret these data. Now, there is some data for re-radiation for brain tumors, but this is from adults. But are the pediatric patients the same as adults? Are they the miniature versions of adults? I'm sorry, they are not, because pediatric disease is a complex disease. Their vulnerability to damage is far greater than adults. The sensitivity to RT injury directly correlates to the developmental dynamics and maturational status of each organ. So dose and volume dependence on specific areas of brain as hippocampus dose, temporal lobe, white matter necrosis, we have to look into all those factors. Now, no meeting of brain tumor can be concluded without mention about protons, because वही हमारा fancy thing on the block है. So this study, which talked about cognitive sparing with protons versus photons. So what they did smartly, from 2000 to 2007, from the older techniques from photons, they were compared with newer techniques of protons and took patients from 2007 to 2013. 10 patients protons, 12 patients photons, they were compared. I don't know whether that's a fair comparison or not. And they said that protons are definitely better. But even in this study, overall survival was not different. So these are the different proton studies which also have their own side effects. And these are after one first radiation. Patients have pseudo-progression, they have developmental abnormalities, they have Moya-Moya syndrome. अब मैंने सोचा भैया ये मोया मोया है क्या? This is
Dr.
something.
Can you wind up, please?
Finding two slides more. So actually, all the pediatric brain patients, they develop a lot of cerebrovascular complications, stroke, and the incidence is 29 times high. And in fact, even after proton treatment, the full-scale IQ drops down by 1.5 times points per year, and it keeps on dropping. And the cumulative incidence of neuroendocrine deficits at 5 years was 55%. मुझे नहीं चाहिए अपना कोई पेशेंट आमिर खान की तरह ऐसे घूमे. I don't want any of my patients to become an Amir Khan. And apart from that, there are brainstem toxicities. So at the distal end of the Bragg peak, the brainstem toxicity is much more with protons. And we are using protons mainly for medulloblastoma and ependymoma, where the tumor is located in the posterior fossa, where there is the maximum, variation. So the pooled risk of grade 1 to 5 toxicity was 10.6%, and for proton treatment, the brainstem doses have actually been reduced. So we have to be very careful when we are treating such patients. Now, the last thing, stereotaxy. My able friend talked about it. So 37 patients, 2 to 24 years, mixed bag, mainly ependymoma and medulloblastoma. So the interesting thing was the 2-year cumulative incidence of local failure after re-radiation was 12.8%, but cumulative incidence of distant failure was 25.3%. So patients were not failing locally, they were failing distally. So what are we gaining by adding radiation? So I think these patients should rather get targeted treatments. So these are the horror stories of the patients, So on the left side, what the patient says, on the right side, what their caregivers say. The patient would say, I get fatigued, I had suicidal thoughts, I don't get any job, and they are always in the fear of whether I'll get a job, when will the disease recur. And the parents on the other side say that patient has my child has a frequent school absences. People don't know when they see him how to talk to him, so they just disappear. And there is always this uncertainty how long my child will live, and the workplace doesn't want to hire them. So what are actually we giving to these patients? So are we just burying them under the hope that we'll give them a good survival? I'm really not happy about that. So now, thankfully, we have very good medical oncologist friends and a lot of targeted drugs we talked about in the previous section. So I think any patient with pediatric tumors should have a molecular profiling, and depending on that, on the areas where you specifically feel re-radiation would help, like hypothalamic pituitary areas, thalamus areas, or the tumors which are close to the optic nerve, where you feel that the vision may go whichever chemotherapy or radiation or chemotherapy or targeted drug you might give, it's not going to help. Or the patients can't afford targeted treatment because of the cost is too high or it's a prolonged treatment. Those are the specific group of patients where I would really be keen, although I'm a very, radiant radiation oncologist, but still, this is one area where I'm very sorry, but I have to say that please go to my medical oncology colleague and take the treatment from there. So let us not make these by giving them treatment. Let us not make our patients nalayak, but give them strength, let them survive, and let them nail it in whichever area they go to, and let's treat them with tender care. So I just pause to recognize those children who succumb to cancer and to express gratitude to those fortunate to have survived while retaining a childlike enthusiasm for living despite the burden of malignancy. I rest my case. Thank you.
Thank you, Dr. Indu.
Thank
Very vibrant talk.
Thank you.
You know, if you see as a radiation oncologist, there we are talking about re-radiation in a very select group of the patient. Like you said, DIPG. DIPG, if there is a recurrence, the median survival is only 3-4 months. And if it is progressing, and if you give re-radiation, you can do it for 8-9 months, and that too symptom-free. And that is the idea of giving re-irradiation. And here we can always give re-irradiation. We can always re-irradiate. Likewise, diffuse midline glioma, very localized high-grade glioma, or sometimes, as you said, the pilocytic astrocytoma, though whenever there is a pilocytic kind of a astrocytoma, we even don't irradiate. We always say if there is a recurrence, we again send to the neurosurgeon for the surgery. So there is a specific group, a specific subset where it's a viable option. We cannot refute completely that re-irradiation has a no role in pediatric oncology.
Definitely. Now the debate is over. Now I can say all these things. So definitely radiation has a role in India because a lot of patients cannot afford targeted treatments. We don't have testing criteria. And the chemotherapy is also prolonged treatment. So specifically for DIPGs or high-grade gliomas or these areas where tumors in the thalamic location close to optic pathways, these are the areas where I would be happy to give. But of course, it has to be an MDT decision.
Thank you. Dr. Santosh, are you here?
Yeah, I'm here. It's a very interesting
so
debate. Yeah.
In the University of Michigan, what is your,
Yeah, so
how do you go ahead in these children?
Okay. So yeah, very quickly. I know we are past the time. Very quickly. So I trained in with Dr. Tom Merchant at St. Jude. So he's one of the really international expert in radiation and re-radiation. I just have very quickly 2 comments. Right. One, re-radiation in general, as everyone has pointed out, there is a selected role for re-radiation in brain tumors, and the most of the data comes from ependymomas. Ependymoma re-radiation does have a curative role, especially in patients who relapse metastatically after the initial radiation. And these are patients considered to be maybe radiosensitive because there has been local control and they relapse metastatically. Now, all of them cannot be cured, as we all know. And so that is one area in relapsed ependymomas where we strongly push for re-radiation. But for most other patients, I think it's largely palliative, especially the glioma patients, the high-grade glioma patients. I don't think a lot of the low-grade glioma patients ever undergo re-radiation. It's the high-grade glioma patients. As you have rightly pointed out, it is more palliation of symptoms, whether it's DIPG or other high-grade gliomas, with a careful consideration, as both the debaters have said, that you have to be mindful of what acute toxicities these patients can develop. Sometimes we have used bevacizumab preemptively to treat these patients, but there is more data coming out for re-radiation. And as Dr. Anjali pointed out, which by the way, I'm seeing Dr. Anjali after 20 years. She was alongside me in Manipal, so it's great to see her after such a long time. Which as she pointed out, now people are actually talking about re-radiation. So 3 times radiation for high-grade gliomas. So it's an evolving field. I think at the end of the day, we all should have an open mind about who these patients can go. And as everyone said, we also do a multidisciplinary tumor board discussion about it and then send the patients for re-radiation or not. So yeah.
In fact, my rebuttal slide had this very point that now we are talking about third time radiation in brain tumors. We have a study from Tata Memorial that has been published recently.
So the only point that I would like to say that if we have to re-radiate, it should preferably be done in the same center because you get exactly the isodosis and everything. Yeah.
Absolutely. Fully agree.
Thank you.
Thank you very much. Thank you. Okay. See, whenever there is Dr. Santosh, are you there?
Yes, I'm here. Yep.
So I was working in Detroit Medical Center long years back, and there Dr. Alexa Kennedy, you remember her?
Yes.
She used to operate in such cases when there is a problem, and then if it is feasible and it is indicated, and if it can help, then surgery is always a consideration. Because that does not have, of course, it has morbidity along with it, but it has no long-term side effects. So
Correct.
what is your idea about it?
Yeah, correct. I think, the role of surgery, especially, I think we can think about ependymoma, right? Ependymoma is one diagnosis where re-resection at relapse and then go for radiation. I think if it's possible, most of the time we send these patients for a repeat resection. And like it was pointed out earlier, extent of resection is very prognostic in these patients. So yes, if it's relapse ependymoma, if the neurosurgery team feels that they can get a resection, we always send them for repeat resection and then go for re-radiation. That has the best outcomes. Not all patients can go for re-radiation, but in generally with high-grade gliomas and of course with DIPGs, we don't send these patients for re-radiation because at that point it is mostly palliation of symptoms or prolonging survival. So the question comes, is there any benefit in putting them through significantly high-risk surgery? Although sometimes you can, if they are symptomatic and the surgeon feels they can get it out, always it's possible. But the incidence of putting patients on high grade glioma for re-resection is much lower than in ependymoma. And very rarely medulloblastomas who relapse late, they sometimes can undergo re-radiation, but again the outcomes of re-radiation in medulloblastoma is also quite poor. But that is another group of patients we potentially would consider repeat resection. But the one standout population where repeat resection and re-radiation is feasible and should be considered is ependymomas. Yeah.
Now with the advent of so many adjuncts in neurosurgery, like the tactography, the monitoring, and all the intraoperative ultrasound, MRI, so now the quality of life even after surgery is not that bad. So previously people used to say that even in high-grade glioma after primary, so even also in Delhi, I mean, they operate first time, next time they say, no, please go to your bed, and I mean, you don't require any sort of treatment. But we at Rajiv Gandhi Hospital, we do re-operation many times. We do not refuse any patients, depending upon the indication and whether we can really operate and give a good life.
Yeah. Yeah, completely
Thank you
agree.
very
I think
much.
it's ultimately at that point, it is the quality of life, right? Especially for
Yes.
high grades. I think that is the area that obviously is most debated probably, but
Right.
exactly. I agree with you. I think if it's a case of palliation, producing a good quality of life, and if extent of resection is going to help those patients, and as a neurosurgeon, if you're comfortable doing it, then absolutely yes. I think we would always consider that. That or rebiopsy to look for any additional targetable alterations, because some of these high-grade gliomas pick up new mutations at relapse, and so rebiopsy or a repeat resection and sequencing is something worth considering. Yeah.
Thank you, Dr. Santosh.
Thank you. Thank you.
Thank you so much, sir. That brings the session to a close. And I thank all the speakers, the chairpersons, and the expert for the session for such an impactful and such an insightful session. And also, I would like to use this opportunity to thank Santosh, sir, who has agreed to be with us at the VRs in the morning. Thank you so much, sir. We look forward to welcome you in person soon and continue this process of learning together. Thank you.
No, thank you. Thanks for having me on. And early morning is always much better than for me than late night. So this is totally fine. Thank you. Yes.
That brings us to the final session of the day. And this session focuses on neuroblastoma, the most common extracranial solid tumor in children, the tumor that never ceases to surprise us. Its biology is fascinating and its treatment is challenging, demanding a delicate balance between aggressive therapy and long-term quality of life. This session will walk us through the surgical findings, futuristic techniques, and immunotherapy breakthroughs. And to lead this session, I would like to welcome the expert who brings not just clinical experience but deep academic insight into today's theme, Dr. Sajid Qureshi. Sir is professor and convener of pediatric surgical oncology at Tata Memorial Hospital, Mumbai. He has authored in-depth studies on outcomes and complications in neuroblastoma surgery, bringing with him both surgical precision and academic insight to the table. Welcome, sir. For the first talk, surgery is central to neuroblastoma. And in surgery, the eternal question that always remain is how much is enough? For that, we have the first talk that is, I'm calling, balancing the radical resection with long-term risk. And for that, the chairperson will be Dr. A.K. Diwan. Sir is one of the leading oncologists and director of the surgical oncology with over 40 years of experience at Rajiv Gandhi Cancer Hospital, and Dr. Devendra K. Yadav. Sir is additional professor, Department of Pediatric Surgery at AIIMS, Delhi. Welcome, sir. Well, the first talk is by the expert only, so may I please request Dr. Sajid Qureshi, sir, to be on stage. Thank you, sir.
टाइम पहले मैंने डॉक्टर शालिनी से पूछा कि I don't know Dr. Sajid, how do I introduce, how do I know? He said, don't worry, he's the only actor, he's the only director, and whole program will be shadowed by him. So here we have Dr. Sajid Qureshi with us, and he's going to talk about very important topic, neuroblastoma. And I've only seen Dr. Shalini operating neuroblastomas in OT and how she struggles for such a long time. Over to you.
Thank you, sir. Thank you for the kind words. The key words are here only, neuroblastoma and GTR. GTR is gross total resection. The talk is focused on this. Let's focus on this disease. I promise you I'll not talk about the NMIC or the Wnt, hedgehog and all those big words. I'll stick to the basics. So the key words are here. And neuroblastoma is somewhat a surgeon's, you can say a playground, or it can be a nightmare also. So, and there are high expectations, especially by our colleagues, to perform well in neuroblastoma, because this is a disease which is really challenging to treat medically also, and challenging to treat surgically also. There are concerns, but we all are aware about neuroblastomas. Now, certain things about neuroblastomas. In India, we have a large burden of disease, additional comorbidities like malnutrition, delayed presentation, and the last one is very common. The disease was unresectable, so we gave on chemotherapy for 1 year, 2 year. That's very common phenomena what we see. So inappropriate or sometime incomplete treatment is the norm usually. Now the keywords, the gross total resection. By gross total resection, we mean that logically, just common sense, that you have removed the tumor completely, complete macroscopic excision. Now, usually this is for neuroblastoma is a problem. So people have scaled down to, if you remove more than 95% of the disease, again, it is a gross total resection. Some have gone beyond that. We can say 90% of removal is also a gross total resection. But the problem with this is very surgeon centric, in the sense surgeon felt that this is so, so that's why it is so. There is no checkpoint on this. We don't do routine post-op imaging to verify what the surgeon is saying is actually truth. He doesn't lie, but there may be an error in assessment. There is some pocket of disease on the contralateral side. So it may be a genuine error, not a false communication. Like the neurosurgeon, next they do an MRI to confirm whether that is a completeness of resection. We are overwhelmed by the treatment of neuroblastoma. So many things are already going on that we don't feel that there is an immediate need for imaging to verify the surgeon. Now, is this GTR? Is this a myth or a reality? Now, there are problems with neuroblastomas. There are several sites. It's not a disease confined to the kidney or a solid organ. There is the sympathetic chain from the neck to the pelvis. So there are multiple sites. We know there are complex spatial relations. This tumor has a special affinity for blood vessels. The surgical guidelines are not well defined, and you cannot say that one person is doing so the other person also should do a GTR. There is a variation in surgical skill. You cannot complain that you are not skilled enough, you should be doing more than what you have done. So these are the problems with GTR. The surgeons were well aware in the INS surgical staging, there is a role of extent of resection. But this was again were not reproducible. That's why they came up with the extent of resection of less than 50, more than 50, complete resection, 90% resection, so on and so forth. To ease on this, we had the INRG system wherein they made it L1 and L2. So yes, non-surgeon are also well aware that this is resectable or this is unresectable based on the presence of something called as the IDRF. Now, this is humanly not possible to remember each and every IDRF of all sites. What we can do is just narrow it down to 4 basic types: encasing vessels, going intraspinally, infiltrating into structures like the porta, or compressing the airway. Examples: this is an example of vascular encasement. This celiac and the superior mesenteric are floating in that. Infiltration of the porta here, that's an example of infiltrative. This is the intraspinal extension. It is less than 1/3 of the canal. So this is not an IDRF. It has to be more than 1/3 of the canal. Then you say this is an IDRF. Airway, any amount of airway compression is an IDRF. And the nutshell was this INR GSS classification system. Now, we are fascinated by this thing and we say that INR GSS has come and it has changed everything. No, this is not meant for treatment decider. No, this was never planned. This was a retrospective study of 8,000 patients. They didn't knew what they have to do and they came up with this algorithm. But this is what we are doing is we follow this and this is how it should be treated. If you see retrospect, the people who have made this, they have not made a single study based on the findings of this. They still use the INSS. So we are very much flattered, or we are very much with the West because they are coming up with data. But actually, what does that mean? Does this ease that this make your surgery simple? No. That does this make the BMT not required? Does this make the immunotherapy required? No. We are just fascinated by the data without knowing what is the implication of that. This is a very nice chart. No neuroblastoma presentation in the country goes without this chart. This is so much in vogue now. Now, what does this mean now? L1 disease, operate. L2 disease, don't operate because IDRF are there and then you should give chemotherapy. There are certain situations where surgery is still required. Now, what has happened with the description of IDRF? There have been a lot more studies. People are now so much fascinated. They are going retrospectively, identifying the data, and they are correlating with IDRF, correlation with the resection. It is common sense. If there are IDRF, resection will be incomplete. Complication. Obviously, there will be complication if the resection is complex. IDRF changes with chemotherapy or not, those studies are there. And then finally, IDRF and outcome. So in short, IDRF is something, not a magical thing which will change your management. It does not mean the surgery has to be avoided in presence of IDRF. This is meant to help, not replace the surgical staging, which is still the gold standard. Now, not always we operate. We have instances where we can very well keep the children in observation. That's the situation. This is a tumor resection surgery. This is an abdominal compartment syndrome for stage 4 MS to decompress the abdomen. We haven't touched the tumor at all. We just did a laparoscopy and a bag, just decompress the abdomen. Once the condition improve, we put the mesh and close the abdomen. No surgery for the primary, but surgery for the complication, which was the abdominal compartment syndrome. Now, coming to the extent of resection, we have the risk stratification, low and intermediate. There is evidence to say that you should not be very radical. You can leave behind some disease. That means incomplete resection is fine. And we have our own data to say that yes, especially in the intermediate risk neuroblastoma, incomplete resection is fine, does not affect the outcome. But if you do incomplete resection, the complications will be less. That's not the case. Incomplete resection, if done properly, also carries a risk of complication. Then this is the biggest question what people ask about the high-risk disease. This is a bad disease, and theoretically speaking, we should take care of all the disease because logically outcomes will be good. That's what the thinking is, that you have to remove the tumor completely. Now, same time, you have to remember, see, surgeons are not magical figures. They have to work through complex areas. There are issues. I'll tell you the issues also. It is the safety. There's no point in doing a fantastic operation and the patient not making it. So you have to balance all this thing. There is always an ego issue. Yes, I'm the surgeon. I can remove it, or I have to remove it. Otherwise, the people will say, "Harry, he's incomplete resection care." No, the ego has to be outside the door. The patient's safety is more important. Any amount of data giving you importance of complete excision and outcome, there are equal number of data saying that, both from PSYOP and COG, that complete resection is associated with good outcome. At the same time, there is equal number of data which says that complete resection or incomplete resection does not make a difference. I'm not showing you a single slide of that because it's just an argument, never ending argument. What we decide, what we do is surgery which should be safe, surgery which should be helpful to the children. There is no ego issue here. If it is possible for you to do a complete excision, that should always be the goal. But a safe excision is always the goal. Now, these are the problems we face. Abdominal large tumors. This is a child who was 4-year-old. Suddenly he presented during the treatment with tumor bleed. That black area, entire thing is all tumor bleed. The liver is gone. There is contralateral nodes also. Now, this is a situation which defies everything. Now you have to take a call. Your angiography is not working. It's a life and death situation. You have to undergo surgery. This is a large tumor. We just use common sense. Here, large tumor, larger incision, 2-compartment incision, thoracoabdominal approach. That's the tumor what we see, and that is the end of resection. This is the defect. This child has gone on to become a MBBS doctor now. He is 25-year-old now. And it's very touching to have a situation like this where just logic was used that yes, a resection is required in this situation. We have used this approach for many of our cases, and this is an excellent approach if someone, the surgeon who want to try this. Now, again, one more example after post chemotherapy, that's the disease everywhere. The bumps, what you're seeing, the grayish bump everywhere, somewhere in between is the aorta and the IVC. Now, we go ahead with the resection and we get a picture like this. This is a very heartening picture for the surgeon. A surgeon seeing this, he can skip his dinner or lunch, whatever. So this is what we get. And this is something for the specimen, for the pathologist. So many things, so many lymph nodes distributed everywhere. Remember, neuroblastoma, here we differ from the adult. Neuroblastoma is not an in toto excision, not possible. If you're planning for a in toto resection, you are in a wrong job only. It has to be a resection which should be complete, but you should not shy away from bisecting, trisecting, or whatever doing the tumor. Because if you want to achieve a in toto, you have to receive the aorta, IVC, vertebra, and so on and so forth. Not possible. In the end, you have pictures like this. Now, if you place the vessel somewhere, it's the vessels like this, the IVC and the aorta. Now, you can imagine how much work, how much dissection is required. These are very important structures. IVC and aorta, a small breach in children, and you may land up with big issues. There is extensive lymph node dissection. We have a problem of chyle leak. We have found that this can be managed with conservative means only, and there is no added morbidity to this. You can go ahead with your planned treatment. This is part and parcel of neuroblastoma surgery. This, I would say, not a complication. You're removing the lymph node, you're removing the lymphatic. Where will the lymphatic go? Into the abdominal cavity. So chyle leak is bound to be there. We have stopped putting drains now. So whatever is there, chyle get absorbed in the body. Now, again, one issue with the GTR. You're getting this nice picture, celiac, SMA, inferior mesenteric artery, aorta, kidney, renal vein. There is a renal artery here. You see this? That's an apparent renal artery. That's a renal artery to the lower pole. We are just concerned that where there is one renal artery, there is one renal vein, and you dissect that and job is over. No. And you can see the problem. This kidney has become little bluish. That's because there is spasm. So we have to be very careful. Despite the most carefulness, you land up with issues like this. And there may be difficult situation. Have you heard this thing? A tumor stealing the kidney? That's very common. In neuroblastoma, after a good surgery, extensive dissection, saving the kidney, the renal vessel was totally encased. But after 1 year or even 6 months, you find the kidney small, 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 and then disappear, as if the neuroblastoma has eaten up the kidney. Autonephrectomy. This is, nobody talks about it, but yes, this is a situation. And this is what? Due to our efforts of GTR. We are trying to do something good, but eventually what is happening? We are getting a lost kidney. Large tumors like this, very difficult to achieve a GTR. The entire root mesentery is involved. You do something here, you lose the bowel, a short bowel segment, the entire purpose of your surgery is gone. Entire neuroblastoma thing is gone. And very aggressive surgery, very rarely we encounter this thing, very rare aggressive surgery, you may land up with this. The aorta is absolutely shattered and you have to put a graft. Small child, artificial thing, what will happen when he'll grow? Will this graft grow? We don't know the answers. So this is again a challenging area. The more you do, the more you may have a problem and you don't know what will happen eventually. Everything because we want to achieve a GTR, because this is said that neuroblastoma GTR is essential. I'm not telling that it is no. I'm just trying to explain you what is the problem with a GTR. Please understand the surgeon, what is their concern. We'll quickly move on to the mediastinal side, mediastinal neuroblastomas. They come in all sizes, the small, the medium, the large, and obviously we have the extra larges also. And these are tumors which have intraspinal extension only. These are tumors in the costophrenic area, the Nausebara show. You remember that? 9, 10, 11, 12. So level vertebral 9 to 12, the Nausebara show is a very critical area. It is one of the IDRF. You know, the artery of Adamkiewicz is there. Any surgery here in this area carries a risk of paraplegia because of spinal ischemia. We have tumor bang in this area. We don't know what to do. We have to take all precaution, get a picture like this to achieve GTR. Now, a very difficult situation. The clips, what we are seeing, those are the posterior intercostal arteries. The spinal artery is one of the branch of this posterior intercostal artery. I have ligated 4 artery. Artery of Adamkiewicz is there or not? I don't know. That's the problem. That GTR, and I'm gifting the patient a paraplegia. So that's a concern with this. Large tumor in a confined space, big tumor, entire thoracic cavity, weird incision. We have to take a T incision, a sternotomy, and a TT incision has been taken to remove this large tumor. Thoracic duct, a very, very troubling personality. Whenever you see it during surgery, kill it. You just ligate it, because this is a injury or even exposure to this can cause chylothorax, which is more difficult to manage than the primary tumor. So whenever you see it, just kill it. Intraspinal extension, it's very tempting just to yank the tumor out and cause paraplegia again. In that also, we avoid doing aggressive surgery. We follow restraint, And if it is a low intermediate risk, we just transect, leave that disease inside. No point in removing all visible neuroblastoma cells, gifting the patient a neurological complication. If we do surgery, that's a problem. Now, this is not a complete resection. This was an incomplete resection. This is a known feature of a scoliosis after any surgery in the costovertebral region. Several reasons are there: post of fibrosis, vascularity is gone, complete or incomplete removal. I'll give you a different counterpart to this. This child has never undergone surgery. This was only observation. And in between, she got lost to follow up. This is observation. So you do, there is a problem. You don't do, there is a problem. What led to the problem, we don't know. We have to be ready. Yes, this is part and part. Not always, this is part and parcel of our patient. Cervical neuroblastoma, supposed to be very good prognosis, but for surgeon, it is a picture like this. The carotid artery is somewhere floating here, the airway is gone, so on and so forth. This is a very fascinating area. I love this area. And when you dissect well, you get pictures like this: the carotid, the IJV, the hypoglossal nerve, the loop, and all these things. It's possible to save everything. There are problem here. Pharyngeal plexus may be involved, and you may get temporary swallowing difficulty. The cervicothoracic region, the vertebral artery is the main dangerous area. We use different approaches. Go to the area, dissect the vessel. That's the vertebral artery which has been dissected. Trapdoor incision, large tumor, we can use a trapdoor. Why it is trapdoor? See, this is the trapdoor. It just opens the entire thing and the entire tumor is visible. Easy to remove, easy to close also. And this is the problem with most of the cervical. Can anyone tell what's the problem with the child? This patient has undergone a cervicothoracic neuroblastoma syndrome, which is not a complication. It's a sequelae. Horner syndrome is not a complication. If you don't get an Horner syndrome after a cervical neuroblastoma, I will doubt you have done a good surgery or not. You have probably not done a surgery for neuroblastoma. You have just removed the node. Horner syndrome, it is not a complication. It's a sequelae, part and parcel of the disease. Many a times the wound heal well, but you have situation where there is hypertrophic scarring. We have situation where there is non-union and all sorts of things are there, all at the cost of achieving GTR. We have published our result with the outcome of and complication of neuroblastoma surgery. Thank you very much. I think I've said enough. I'll take questions if there are any.
Thank you, sir. Once again, nice to hear you again. I think as a surgeon, whenever is feasible, go for the excision without any compromise. But as you said very rightly, especially in cases of suprarenal neuroblastoma engulfing all the renal vessels. And at the initial presentation, if you are so sure that only renal vessels is involved and rest of the tumor can be removed and patient is in high risk group, try to preserve, don't try to preserve that kidney only. It may be problematic in the bone marrow transplantation, but ultimately, if you are achieving total gross excision or sometimes as a COG protocol, complete macroscopic excision, that will be helpful. But otherwise, what will be happen with the time you will left that tumor, ultimately that kidney will go. So if possible, if you are so sure that apart from this, you can remove all this tumor, certainly you will go ahead. And I think for the mediastinal and paraspinal neuroblastoma with the involvement of spinal area, try to treat with the proper chemotherapy. Most of our patients with the intraspinal extension first responded very well to the chemotherapy, very well to the chemotherapy. And if possible, don't touch that spinal part. Otherwise, with help of chemotherapy and near total excision, the child may be good. But if we will try to remove that intraspinal part, ultimately we will land to the other, much major problem of paraparesis. Okay. Thank you, sir.
Yeah. So it boils down, basically it boils down after the chemotherapy. Be very liberal. Chemotherapy is most important thing. Any day I'll be happy with a child with a post-chemo situation than the pre-chemo status. The common argument is that chemotherapy induces fibrosis, make it more unresectable, make it more difficult. I take that to an advantage. The fibrosis really helps in the dissection, especially the perivascular dissection. So never be in a hurry, right? You rightly said, for a upfront resection, take the help of chemotherapy, and then you can go ahead and use your logic, use your common sense about the safety of the procedure and the extent of the procedure. Thank you.
So for our next talk, the topic is 3D printing in neuroblastoma, game changer or a gimmick. Technology is increasingly complementing surgical oncology, and 3D printing allows surgeon to visualize and plan complex resections with precision. But does it really change the game in complex neuroblastoma resections, or is it more of a flashy gimmick? And to chair this session, we have Dr. A.K. Devan with us, Dr. Abhishek Singh, consultant head and neck oncosurgery at RGCIRC, and Dr. A.K. Devendra also. I will do. And the speakers for this session would be Dr. Anjan Kumar Dua, Additional Professor, Department of Pediatric Surgery at AIIMS Delhi, and Dr. Shalini Mishra, Pediatric Surgical Oncologist. What stands out the most about Dr. Shalini is the blend of skill and heart she brings to each case, treating every child as if they were her own. We welcome the speakers.
Thank you. Starting from where Dr. Qureshi left, I'll take you to another world where we are really working on the bench, not in the OR, and try to showcase some technological advancements which can help you plan exactly your surgery, how to go about. Is it really resectable in first place or not? Till now, we were discussing everything in 2D pixels. CT MRI comes in 2D plane, and there we are really playing with the pixels. But here we will take you to another world where we would be playing with voxels, or it would be a 3D environment, and then we would see how it has helped us or where do we stand. Giving examples from different other conditions, not necessarily neuroblastoma, and then at the end, Dr. Shalini would take us through some of the case vignettes where it has really changed the way we have been seeing resection of pediatric oncological cases. So Dr. Shalini wanted me to take how to go ahead. Like the arrow is not working. Right. Okay, fine. So I'll take you through a few of the soft areas, the softwares, the hardwares, because that will give you a glimpse of how to go about, how to get a roadmap, and how to ultimately get a model out of which you can then derive and take a decision whether to go ahead, how to go ahead, whether it is going to help in your day-to-day practice, is it going to help in your patient counseling, or even as a teaching model. So these are the areas which I'll touch upon. Starting with the basics of 3D printing, it's just an additive method of getting a model. So there are two ways. Carving out something out of an already existing raw material is called subtractive. Here it is additive. Here we add a layer, essentially thermoplastic, which melts in high temperature, and then a layer of the model first is created and further layers are added over it. So that's how it works. Hardware can be a variety of hardwares, but predominantly and the most used model is the FDM, is a fused deposition model. Here we have a printing head, which works around, which melts the filament, and then there's a stage upon which the model starts getting deposited one layer over the other. So something like this, where at the end of the process, you have your 3D model in hand. Don't have to know all those, but yes, so we have now ability to have polygets which create a very colorful multiple colors feeding into the model, and you have a colored end product at the end of the process. This softwares are very important. Here there are basically three types of software. The first software is called the segmentation software. So we know the dicoms. Dicoms are basically stacks of JPEGs. They're stacked, and as they have been captured in three sections, and from that, how to create a voxel is the job of the segmentation software. I use this 3D slicer, which is an open source software and developed by the NIH. Then plus or minus, we can use a CAD software which will further edit it or refine it. And the final software gives direction to the printer how exactly to print. So taking you through, the first job is to basically segment our area. Segment means to define our region of interest, because as you know, an axial scan of an abdomen will have so many other organs, but we are here looking at only the tumor, maybe the blood vessels also, and its neighboring structures, because that is where we would be possibly causing collateral damage, and we want to also have that in our 3D model. So that defining that is the role of the surgeon, who is the end product, end user of the product. So he has to sit down with the radiologist, define, annotate the file, and then the software do the rest of it. It's a very labor intensive, easy for bone structures to be constructed or defined. But for us, neuroblastoma being a soft tissue tumor, sometimes the edges are very fuzzy, and that can create problems. Now AI is emerging. I'll show you how it helps. I'm not going through the details of this, just to show that how three sections that we take normally. The blue area is the stage where your final 3D orientation or rendering is happening. So we have an axial section, we have a coronal and the sagittal. Here you can see how it is being initially screened through. And once we are happy with this, we would order the rendering part, where these JPEGs, which are stacked one above the other and by the side, they would be rendered into a 3D, obviously on a virtual in a virtual world. And then we get the end product of this. This is called the STL file. I'm skipping this part. The STL file is the end product of segmentation. So from a pixel, we have now a voxel. This is very interesting. This is how the segmentation would look like as you go through. Here, a liver has been segmented. You can have the vessels also segmented. Here we have add-on, there's a plugin available which can be added onto that 3D slicer software, which will do the segmentation in one go. You possibly do here, you may not need another surgeon by the side of the radiologist can very well do it. Otherwise, this AI is trained enough to do the segmentation itself just by the click of a mouse. Here you can see there is a liver tumor, and by click of a mouse, it has been trained with the background algorithm, how it would do the segmentation. The blue is the liver, and there is a lesion or a metastasis sitting over there. Everything has been done with this click of a mouse. Add-on facility, of course, there are other facilities. I'm not going to them. Volumetry is often needed for cases like hepatoblastoma and so on. So at the end of this file, you will have a file like this, which will have a lot of defects or free floating areas. These are called the defects, and you need to clean them up, noise basically. So STL with a noise is the end result of your segmentation, the first software. So we need some kind of a software. I use this mesh mixture where it would be done manually, but manually again is a very tedious process. You have to basically click them one by one and then delete them. But yes, the software has an inbuilt mechanism to do the automatic analysis. The inspection is done. It will give you the number of defects. Here there were quite thousands of them. And then auto repair would take care of those floating elements, and then you would denoise it. At the end of the procedure, you will have something like this. You can run the auto repair multiple times till you are happy with the output. So next, the last step in the software, the last software that will be used is called the slicer software. So here, basically, after having the STL in your hand, the STL would not be directly used by a printer. A 3D printer uses a G code file, which carries all the necessary elements like the movements, the bed temperature, the temperature of the head of the printer. All those are fed into through these softwares. Anything can be used. But ultimately, what you are looking at is the G code file from the STL file. So here, that same model which I had used earlier, this is a model which I used in one of our patients with cloaca or in fact anorectal malformations, we wanted to see the effect of how do we recreate these images into 3D. So here you can see on the right, you have all the elements, you can change, tweak them as needed. And the end of the STL file gets converted to a G code file. So yes, the ultimate workflow, if you see, I'll show you here multiple ways to get the STL file, but what we commonly in neuroblastoma, we would use this from CT or MRI. We get the STL file generated. From there, we get a CAD software to further refine it and ultimately a proper G code conversion. So as far as all the papers are concerned, at the end of the day, how do we actually prove that it has helped or not? So we do have something tangible in our hand as a roadmap, but most of the papers deal with elements like whether it has helped us in decision making, planning the surgery, to go in at the first resectability. They have talked about using it in surgical education and training. And of course, we have now patient specific implants in craniofacial surgeries. We have also used it in our setting in pectus excavatum. Now, there's a condition where we have ready-made implants, but not necessarily they will fit into kits which would come in various shapes. So here we have used templates to 3D printed templates, which can be then used to have a steel or the molybdenum alloy steel to have the exact replica of the kind of implants that are needed. We have also used in chest wall, there's an Ewing sarcoma, a group of tumor from the chest wall, where it helped us in deciding whether should we go ahead just like that or we need something to provide support after excision. Now the papers, if you say as far as neuroblastoma is concerned, it's very nascent, just evolving. In fact, all those 4 papers I could, there's one more, I just left it because it was more of a MIBG, the role of MIBG and 3D modeling. So if we have to see over the surgical, the role in surgical resection, they are scattered, only case series to the best of these are the best. The best one was the scientific report published in a Nature group of journal. But the key takeaway is that at the end of the summary is that the 3D models definitely they help, and they help in planning, and they help us in boosting the understanding the way we have to approach the anatomy, and that is how it goes. Now, of course, the last sentence you would see 3D virtual printed models. Now, what are these 3D virtual models? This is important because as you can see, just like we have the BMT, like we have MDT style management decision making, here also we need stakeholders of all 3 kinds. Surgery, the surgeon should be the lead, and then we have the radiologist to put in the efforts, and of course the biomedical engineer. When they put in their efforts, possibly the best 3D model would be in our hand. But at the other hand, we are talking only about the good things. What are the cons about it? The cost I'm not talking about, because the cost is variable starting from 30,000 and above. Because if we want a 1:1 scale, it starts something around 25,000 with the cheapest raw material, and then it goes up. There are challenges, as I had told. The soft tissue segmentation is the most difficult and the most time-taking procedure. The vessel definition, they are also very time-taking to define. The tumor boundary is already explained. So basically, the time it takes can delay your procedure. At the end of the day, if we have a urgent case to take up, possibly 3D printing is not the answer. So what should be the path? Possibly 3D reconstruction, where we don't end up having the print in our hand, but yes, we have a 3D recon, which we can use it. We can perform virtual surgery upon it. It can again gets recreated. We can approach it in another way and do a surgical virtual surgery. And more about it, I think Dr. Shalini would be taking up with the case vignettes, where she would showcase the role of virtual 3D reconstruction in surgery. Thank you. Can take up questions at the end or even now? At the end, yeah. Yeah. Thank you. Yeah.
So thank you, Anjan, for explaining everything so lucidly. It is all very complex for me. I only go sit with the engineer, and my job is to make sure that he is understanding what I want. So first I sit with the radiologist, and then I go and sit with the engineer and show him which is the artery, which is the vein, and where's the tumor. Of course, he knows it, but I need to sometimes help him, especially with children. So I'll just show. Yes, it is distorted. It is distorted. Once he called me up and says, I don't know where the tumor is. Where's the tumor? I can't see the tumor. So then we need that input. Again, before I proceed with this, we've just done a few cases, so I'll just show you a few videos, very brief ones. It's very important to do a good CT angio or even an MR. I think we are not yet, I'm not yet used to MR, reading the MR, so I prefer CT angio. And in a child, when we're doing a CT angio, there are two prerequisites. One is that you must sedate the child, and because if there should be any movement artifacts, it will be very difficult to understand. And secondly, what I have noticed is we use a little larger bore cannula, that is a 22 gauge at least, not 24. Because when they do the CT angio, the contrast goes in quickly, and with a 24 gauge cannula, it will not go in. And so you say you did under sedation, but still you can't see the artery properly. Where's the tumor? Where's the branch? We're not able to visualize it. So that's important. Here, इसका music off कर दोगे? This is a 5-month-old infant with respiratory distress, and you can see this is like neuroblastoma. इसका he's doing it now. हाँ हो गया अब हो गया. Right. So this is a thoracic annulate kind of a neuroblastoma, quite a large tumor. So obviously we gave the Yeah. So we gave neoadjuvant chemotherapy, and the problem was that it was L2 tumor encasing the subclavian artery. And the challenge that we were facing is how to approach this tumor, just like Dr. Sajid talked about, whether I need to do a cervicothoracic incision or how do I approach this tumor. Otherwise, it was an intermediate risk tumor. So after 4 cycles of chemo, it did respond. As you can see, the size has decreased in size, but still the subclavian artery was encased around 180 degrees, a little bit, approximately 180 degrees. So we decided to try out the 3D printing virtual image, and that really helped me to plan my surgery, and I think it definitely decreased the duration of my surgery. And finally, we realized, so this is one of the first few ones, so you can understand what the problem is that, the engineer has marked everything red, even the veins he has marked red. So next time I did definitely helped to change it, which is artery, which is a vein. So you can see that subclavian artery is actually just in contact, and it was going on the surface of the tumor, and there was some space there. So I was able to approach it through say a third intercostal space anterior thoracotomy, and we was able to take it out completely, which I'll show you very briefly. So you can actually even take out the layers and look at the, here we have removed the ribs. We want to see the exact anatomy of the vessels and the tumor. And especially in renal tumors, we can take out even the kidney can become transparent, and you can look at the pelvic alicil system. So here we see it was, because of post-chemo, it was quite well encapsulated. And I was able to separate out the subclavian artery. And because, it's a small child and the whole hand is involved, and we didn't want to take any risks. So here you can see at the lower end, that is the subclavian artery, which I'm pointing out with my dissector, and I was able to separate out the whole thing slowly. And this child obviously had a Horner syndrome post-op, and but it has improved slowly over the last 6 months. We followed him up, and no further chemo was given. I will just move forward to the next one. And this is another one with a ganglioneuroblastoma in the retroperitoneum. She's a 3-year-old child. I'm sorry. She's a 3-year-old child, and this was a very interesting patient because she was worked up for PUJ obstruction, and found that there was actually a tumor which was causing the hydronephrosis. And again, it was encasing the IVC and also the right renal vessels. Because it was L2, we gave chemotherapy, but it hardly responded. That's what happens in ganglioneuroblastomas. They don't respond too much, but it is again intermediate risk. And so post chemotherapy, again, we did the 3D virtual model, and that again helped me in during the surgery. So again, as Anjan was saying, it is a subjective thing that I am able to visualize it. Otherwise, what happens is I sit with the radiologist at least for 1 hour the day of the surgery or one day before to look at the tumor in different planes and give all the 3D reconstructions. So this is the 3D virtual model for that child, and you can see that the IVC was really draped over and it was adherent over there. I had to separate it out very carefully. The challenging part was we could not trace the right ureter, neither on the image nor on this 3D model. And when I show you the intra pictures, you will realize why it was like that, because actually the ureter was kinked and it was anterior to it was looping over the whole tumor. And so it was probably not getting opacified. So here you can see that the kidneys have been become made transparent, and we can look at all the pelvic calyceal system and everything. And the artery was kind of safe here, but the IVC and the renal vein was encased. It's just a quick, I think, 30 seconds. So you can see the ureter over there. Ureter is draped over there. You can see the movement also. And that's why we could not visualize it on any of the imaging, but I was able to separate it out. IVC was difficult to separate, but yes, patiently did the dissection. So always the veins are much more difficult to do the gross-total resection and the subadventitial resection when we are working around the IVC. There you can see that's the IVC. And so it's important to tape it above and before. I don't know why there's some tremor in the video. So, and then separate out the rest of it, get good control proximally and distally. And finally, we were able to resect this whole tumor, and this child also has been followed up, and as the whole tumor has been removed. And you can see that the anatomy is bare there, the ureter, the kidney, and that's the IVC. And this is just some tissue glue that I always spray after I do this kind of a resection, so that it helps me for the chyle leak, preventing the chyle leak. And just two more small videos. This one is okay, it's not working. Doesn't matter. This one was actually a rhabdomyosarcoma, and the patient came all the way from Kashmir to get surgery done here. And I actually used this model to explain to the father that the common iliac artery was bifurcating inside the tumor. So it was very difficult to, if it was neuroblastoma, I would have done the surgery, but in a rhabdomyosarcoma, we would not prefer to do R1 resection or transect the tumor. So I finally convinced them to go for definitive radiotherapy. And that was very useful for me. This is not neuroblastoma, but a very neuroblastoma-like picture. This is another challenging case. This is a horseshoe kidney in which the anatomy was so complex, and this 3D model really helped us to understand this horseshoe kidney and where the tumor was. The WIMS tumor was in the right moiety, and we could visualize the pelvic calyceal system, and also usually they have more than one arteries, and there were two arteries on the left side, which they were able to save. The right moiety vessels were going through the tumor, which again, you can see the tumor has been made transparent over there. And these are the vessels which we could save on the left moiety. And this is not my patient, but I helped another junior colleague to get this 3D printing, and subsequently they operated, and the child has done well. Thank you so much, and we'll be happy to take any questions. Although it's just the beginning, I think we need to always break all our boundaries and try to do some strive and do something more than what we do. Dr. Abhishek, would you like to, because this is where I just went with one of my surgical oncology residents whose thesis was on the SCAD-CAM mandible. So I went to see the lab, and then I realized I can actually use it for virtual printing for my patients. And they're doing a lot of work in head and neck, so I just want Dr. Abhishek to tell us about it.
Very good evening. So we've been using CAD-CAM for mandibular reconstruction for maxilla as well. So we've done about 30 odd cases. So not only does it help you in planning, it helps you in any anatomical variations. For example, if you have a peroneum magna for the fibula, so with the CT angio, you know beforehand that probably it's a single vessel So you might not be able to harvest the fibula from there. The accuracy of mapping the fibula and getting the contour for the mandible again is a very good tool for that, because the more accuracy you have, the rehabilitation in the future for dental rehab also is impacted on the contour that you give for the mandible. So we are routinely doing the CT angio, like ma'am said. CT angio is a must. A good quality CT angio is needed. So you have a minimum thickness in our hospital. We can get a thickness of 0.6 mm. That's the best. So the basic requirement for any bony 3D reconstruction is 1 mm. So the finer the cuts, the more accuracy you will have, the lesser noise distortion you will have when you do the 3D mapping of that. And again, with the MRI now, with the coming in with MRI, you can define the tumor. So if the tumor is going to the bone, you want a live model. Again, it all depends on the costing. So a basic model will cost you somewhere around about 20 to 30,000 with the planning, with the guides, the surgical guides, as well as the planning itself and the printing. So what we do is for the mandible as well as the fibula, we get these models printed. So these are the reconstructed models as well as the cutting guides which we use in the surgery. So our cuts are predefined. So you have to be very thorough with the radiology, your bony extent, your soft tissue definition, both, because sometimes it can happen that your soft tissue tumor is going beyond the bone. So your bony margin might get compromised if you're not catering that into the picture. So keeping all these factors into the picture, if you can plan, also again, it gives you a very good advantage of doing a mock surgery on the patient.
Yeah.
You're operating on the patient using the models.
So for complex tumors like
Yes.
horseshoe kidney or bilateral Wilms tumor, I actually use in the bilateral Wilms tumor also. We can actually do a mock surgery the previous day, and that could with in silico model, so that we could do. Unfortunately, for implants, children, because we can't cater to their growth, so we cannot print the implants until they have completed their growth. So
But
I
ma'am,
think
they
it
will
take
be
some
helpful
time.
in the later stage when they come in that point.
Right.
So that, yeah.
Thank you so much. Mike,
There's some role also in NSS for planning.
Yes.
NSS where
So that's why I said bilateral Wilms tumor, NSS. I had some videos also, but because of time, it is really helpful. It just gives you a very good clarity of thought before you go in for the surgery.
Pardon my ignorance, Shalini.
Yes.
I have not used this thing. Now, what you're doing is you're telling that I take the tumor in my hand, the model in my hand, and I do the planning. I don't take the tumor in my hand.
So this is virtual, sir.
Yeah.
This is only virtual. Huh?
No, the point I'm trying to make is that I do this on a screen. You decide that this is the area I need to cut. You have a model, you cut and you enter. I do that on the screen. Unless you tell me that your way is better than this or your way adds some benefit to this, the feel good is fine. Yes, something which is there in 2D, now we are seeing in 3D in front of eyes. Yes, it is something rightly toys for the boys and the girls. So well, I want why this thing is better or how this has changed, because you have to convince people that
So
yes,
Anjan
this is
said
good.
that we don't have any clear-cut evidence. I don't know. I'm just thinking maybe I can map my duration of surgery and see if it is. Obviously, it cannot be done randomized or anything like that. Maybe the previous ones and now. Yeah, Anjan.
all surgeons are like doctors are like. Well, what you do is you do 3D printing in your brain, which cannot
Everybody cannot do that, sir. That's true.
transfer. It cannot be shown to a resident how exactly you're going to approach.
Yeah.
So that kind of a situation probably where it comes to help, and of course it takes more time than how much you take time to remove. 3D printing takes definitely at least 15 to 20 hours if only the
Yes.
only the 3D model is concerned.
Yeah.
Days, 3 days.
3 days, yeah. The annotations, they have to do it manually.
But for
Rest of us.
models, I
Yeah.
think it has a role to play.
Very well said, Anjan.
Yeah. And it looks like 3D only.
But this is better than that.
Annotate the colors, you can add, give it, look it much more real.
I feel it's better than that. They do it. Our radiologists do that all the time. But this is one step ahead. Yeah.
In fact, all the 3D models that we have generated, 90% of the effort was of our radiologists.
Yes, yes,
And
definitely.
now I have taken up because sometimes it becomes difficult to catch in. So I do a lot of the annotations and the other thing. But yes, the machines, the softwares, they already have these facility of having.
You said that probably you are doing that now, but the model. Moment we see again.
Yes, of course.
Section in our.
So that's why we always discuss radiology with you. We come to your console and discuss before we do a complicated surgery. That gives us a lot of help in the surgery next day. Thank you.
I think the now with the AI time and most of the time we are making more intelligent. Surgeons are making AI more intelligent, and especially in cases where we can preserve something. If there is something in the body which can be preserved without any harm, with the help of this 3D printing, and if not possible 3D printing, virtual. With the help of these virtual things, we can save the things given by the God, and we can really go ahead without any serious problem. Thank you.
Thank you.
So for our next stop, the topic is targeting GD2 in high-risk neuroblastoma, translating immunological targets into clinical impact. And for this, I would like to invite Dr. Ramandeep Arora, pediatric oncologist and visiting consultant at Max Super Specialty Hospital. He serves as the director of the Indian Pediatric Hematology Oncology Group INPOC and is the governing council member of ICCI, which is the Indian Childhood Cancer Initiative. We welcome you, sir. May I also request Dr. Ramandeep to please introduce and invite the speaker for the session, Dr. Manas Kalra.
Yeah, I was thinking in introductions of our doctors, we now have a celebrity over here. So for those of you who did not get a chance to see him on the Kapil Sharma show, here he is live in action. So it's my enormous pleasure to welcome Manas, my friend and colleague, who's going to talk to us about anti-GD2. I hope the science as well as the issues around accessing this therapy. Manas, over to you. Thank you.
Thank you, Raman. So when I heard her asking you to introduce me, I thought something mischievous will come very soon, and that was there. So good evening, everyone. I've been asked to speak on targeting GD2 in high-risk neuroblastoma, and I thank the team at Rajiv Gandhi to give me this opportunity. So you all know that high-risk neuroblastoma is a difficult disease to treat, disease that... Stop moving forward. Sorry. Oh, okay. Yeah. So we all know that, high-risk neuroblastoma is a difficult disease to treat, and GD2 has opened some new avenues for management of these difficult patients. And my talk today will highlight some of the aspects of what GD2 is, what are the different types of antibodies, the role of GD2 in the upfront setting, in the relapse setting, the role of newer therapies like CAR-T and vaccines very briefly, and other newer agents. So I think, this speaks volumes about where we are with high-risk neuroblastoma. And really speaking, whatever graphs the Western world throws at us, in India, most of the children with high-risk neuroblastoma die. And this is despite all the chemotherapy agents we use. We do a transplant, we give radiation, we do retinoic acid. Unfortunately, that patients that present to us present at a very late stage. They have aggressive disease, they are NMIC amplified, And most of these children, essentially, whatever treatment we give are really palliated by our chemotherapy, and eventually we lose them, not to chemotherapy toxicity, but to relapse disease. And this really was the holy grail, considered that this is where we are with the treatment of neuroblastoma, and really we were not moving the needle beyond this, because we had high dose chemotherapy, we had tandem transplants, we had retinoic acid, we tried very aggressive upfront chemotherapy strategies, like N7, like the COG protocols, and the relatively not very aggressive, like rapid Kojak. And despite all this, you can see the outcomes were not very good, and the best outcomes were for those patients who underwent a stem cell transplant and received cis retinoic acid therapy. And we continued using this for ages together to improve the outcomes of neuroblastoma, and we know where we are. But in 1980s, it was found that GD2 was uniformly present on the surface of neuroblasts, and that kind of opened new avenues of therapy for this very difficult disease, because we now had a marker, and this was the era of immunotherapy. And all attempts were made if we could cure patients by targeting this GD2 molecule, which is present on neuroblastoma cells. And a lot of antibodies have been developed since. The start was with the murine antibody, which was 3F8, 14G28, but this was associated with a lot of toxicity because it is a murine product. And then came the chimeric antibody. And when I was training in Australia, we were giving this for all the patients, and it was not at all an easy treatment. When we used to give dinutuximab beta along with IL-2 and GM-CSF, the patients were very sick. And my BMT boss used to just go back and ask each and every patient which was worse, autologous transplant or the antibody. And the uniform answer was antibody therapy, because it was associated with a lot of pain, lot of toxicity. They were all on opioids. And those were the starting years, so we really didn't know how to mitigate the toxicity of these patients. And I remember writing to Alice Yu in the middle of the night, because we found this dilated pupils in one of our patients. And then only later we understood that this is common with dinutuximab. And I can very nicely, vividly remember she replying at the middle of the night, because she was the PI, within like 5 minutes that, don't worry, do this. And we were very impressed by, the support that was provided by the trial, by the dinutuximab people. And then came the humanized antibody, and I'll show that in a bit, which is naxitamab. And again, we have got some really good trials highlighting the usage of this drug. So, coming back to the drawing board, when we have this GD2 and we are trying to target this GD2, what are the mechanisms with which, we are able to get on top of neuroblastoma? And when we talk of anti-GD2 antibodies, it is essentially the antibody-mediated cellular cytotoxicity and the complement-dependent cytotoxicity, which are really leading to this kill of these neuroblasts, which are otherwise refractory to treatment. And addition of IL-2 and other agents are just to, augment the immune-mediated killing of these neuroblasts. And the researchers really try to club all these things together to get a good outcome. And we all know of this seminal paper by the Alice Yu group on GD2, which was published in NEJM, and which clearly showed that there was an outcome benefit if you use immunotherapy for these high-risk neuroblastoma patients as compared to your standard of care, which comprised of aggressive chemotherapy, stem cell transplant, radiation, followed by retinoic acid. And if you look at event-free overall survival, the benefit is uniform. And if we just kind of focus on the difficult ones, that is the kids who are more than 1 year old and have stage 4 disease, even those patients had a promising outcome with immunotherapy, which led to the FDA approval of dinutuximab. And and rest is really a history for the Westerners, because they have been using this drug for almost all patients. And this is one of the examples where expedited drug approval was given for this very difficult disease, where the outcomes otherwise were quite dismal. The long-term follow-up, however, has shown that the curves are kind of merging, and the survival benefit which was initially observed with the dinutuximab trial has probably gone down. Having said that, it still is superior to the standard of care therapy, and clearly, since then, immunotherapy has been used in each and every Western protocol for their patients because of ease of availability and various other reasons. Outside of the trial, when they used dinutuximab for more than 1,100 patients, they still found that the EFS for these patients was reasonably better than the previous cohort. However, the figures are not really touching 70, 80, or 90% like what we are used to see in children with acute lymphoblastic leukemia. So if you look at the history of neuroblastoma, we definitely have made progress. And whatever, even if we say these curves are merging, I think dinutuximab is going to stay, or the congeners are going to stay, because if you look at the outcome improvement in 2019, we are really touching 60-70%, which is still better than what we were for high-risk neuroblastoma. But this has not come easily to us. It has come with a lot of toxicity, fever, hypotension, which was mainly because of the murine antibodies, neuropathic pain, which is because of the targeting of GD2, and capillary leak syndrome. I think mainly the contribution we all now understand is because of the interleukin-2. And you can see all these toxicities did not make the life easy for high-risk neuroblastoma patients. And thanks to Ciopen group, who actually looked at the role of IL-2 and clearly showed that maybe IL-2 is theoretically or in the lab increasing the immune mediated kill, but practically for our patients it was just giving toxicity and not leading to better cure, and IL-2 has now been kind of removed from most of the protocols. Coming to the humanized antibody. So again, theoretically, this is less immunogenic because it is a human thing. It's produced in the rat myeloma cell line, which results in decreased fucosylation. There is a decrease in the complement activation. Maybe that leads to less of side effects, but there are advantages that you can scale up the dose and have a better antibody dependent cell kill, which could lead to, which was theoretically postulated to have better outcomes. And we now have published data. This was the initial paper with 42 patients during induction. When the humanized antibody naxitamab was added to these patients, the curves look pretty impressive. And this is how the tumor kill or the shrinkage of tumor was observed in this plot here. And if you look at the further data for the same group, which comes from St. Jude, it did show that the outcomes for these patients with this humanized antibody was reasonable, but this does make the treatment quite complicated. So you're hitting them with cyclotopotecan, with anthracycline-based chemotherapy, you have cisplatin, etoposide, and you combine this entire treatment with the humanized antibody. So you can only imagine the burden of treatment that goes on. Financially, it's a huge impact. Although, therapeutically, the injection is, given not really like the infusion of dinutuximab. It's different from that. And probably there is an ease of administration with the humanized antibody as compared to the other one. This has also been looked at other groups. So this was the St. Jude group who really pioneered most of the work. But the Spanish group has also done a lot of work on this humanized antibody. They had access through the compassionate access program, and they have also given us a good data on the usage of this drug with reasonably decent event-free and overall survival. And if you have a minimal residual disease, which is very less, so by the time you take these patients up for treatment and you have very less disease after the induction chemotherapy, the outcomes of these patients treated with antibody therapy are better. The question is, what about transplant? So if you look at this figure, it really looks that the transplant is better. And that is what was my first impression, that, if you have a patient who has undergone a transplant and gets chemoimmunotherapy, the outcome is better. but the overall survival is not very different. And if you go into the depth of the paper, they highlighted similar to and akin to the MSKCC experience, where they use a very aggressive N7 kind of a strategy that probably, the Cox models did not find autologous transplant to be very beneficial, and it was only the extent of the disease which led to better outcomes for these patients. And in the era of chemoimmunotherapy, even these studies have led to a question whether autologous transplant will stay there strong for these patients. Dinutuximab has also made an impact in patients who have relapsed refractory disease. And really speaking, those were the ones where initially the drug was tried. And as compared to temsirolimus, it clearly showed that this drug led to better outcomes of these patients. And there are many other papers which have suggested the improvement of outcome of dinutuximab. And actually, that was the reason why this drug got approval. And even naxitamab has now been tried for relapsed refractory patients, and there has been a clinical meaningful efficacy for these patients. So probably all this data points towards some benefit. The curves are merging, but there is some benefit of using this. GD2 is universally expressed in neuroblastoma. I think we just need to understand how to use these drugs better to make them more reachable for the common person. They are very expensive. They are not easily available. And really more and more trials and science is needed to harness this benefit into the outcomes of these patients. Even post, patients who have been taken up for haploidentical transplant, that is again a new avenue for these very difficult patients. This drug has been added to their protocols, and you see that if really relapsed refractory neuroblastoma patients, if you see a curve which is flattening, you kind of think that maybe there is some activity going on for the drug, and you will be able to cure some patients, although the number may not be many. The other important area where GD2 is being, the role of GD2 is being exploited is really CAR T cell therapy. We know that it has done big wonders in the field of acute lymphoblastic leukemia, but I think CAR T in solid tumors is still, has to find its clear, unique place, and I think the science has to really evolve in this speciality. But we know of this paper from the Italian group where they tried to use this GD2 CAR T. And I was, I heard Dr. Buffalo speaking about this with a lot of passion, and how she expressed that, they are very encouraged by the initial outcomes of patients. There were few patients who actually got complete responses, and they are really, really bad patients. They have relapsed, refractory, they have tried multiple lines of therapy. And if you find some patients to have complete responses or even partial responses, that, this drug is probably working. We just need to understand it better. And there are a few patients you can see in this plot that, those which are highlighted by yellow actually got a complete response after using the GD2. While looking at details for this, the overall survival is 60%, but the event-free survival is still around 30-36%. And there is a subgroup here where, you can get an event-free survival of 58% if you have a low disease burden, and you could scale up the CAR T to that amount that you actually, you wanted to give. If you are able to scale up CAR T to that amount and you have a low disease burden, you may have a chance for cure for these patients. And there are more and more trials, and this is the recent one published in 2025 in Nature Medicine, where again you see that a 5-year overall survival of 68% for relapse refractory and a 50% event-free survival when you have used GD2 CAR T. So there is something which is going on, and we need to watch this space closely. The other avenue where GD2 has been exploited is the vaccine. So, I think this work needs to be done on a larger scale, because the data is very, very limited, mainly limited to phase 1, phase 2 trials. But what they have done is they have targeted the GD2 and GD3, combined it with the oral glucan. So this beta-D glucan is actually just a potentiator for your immune response. So you give the oral beta-D glucan along with these subcutaneously administered vaccines, and you hope that body generates an immune response against neuroblastoma cells and kills them. So I'm not going to go into the details, but this just phase 1 trial did show that with 9.6 years of median follow-up, there were 14 patients who were actually long-term survivors. So that actually was quite surprising for me when I read that. But if you look at the larger data, the one which has got a longer follow-up, the numbers are not as many, but there is a progression-free survival of 32% for few patients who have received these, regular GD2 vaccines, GD2, GD3 vaccines. And if you are able to generate an immune response with the anti-GD2 above 150, you are likely to actually do better in these patients. And this is what is highlighted in these graphs. These are some of the studies for the vaccine trial, and I think again we need to watch the space. I'll just close my talk by saying that a lot more is being done in the field of GD2. There are ways of intraoperative molecular imaging of neuroblastoma. So you inject them with dyes that highlight the GD2 areas, and the surgeon can actually see where all the disease is and is able to resect it better. There are ways where you can generate photo-oncolytic phages that can lead to the kill of neuroblastoma cells. And this is all there, and more and more research is going on in this field. And when you go through these articles, it's pretty heartening. But really what happens from bench to the bedside is something we need to really understand. So there are immune targets, especially the GD2, which has opened new avenues for therapy in children with high-risk neuroblastoma. Anti-GD2 monoclonal antibodies have impacted the survival of these patients. Tumor vaccine CAR T hold good promise for the future, and we need to see how they evolve in the next few years. The challenge for us is the prohibitive cost, the availability of these agents, and really speaking, 90% of our patients are not able to afford the usage of GD2. At Gangaram Hospital, we have just used it for 2 patients, and one of them relapsed post 4 cycles of GD2, and the other one is 3 months post completion of 5 cycles, 5 courses of GD2, and so far is doing okay. And we need indigenous drugs, we need lower cost drugs, and we need our academic centers to really push this forward so that we can have better outcome for patients with neuroblastoma. Thank you very much.
Thank you, Manas. I think as the science has progressed, and after you've taken this picture in and you've understood where Manas is coming from, we also want to bring in the reality of accessing this. And Girish, if I can invite you to just briefly comment on 2 things. One is the anti-GD2 experience in Tata, and maybe if you know about the India, how many patients and what's been the outlook. And the other is this naxitamab study, which is open and I think has recruited its first patient in Tata. If you can tell what's the eligibility criteria, what's the plan with that study? Thank you.
So first thing is what is available is dinutuximab beta, and the cost of that for a 20 kilo child is about approximately 75 lakhs. And to add that to already existing therapy, which has already cost you minimum 20-25 lakhs, it's almost 1 crore of treatment to get an outcome of maybe 50%, 60%, what is there. So, and the long-term data is also not very good with dinutuximab. The curves merge. So what dinutuximab has probably done is delayed the relapses in the immunotherapy arm, and whereas those who did not get immunotherapy relapsed earlier. So it kind of merged in a way. What I think the dinutuximab is useful, we feel, but I think the strategy is not to do it as maintenance. The strategy is to do it as upfront. See, if you look at all chemotherapy, what the response rate to induction chemotherapy is only 2/3. Only 2/3 achieve what we call as a satisfactory response in our present day standards of what is satisfactory response, which is metastatic CR and all that various scores what we use. But in spite of achieving that, that more than half of those who achieve that satisfactory response also relapse. That means the depth of relapse response is not good.
Yeah.
So we need a better, deeper response. And what we know is that when you do minimal disseminated disease in bone marrow and you find that's positive, they relapse more than those who don't. So in other words, I think early deep response is what we need to achieve. And there are only 3 strategies to do that, what we know. One is to combine immunotherapy with chemotherapy. Other is to use MIBG therapy, which is logistically a nightmare. And the third one is to use ALK inhibitor, which is only in 5-10%. So there's no other way we know to actually enhance intensity of initial induction. So from that point of view, chemoimmunotherapy is the best strategy to use, and the data what you showed from St. Jude's actually shows a if you look at their achieving remission with chemotherapies, is more than 90% remission achieving after the induction treatment. Now that is 30% more than what you would get from routine chemotherapy. From that point of view, I think that should be the strategy. You actually should do 3 or 4 cycles initially, and whether maintenance is required is questionable after that, and that maybe you can do 2 or 3 more later on. The second component is we are able to achieve remission, but we are not able to sustain the remission. And I think there the other therapies are probably more going to be useful, both in terms of maybe CAR-T or vaccines may be more useful. So that's the science of it. But the accessibility of that is obviously a big question. There has been a lot of negotiations. Many of you have been involved with the companies to bring down the price. So right now, with 15 vials, you pay for 6. That 6 itself is 75 lakhs. We're negotiating for 3 to pay only for 3, and they probably will give it at 4 to 5 cost. So it may come to 45, 50 lakhs. But the long term is to actually manufacture it. Ultimately, when the dinutuximab beta patent expires in 2026, and then somebody has to start manufacturing it in India, which some people are interested, whether they will do it or no, we don't know.
And the Tata study?
Naxitamab, sorry?
The Tata study Naxitamab?
Yeah, so ours, except the dinutuximab, we have done 17 patients. It's only a modest outcome. So we have 11 patients who are upfront treated and rest 6 are relapse refractory with dinutuximab beta. And in that 11, 8 are in remission, but it's very early days. So I don't think you'll get very good outcome with dinutuximab beta because all of them are maintenance. The naxitamab study is it's not a great study from an Indian context because it's only for relapse refractory patients. And you know that outcome is actually very poor on the long run. With relapse refractory, it's technically palliative. I think the company has 12 patients left to close the trial, and as desperate situation, they have come to us, and we were also debating what's the value of taking this because after 12, it's going to stop. And there is really not much change which will occur on the ground after these 12 patients are taken. So we also took it more for experience rather than expecting that will actually be a game changer. So right now it's relapse refractory. So you have after your induction chemotherapy and all, if somebody is still got positive, but the soft tissue disease has to be surgically removed, and then you only bone and bone marrow disease, then we can take. Or when they relapse also, the soft tissue disease has to be treated. You can give some salvage chemotherapy, remove the soft tissue disease. And if they're bone and bone marrow disease on PET, MIBG and bone marrow, you can take. So, but which is there. So if there is any patient, we will take, but it is a 2 years they have to stay in Mumbai for that. That's what I will tell you. 2 years they have to stay. So it's not an easy trial to do.
Thank you, Videsh. I think, there are 2-3 hands, but time-wise.
Split transplant. Split transplant.
Where does DFM come in?
So that was the question I was going to ask at the end because there was you said that probably you will have DFMO made in
Correct. So
India.
the DFMO is made in India. It is
Yeah.
with DCGI at the moment.
Yeah.
So we will open the trial. It will take 4 or 5 months to open the trial. So the DFM also, as you know, the trial is questionable what has been done in US because it's after everybody has received immunotherapy. You've taken a population which is already starting at 60-70% cure rate and improved it by only 12%. So it's not like it is 90%, 30 to 90%. You started at 70% and made it up to 80%. So you're actually 60. So it's only a 12% improvement in DFMO, which is of course good. It's not that it's not good. But the company, the drug is too expensive. So they are charging $8,000, and I think Deepak had negotiated with them for $6,000 per month for 2 years, which is it's more expensive than dinutuximab. So as we were going through all that, we realized that it's being made in Vapi, Gujarat. So and sold from US at $8,000. So the company are interested, but the tablet was patented. So they have now made a sachet. The sachet is what is waiting for trial. So now the trial will start. Then any patient from India can come, but they have to come to Mumbai to collect the drug. They cannot, we cannot make it too multicentric because to do it. So they have to collect the drug, but go back to their place. So we will.
So like you said, when I was just going through the blueprint of future research, most of the articles actually mentioned that you do all this. You give chemo, immunotherapy, you do transplant, you give radiation, you do everything, and then follow it up with tumor vaccine. And that probably giving long-term vaccine is what
5
probably
to 6
will
doses
give better
is what
chance
will
of
be
cure.
better chance. But right now, DFMO, please don't jump at it and don't
Sandeep,
really
last
buy it.
question.
I really don't think it is.
You wanna?
Yeah.
Now, suppose you have new patient stage 4 neuroblastoma and patient family can afford anti-GD2. Would you offer it in the upfront therapy?
So we have not done it yet. We are giving on maintenance only yet. We are not giving upfront. Only in relapse we have done chemoimmunotherapy.
Thank you so much, sir. That was such an insightful and neuron-stimulating session. And for the next, we know that from MIBG to PET imaging, nuclear medicine has transformed how we diagnose, stage, and even treat neuroblastoma, metaphering newer eyes on neuroblastoma. That is our next talk. And to chair this session, we have Dr. Sunil Puri. Sir is Director of Radiology Services at Rajiv Gandhi Hospital with vast experience over 35 years. And Dr. Pyali Mandal, ma'am is Professor, Department of Pediatrics at Lady Harding Medical College. Welcome, the chairpersons. So kindly introduce the speaker.
So it's my personal privilege to invite Dr. P.S. Chaudhary, who is Director of Nuclear Medicine and at our institute needs no further introduction. He's a stalwart in nuclear medicine, and he would be talking on neuroblastoma, new eyes on neuroblastoma, diagnostic advances and therapeutic precision in nuclear medicine. I'm sure he's going to take us through some of the really new advancements in not only imaging and in theranostics also. Dr. Chaudhary.
Thank you, Dr. Puri, and thank you, team, for inviting me here. It's actually, I'm speaking about MIBG after many long years. I think MIBG was a forgotten thing. In it, for the last 10 years, I hardly remember that we might have done a MIBG case on pediatric neuroblastoma. But anyway, all the same, if we have to talk about new eyes, we have to talk about combination diagnosis, combination treatments, and I think that's the order of the day. So in the next 15-20 minutes, I'm going to take you through what are the history of the diagnosis of neuroblastoma from the molecular imaging point of view and whatever we have in store at this point in time regarding the treatment. So getting back, MIBG is a meta-itobenzyl guanidine, and it's a alkaline guanidine, which is structurally similar to norepinephrine. And that's the way that it concentrates in the neuroblastoma cells. The majority of the neuroblastoma cells express the norepinephrine transporter, and once inside the cell, it stays there. And that's the reason why MIBG can be imaged over a period of even 24 hours, 42 hours. Of course, it has to do with the radionuclide target as well. So it's a win-win situation for both, for the target as well as for the radionuclide. So it can be labeled with either 123, I-123 or I-131. I-123 would have been better as a imaging characteristic wise, but unfortunately we don't have I-123 in India. So we need to use I-31 only for imaging as well as treatment. So the majority of I-131 MIBG is excreted as it is through the kidneys and the bladder. And therefore, from the free iodine, there is hardly not much toxicity as far as the radionuclide toxicity is concerned. So what was I-131 MIBG imaging? We used to struggle to read the scans at that point in time when I'm talking of 10, 15 years back, because it is very poorly suited to a gamma camera imaging when we didn't have a proper hybrid imaging years back. And since the iodine 131 has a very high level of photon of 364 keV, which actually penetrated the septa of the collimator and giving a lot of scatter to the images. We didn't have the hybrid images in those times where we can combine anatomical imaging as well as the molecular imaging. So having said that, I-123 has better imaging characteristic as far as gamma camera is concerned, and therefore would have been better. But we didn't have the luxury to have I-123. And another point in MIBG, I-131 MIBG was that it has purely beta emitter. It also has beta emission, which is used for therapy and which has no imaging characteristics. So whatever imaging characteristic were there was used to be the high energy gamma photon. And
The effective dose, if you look at in children from I-123 and I-131 is much, much more wider. I-123 would have given a lot of lesser dose to the child during scanning as far as the I-131 is concerned. So since it is I-131, patient needs to be prepared. And I'll just go a little bit about the preparation. Mostly it's the thyroid gland which needs to be blocked. And we can block with stable iodine. And there are other drugs which interfere with MIBG, but probably that is not relevant to this presentation because we are dealing with pediatric neuroblastomas. So over the years, now we have hybrid imaging available, and the addition of SPECT and the CT would give us a better diagnostic accuracy, certainty of lesion detection. We can always combine anatomy and physiology, and especially helpful for identifying small lesions. Now, if we look at MIBG, MIBG has a very, very solid positive, true positive rate. But it had 10% of false negative rate. It's not because it didn't concentrate in the tumor, but because it was beyond the resolution of the imaging equipment. So that has been taken a lot care of by the hybrid imaging and the current generation equipments. So the ability to reformat SPECT data in multiple fractions, combined with imaging, the hybrid imaging combined with CT, and as well as there is option of triple fusion with MR, CT, and the MIBG imaging these days in the current generation equipments, which can also enhance the diagnostic potential. The clinical applications of is the first line functional imaging agent used for neuroblastoma, especially pediatric neuroblastoma. And MIBG uptake is seen in almost 90% of the neuroblastomas, identifying both the primary tumor and the sites of disease, detection of extra-adrenal, suprarenal, metastatic spread with a high overall sensitivity and specificity. And it could also detect recurrent disease quite early. So this is one of the images from the history. And you could see an MIBG scan, a big mass in the abdomen with some bony lesions. Of course, it's from the earlier generation equipment. So that's why the resolution is not. But these days, we have much better resolutions to play around with. So these are the response evaluation criteria which we use to do with MIBG and the initial and the post-treatment. There are difference in the metastatic disease. There's difference in how we treated the initial tumor. So it was again the common one, the complete response, partial response, progressive disease, and the stable disease. So this is one of the examples of a mediastinal mass, which over a period of time had regressed. If you see the left-hand panel and go over to the last panel, then there is significant reduction in the mass, which is MIBG positive. There's a neuroblastoma, which, and you could see this is 2011. The images are from 2011, so decades back. MIBG could also help in prognostication. We could use the few scores like the Curie scores and the Saipan score as a semi-quantitative scoring system. And these are the way which Curie system and the Curie score and the Saipan system, we could prognosticate the neuroblastoma. And you could very well see in this curve that a Curie score, which is less than 2, after induction versus a Curie score, which is more than 2, had varied in the overall survival and the event-free survival in these cases. Similarly here, the event-free survival and the overall survival with a lower Curie score and a higher Curie score. Talking about bone scan, we used to do a lot of bone scan earlier days along with the MIBG. And probably the bone scan for neuroblastoma is almost history now. Since the most important thing which bone scan could give, other than because MIBG would give you more of a bone marrow involvement, and if there had to be a cortical involvement, probably the bone scan would be better delineated. But now with the current hybrid imaging modalities, we don't need a bone scan. So bone scan for neuroblastoma, the conventional bone scan is not preferred these days. A hybrid imaging with SPECT CT with MIBG can very well be useful. So here is an example of a MIBG and a bone scan, which you can see that the cortical bone is quite avidly visualized in the bone scan, and the bone marrow uptake in the MIBG is not to that extent. So combining both these imaging modalities, we could very well detect that whether there is a cortical disease or only a bone marrow disease. So coming to the newer generation of radiopharmaceuticals, when positron emission tomography came in, it was mostly a better image resolution, hybrid imaging, and good radiopharmaceuticals. So one of them is 18F-FDOPA. It's a powerful and increasingly used technique in the evaluation of pediatric neuroblastoma. It offers high sensitivity than the traditional scintigraphy, diagnosis as well as treatment monitoring. It functions similar to the L-DOPA, which is being metabolized by the enzyme L-amino acid decarboxylate, which is highly expressed in neuroblastic tumors. And it has selective uptake within neuroblastoma cells in a particular clinical setting. The diagnostic utility and performance, it's more recent literature now of the FDOPA. It is a positron emission tomography tracer. And if we combine FDOPA with MIBG, then the sensitivity, specificity, and the true positivity is a slightly more in FDOPA than MIBG, but that is mostly to do with the imaging characteristics. Imaging characteristics of FDOPA with a positron emission tomography is much higher resolution and sensitive than MIBG, which is using a gamma camera. Coming to the DOTA PET, gallium-68 DOTA. Gallium-68 DOTA, if you know that it's mostly used in the SSTR expressing tumors, and we use them very in the neuroendocrine tumors. In children, pediatric neuroblastoma, it could be a very useful tool. It has a high uptake and specificity, better disease evaluation, and it can facilitate PRRT also in this setting. The other tracer which is now available is the fluorobenzyl guanidine, MFBG, but labeled with 18-fluorine. It's a positron emission tomography tracer, which has a superior diagnostic performance, safety, and logistical advantages. It could be used for staging, response assessment, and monitoring in comparison to MIBG or FDG. It has detected more lesions overall compared with SSTR PET. So SSTR PET as well as the MFBG can use either way depending on the availability. Now, SSTR PET is widely available in our country. MFBG is still not available in our country. So therefore, the modern day imaging can be with either FDOPA or with the SSTR, that is the DOTA PET. So coming to the theragnostic aspect with the I-131 MIBG treatment, we all know that it is suitable targeted radiotherapy because it is tissue specific, and it's one of the theragnostic agents, and it has a lower toxicity since mostly it's a targeted treatment localizing only in the neuroblastoma cells. It has been also used in preoperatively at the start of treatment protocol for inoperable stage 3 and stage 4 disease, and in combination with hyperbaric oxygen treatment. So dose of MIBG we used to give is about 100 millicurie to 300 millicurie depending on the disease volume, and activity reduction is dose dependent myelotoxicity could actually, we can do the curtailing of the dose. So one example, now these images are not very eye friendly, if you call it, as on today, because we see much better resolution images these days. But all the same, this is a pre and a post-treatment scan from MIBG pediatric neuroblastoma, the pre-therapy scan and the post-therapy scan. So it gives that what we see what we treat, and we treat what we see. There's another example of the same one in a follow-up setting where you can see the regression in disease in the last panel. In recurrent neuroblastoma also, the earlier studies have shown good response with MIBG treatment, and objective response was almost seen in 40% with the 99%, 9 patients had complete response. So if we revisit MIBG today in a latest review article, so what can MIBG do is MIBG therapy may overcome therapy resistance in high-risk neuroblastoma. It has studied in over 1,500 patients worldwide in the first line and in second line settings. It induces objective response in almost one-third of high-risk patients, and MIBG combination therapy now it may enhance its efficacy. So MIBG combination with immunotherapy, epigenetic modulators, vorinostat, MIBG plus melphalan can also be used provided the toxicity is limited. And there are randomized controlled trials or MIBG and combination treatment are underway these days. And we can also integrate the role of MIBG in the strategy of CAR T cells. So what are the emerging nuclear medicine therapies for neuroblastoma? There are some novel radiopharmaceuticals. There are new radioisotope targeted radioimmunotherapy and innovative combinations that can enhance specificity and reduce the toxicity. So novel radionuclide therapies are, we can use targeted alpha therapy. Targeted alpha therapy, there are some radioisotopes which are astatine, actinium, and lead. It can be used for resistant or relapsed cases by combining with the ligand either MIBG or the DOTALA. The targeted alpha treatment, it delivers higher energy in a shorter range of radiation, so micrometastasis can be tackled, and it reduces collateral damage to healthy tissue because of the targeted approach. Radio-labeled SSTR analog, which we commonly call as the PRRT, mostly used in adults for neuroendocrine tumors. It can be used for targeting receptors which are present in neuroblastoma in MIBG unsuitable cases. Radio-labeled antibodies, the neuroblastoma cells expressing distinct surface markers, and dosimetry could be adjusted to I-131 MIBG therapy because we have dosimetry protocols these days. So dose limiting to the tumor as well as to the organ at risk can also be calculated. So radio-labeled SSTR analogs has been tried, but it is still at the bench. It's not at the bedside as far as pediatric neuroblastoma is concerned. And it has the same potential as the diagnostic capability and as a theragnostic agent. And the whatever trials have been underway, it has manageable toxicity profiles. But again, this is not used in the routine setting these days. There are experimental and emerging radionuclide treatments. There are novel vectors targeting other receptors. We heard about the anti-GD2. We heard about the denutuximab. We heard about the denutuximab beta. These can all be combined with I-131 MIBG therapy, and there are trials which are underway. A lot of trials are underway all over the world. Targeted alpha treatment and Auger electron emitter with different radiation properties are also under evaluation. Auger electrons can take care of the micrometastasis, and the beta therapy can take care of the macro lesions. So combining Auger electron treatment and the macrometastasis in a single setting can hasten the outcome in these patients. We can combine radionuclide treatment with the external beam radiation, immunotherapy, or DNA repair inhibitor therapy are also being explored. So coming to the future diagnostic outlook, we still have the conventional I-131 MIBG with a better diagnostic capability and accuracy, but there are recent PET tracers, MFBG, FDG, FDOPA, which can markedly improve detection capabilities, more for the receptor expression, as well as for the better imaging characteristic. It delivers high sensitivity, superior image resolution, and faster scanning, can identify more neuroblastoma lesions. Catecholamergic PET tracers, these are the new diagnostic standards. Trials are underway, which would probably come in a couple of years. And clinical impact studies are ongoing. Initial results are promising, but they're still at the bench, not at the bedside. And 18F MFFG has mostly superior lesion detection as compared to all the tracers which are concerned, because it's a precursor of the MIBG, only labeled to a PET tracer. So to summarize, I-123 or I-131 MIBG imaging and treatment for neural crest tumors is of course unique. It still remains unique as a theragnostic potential. Specific uptake mechanism due to similarity with norepinephrine, treatment of stage 4 neuroblastoma is feasible, And radionuclide treatment exploiting the SSTR receptors is being explored in the trial setting. There is one part of the trial data which has been published in 2020, but again, it's still not cleared by the FDA or other agencies to use it in the bedside in pediatric neuroblastoma. And better imaging, molecular imaging agents are available, which will, of course, be used for modern day imaging. Thank you.
Thank you, Dr. Chaudhary. So, if we talk about only the initial diagnostic part, the imaging, how does a CCT or for that matter an MR scan compare with MIBG or this F18 dopa PET?
So I think both, it cannot be compared because the purpose of imaging is completely different. That's the reason why hybrid imaging now has a better role to play. It can combine with the functional imaging as well as the structure.
Right.
So especially in response evaluation, the molecular imaging would have a better role to play because the tumor may not regress in size that much, but it can almost take over the treatment, can take off the receptors. So I think in isolation, I don't think we should be used now as in 2025. We are not using anything in isolation. It has to be a hybrid imaging where we can utilize the potential of both the imaging modalities.
If a CT or MRI has already been done, then you take the help of fusion imaging and
yes,
that serves the
yes,
purpose.
yes. These days, the softwares are so robust that MR imaging with different sequences done in your machine can be imported to our equipment and we can fused, provided the, the acquisition protocols are relatively similar. And we know from beforehand that we need to do a triple fusion.
So what is the protocol at our institute now? Are we doing MIBG or we are doing F18 dopa?
No, I think for pediatric neuroblastoma, last 10 years, we haven't done it. We have done in MIBG for other adult conditions, but not for pediatric neuroblastoma.
Currently, we are doing, you are doing CT along with PET CT, or what is the protocol for diagnosis?
Diagnosis, I think we are mostly doing FDG PET.
FDG
And since now F-DOPA PET has come, like F-DOPA is available in Delhi now. So probably we'll switch over to F-DOPA PET.
So is it so that surgeons ask for CT for surgery purposes, or that PET CT is good enough for them? Exactly.
Exactly. CT and PET, then it serves the purpose.
I think.
So, I think we cross-sectional imaging from surgical perspective, like Dr. Sajid was saying, or what Madam had shown over here in the 3D printing, is something which is different. And most of the time, this is always a discussion with the radiologist and the nuclear medicine specialist, because we are using a 256 slicer CT. And whether you get the same resolutions with the low dosing of radiation for pediatric cases. So that's always a challenge. Many a times we go to the nuclear medicine PET unit to see the images, and somehow that surgical planning, especially for small HOMAS-like lesions, it becomes a challenge. For bigger diseases, I don't think that's a challenge.
And what is...
Yeah, I think last MIBG, if I remember, for neuroblastoma, we did in 2015. And again, earlier we have done quite a significant number of MIBG treatments for neuroblastoma as well as other adult conditions. And but I think that time the imaging equipment was not that robust, and we could only see some black dots, which it didn't give us a very good feeling to have a response evaluation. But if you talk of today, the images are so robust, the programs are so robust that response evaluation, other things can very well be documented. So in fact, if we can start MIBG treatment, revisit again with combination, the trials are coming in with combination of immunotherapy and all, that would be a good thing which can probably increase the outcome.
So for abdominal neuroblastomas, so what is the like you order CT first and then for metastatic workup we get a PET CT done? What is and then that with them.
Initially, a diagnostic CT or
Diagnostic
an
CT,
MR
yes.
always
MR would always be done.
because
That's it.
as Sir was saying that the imaging machine, CT machines, particularly in radiology departments, would always be better than a PET CT machine.
Yeah.
So it will always leave, I mean, something in mind that I can get something better on a better machine. So the initial CT will
No, I think I would
always be in radiology.
differ in that. Machines are more or less similar these days.
No, sir, now you might be having a 64 detector CT, but we are getting a 320 detector CT. Some difference will always
So
remain.
that's agreed, sir. But when we actually talk of the bedside and when we talk of the whatever, say, information we are giving, it would be a combined information from two modalities.
That
So
is agreed.
definitely the amount of information will
That
be.
is agreed.
So most of the times in the beginning, at presentation, we're not doing surgery. So PET CT is fine. We can, define, but unless we have to look at L2, features. But before surgery, we definitely need a detailed cross-sectional imaging. That is very important for us.
And one thing I just wanted to highlight is, yes, the equipments are important, but more important is the man or the woman behind the machine.
Definitely, sir. Definitely.
Thank you.
Thank you very much.
Thank you so much, the speaker and chairperson, for such a detailed discussion. Now conclude with the tumor board, always the highlight of any oncology meeting. With an outstanding panel, this promises to be the perfect finale for our academic day. And for this tumor board, I would like to call Dr. Nitin J. Peters, who is Additional Professor of Pediatric Surgery at PGI Chandigarh.
So good evening. I think at the outset, thank you to Madam Gauri Kapoor, Dr. Dr. Shalini, Dr. Sandeep and the team at Rajiv Gandhi. Always a pleasure to be here. So I'll invite the panelists, Dr. Anuj Singh, Dr. Megha. Dr. Anuj Singh is a pediatric hemato-oncologist at the Super Specialty Hospital at Noida. Dr. Megha Sarwa at the Narayana Super Specialty Hospital at Gurugram. Dr. Shilpa Sharma is, I think, joining online. And in case there's some glitch, we have surgeons here. So we'll take inputs from there. Dr. Jaskaran, radiation oncologist. And Dr. Meenakshi Kampoj, who's a consultant in the Department of Pathology at Rajiv Gandhi. And Dr. Rakesh Oberoi, the senior consultant in radiology at Rajiv Gandhi. So we, yes, absolutely. Dr. Anjan is also there. Don't run away. So, no, Dr. Shilpa is there. So welcome, Dr. Shilpa. She's online. So what we'll do is we have 3 cases, and we've kept a mix of clinical problems which we come across in neuroblastoma. So let's just start with case 1, and this is a case from the Parent Institute where the meeting is being held. This is a 17-month-old boy who presented with a left temporal region swelling, fever and irritability for 1 month. And general examination was okay. Eyes were normal and no skin nodules. And there was a 8 into 7 centimeters fixed bony swelling in the left temporal region with dilated veins. And in the abdomen, there was a hard, palpable lump in the left hypochondrium, epigastric and left lumbar, large lump, which was not moving with respiration, and rest of the examination was essentially normal. So I can go on to ask my medical oncologists here, how do we further investigate this child? Dr. Anuj and Dr. Megha, maybe you could take turns in telling us how you
Yes.
would proceed.
Yeah, so thank you for the case. So as you can see, the kid is 17 months old, and he has subacute history, 1.5 month history of pain and irritability. Within the mass from the description looks like it's a retroperitoneal mass, and with a bony hard swelling in the temporal region. So at this age, the most common diagnosis will be most likely suprarenal mass with metastasis, and neuroblastoma is on top differential diagnosis.
Correct.
So we'll start with basic blood workup analysis. We'll do complete blood counts, biochemistry. We'll also send LDH and serum ferritin and coagulation profile. We'll evaluate the child clinically closely for any life-threatening symptoms.
Right. Dr. Megha, anything else you would like to add to this, what Dr. Anuj has told?
So in addition to that, local imaging I would like to do, and if it is possible to do a CT upfront, I like to do a CT abdomen, chest, and include the temporal region, or at least a ultrasound abdomen to prove what we are trying with what we are suspecting.
Right. Um, So anyway, essentially, like earlier, we do a ultrasound usually, and an abdominal mass 9 into 10 into 8.5 was seen in the suprarenal region, and a CT scan was done. And I'll show you some of the images, and I can ask Dr. Oberoi, sir, if you could help us in reading. If the IT person could remove this, yeah, the Zoom link from the CT. Thank you. So, sir, what is your take on this CT, and what would your answers be?
Abdominal contrast-CT. There is a large suprarenal mass, the mass in the suprarenal region, heterogeneously with the indistinct planes with the left kidney and left adrenal is not separately defined. It medially superiority extending up to the level of diaphragm with indistinct planes, medially extending just up to the level of midline.
So if, I mean, you should not go in for a tissue diagnosis per se, but what would your take with the background history would be, sir?
It could be a neuroblastoma. Second differential is a lymph tumor, but it is less likely.
Right, sir. So blood and urine, we've already, the medical oncologist have told. So essentially, everything looked okay. The serum LDH was high, 2,308, and urinary HbA was also high. VMA was also high. So I would like to ask our medical oncologist as well as Dr. Meenakshi, and what would be your plan of biopsy? How would you want to go ahead with the biopsy? Maybe Dr. Anuj can answer that first, and followed by Dr. Meenakshi.
Yes, sir. So now we have the initial imaging and the blood workup, and the next step will be to go for the biopsy of the mass. It will be core needle biopsies, and that can be done through the transabdominal approach or retroperitoneal approach. So retroperitoneal approach would be better, and that's what will be preferred. We'll also be careful in monitoring the child post biopsy for the presence of post procedure intratumoral bleed or any hemorrhage.
Right. Thank you. So, Dr. Meenakshi, I mean, I come from an institute where we do a lot of FNAC, and there is a preponderance of doing true cuts. So, what would be your preference, and why would you go with a true cut, and what would you like to see in that?
We always prefer a true cut biopsy because firstly we know that the neuroblastoma is a heterogeneous tumor. So well, heterogeneity can be it will give you different areas. So if we get multiple cores from different areas, then it can part into all the types of the subtypes. It becomes easier to subtype the tumor.
The FNAC can also be done. FNAC is a good procedure if you have a cell block made. If we have a cell block, then we can do the IHC for diagnosis on the cell block, and we can even go for the molecular analysis. But the part here remains if we get only very few neuroblasts, if you're talking about neuroblastoma, and mostly ganglion cells. So it would be false to call it a ganglion neuroblastoma or a ganglion neuroma based on that. So the percentage of neuroblast is a key here. So it's always better to have a biopsy, a better, with more number, we expect a more number of tissue in a biopsy than a cell block. And
Yes.
it's difficult to count MKI index also in a cell block. So there are limitations of FNAC, but if done, then some of the tests can, yes, be done on a cell block.
Right. So yes, like you rightly said, I mean, you can tell the maturation and so many other things you can tell in a true cut, which is better. And so we've already discussed the site of the biopsy, and I think retroperitoneal is a no-brainer here that everybody would go through there. And what the team had done was a image-guided core-needle biopsy. And so obviously this usually it's a child, it would need some deep sedation or a GA. So what is the practice in your hospital, Dr. Megha? Maybe you could tell us. You would do a sedation or a GA for this?
At my center, we are we are comfortable with the sedation, and because it is in a controlled environment, so we are comfortable with a sedation.
So I think the take home for the audience and the trainees in the audience is that the anesthetist and the person giving the sedation has to be well trained, and he has to be well, he has to be ready for any complications which might occur. So that is more important than GA versus sedation. So it has to be in safe hands. And do we need a core needle biopsy from the temporal region? So we've got an abdominal mass and we've got a lesion in the abdomen. So maybe the medical oncologists can take this. Would that change the management?
No, sir. So if the imaging is, if I think we can see the presentation, the imaging, if the imaging characteristic of the metastatic lesion and the primary are similar, it's better to do biopsy from the easily accessible site, which is abdominal site here. We need not to do biopsy from the temporal region. Yeah.
Right. So the histopathology showed a poorly differentiated neuroblastoma. And Dr. Meenakshi, maybe you could just briefly tell us about the immunohistochemistry.
Yeah.
What is essential for neuroblastoma?
Yeah, when we receive a biopsy of small round view cell tumor, it has many differentials after neuroblastoma, Ewing sarcoma, Wilms tumor, and lymphomas. So so neuroblastoma IHC is mainly a diagnosis of exclusion. There is no specific IHC to call it a neuroblastoma. Like ALK can help if it comes positive, and it does not come positive in all the cases. So when we do NKX 2.2, we're ruling out Ewing sarcoma. With desmin and myogenin, we are ruling out the rhabdomyosarcoma. And with WT1, we are ruling out Wilms tumor. CD99 is one marker which is always negative in neuroblastoma. So that is one marker which helps and usually comes positive in all other tumors. And LCA will help to rule out the lymphomas. So that is how the approach of IHC is done.
Right. So I think immunohistochemistry is essential to rule out a lot of other things and then kind of.
A new marker of FOX2B has come, which is said to be very specific for neuroblastoma. We don't have it as of now, but it may have in future.
Right. So now for staging, what would we go for? I mean, we've already discussed this with the previous speaker very nicely, and generally a PET CT is done for staging. So maybe we don't have do we have a nuclear medicine person here? Maybe what is the take home from here? Because different centers are doing different, mostly based on availability. Like you said, MIBG is not easily available, so people move to PET and send to different centers. So if maybe Dr. Jaskaran, maybe if you could tell us.
I think as per availability, it's PET which is most commonly done.
Right. So and
although there are other options as Dr. Chaudhary just
Yes.
illustrated, but I think PET is the one that's most commonly done.
Right. So how many in the audience? Maybe we can just take a poll, do a DOTA PET, FDG DOTA. FDG PETs you do. You don't do a DOTA knock or DOTA date. No. Yeah. Right. So maybe Dr. Renu, you can, because we are doing DOTA knocks and DOTA dates very frequently for the last 5-6 years. Yeah. Yes. We do FDG if the DOTA is not available. Like again, it's a problem of availability. And routinely, maybe Dr. Renu, you can tell us. We are. DOTA PETs, and we found it quite comfortable with our practice over there at PGI. So here a PET CT.
FDG PET, but DOTA makes more sense, obviously,
Yeah.
because more specific for neuroblastoma tissue. But because if you're having a histological diagnosis of neuroblastoma, then it's a question of staging only. For that we want. Now, DOTA would be more useful if you are not able to, if your biopsy is inconclusive and etc. And then you know that DOTA uptake is there. Then you know that there's actually a neuroblastoma, just like MIBG. Sometimes you use MIBG for a diagnostic reason. Then you cannot, your pathology is showing multiple times necrotic tumor, something like that. So, but if you can routinely do DOTA, that's very good.
Yes,
That's
so
fine.
I agree with Girish sir. I think the whole thing moves in a real world scenario where, you know, the biopsy is also to happen, the radiology is also to happen, and the date for PET also. So many things going on, and usually that also plays a role in how things are being done. So if you get a date for a DOTA PET, you know, it's quicker diagnosis, and anyways, a biopsy would take time. And usually our FNACs, we get by the end of the day, we get a idea of what we are dealing with. So this also showed a metabolically active soft tissue lesion in the left temporal region. So, and also lesions in the left humerus, proximal and distal of part of the left femur and distal right femur, and subcentric nodules in the lung. So now in this setting, would you still go ahead with the bone marrow?
Definitely, sir. So it's a metastatic neuroblastoma till the information we have, and bone marrow aspiration biopsy is mandatory.
Ma'am. Dr. Megha?
I agree with that. Bilateral bone marrow aspiration biopsy is the standard, and we do take part, as in it is part of staging, and it helps in reassessment of the disease. It has to be clear before we move ahead. So to document that, that part has to be done.
Right. So yeah, for reassessment, I think its baseline is essential. So you rightly said that. And the bone marrow was also infiltrated in this child. So essentially L2 metastatic lesion. So I would ask Dr. Shilpa, madam, can you hear me?
Yes, I can hear you.
Okay, so I mean, you've seen okay, and NMIC fish was not amplified for this child. And I think there was some rider with this fish because what Dr. Shalini told me was done from someplace else. So these are the temporal lesions. These are the lung nodules which are there. And so it's an L2 and metastatic L2 in the abdomen and metastatic. So, ma'am, I mean, I think it's an easy one for you that would you offer any surgery for this child? Immediately
If
upfront.
chemotherapy.
Yes. So
Okay.
I think this is clear. There's nothing to discuss over here. And we'll go ahead for some sort of chemo protocol. So we've had a wonderful talk about MIBG versus PET. So we can move on from this, I think, if the organizers tell me. So we've talked about advantages and all these things, institutional preference, availability, reliability are there. So I'll just summarize. Sorry, ma'am.
Regarding MIBG and PET scan, we usually prefer PET scan, but MIBG has a concern. Like in our institute, they say they have to keep the child isolated because he's going to have some radiations around him, and keeping a sick child in isolation for 24 to 48 hours is. Do they do it there? Does anyone do that? Does anyone do staging with MIBG?
Dr. Girish, sir.
So we do a lot of staging with MIBG, but it doesn't require any isolation to be done for a diagnostic scan. It's only for therapy we actually need isolation.
Maybe things that.
Yeah. For diagnostic, we just they're in outpatient test now.
So essentially, we have a situation which is commonly seen in the clinics is a less than 18 months intra-abdominal suprarenal primary with a bone and bone marrow positive, and the INPC is INPC Shimada is favorable. NMIC is not amplified. Ploidy is not available, like most commonly it is not, and MLP is probably sent and awaited. So the team has stratified as intermediate risk. So Dr. Megha, maybe you can help us with how would you like to treat this child now?
So it's a L2 metastatic disease, intermediate risk. I will like to start with neoadjuvant chemotherapy. Cycloid topo carbodox, that will be the combination. Reassess after 3 cycles 2 to 3 cycles and then assess for further surgery. That will be my approach.
Right. You, sir, you would like to add anything?
Yes, sir. So it's a infantile stage M intermediate risk. So even in the intermediate risk, we can broadly divide them into good intermediates and bad intermediates. So till now, what information we have, the kid is towards the bad intermediates. This is one scenario where segmental chromosomal alterations can help us in deciding the number of cycles, and also we'll take response into account. So yes, neoadjuvant chemotherapy, carboitopo will be the initial approach, and after 2 cycles, we can reassess the child.
After 2 cycles, you would like to reassess, ma'am.
Definitely. That will help in deciding. Till now, actually intermediate risk, but this is one subset in which the new COG classifier has incorporated and proposed them to include in high risk, because in the last ANBL 0531 study, this specific subset had outcomes only in the range of 60%. And when we are escalating our high risk outcomes to 60, it's not good to label them as intermediate. So
yeah, I think that JCO paper, which is referring to 22, 21, 22 paper, is the game changer of re-stratifying things, and that is how we would go. But I would just take a opinion from the house where people would treat this.
I'll also like to ask, if we put it into high risk, is there any data to upgrade the treatment to the same level as we do for high risk? I could not find anything that way. Maybe Kojak plus surgery, but not per se high risk treatment. Okay.
You're not sure why much bone disease. So we will usually, an MLP is not available upfront. Even MMIC sometimes the tissue is not good enough, or there are some issues, and sometimes we doubt the reports. You know, I suppose as clinicians we see marrow and bone disease, and age is somewhere between 12 and 18 months. Then we go for Kojak.
Because by the
Because we don't believe we can cure bone and bone marrow with just carboitopo and cyclodoxo. So we tend to overtreat.
Right.
And in this scenario, even if the SCAs are not available, maybe clinically the child is irritable with the high LDH, there are few soft markers towards being maybe a high risk disease, but I'm nothing really in the SCA.
This child also, the tissue was a problem. The first biopsy was done somewhere else. And we got the blocks here, then we got it reported, then we got the NMIC done, and then there was hardly any tissue left.
So I'll just take this cue and ask Dr. Meenakshi. You know, the Europeans have consolidated and quality assessment of their fish reporting and things. So do we have something in the works for this kind of a thing where you have a centralized? It's very difficult, but are there centers? Maybe Delhi is a big place, or maybe Tata. Is something being worked towards? Maybe that is the next thought which should be there, that we centralize our pathology. It would be much easier to quality control. Ma'am, your takes on that?
Yeah, I am not sure. We don't have any centralized thing as of now, apart from the trials in some cases. So everyone is doing their own validation, their own quality control. But
Yeah.
I'm not sure it.
I think that's one of the ways forward for our teams to work towards, because you know, even the Japanese, Germans, everybody is doing that, and they're centralizing radiology and centralizing pathology, which will take the things to more standardized care. So I think that is where we fall. Sir.
So, I mean, it is aggressive disease, whatever this it falls. I think this is a flaw in the classification in this situation, where actually stage 4, which is bone marrow disease positive, but NMIC is not amplified. Because of that, it is getting classified as intermediate risk disease. The same thing 15 years back would have been high risk disease, because
right.
anybody around 12 months. His child is how old?
17 months.
17 months. So at 17 months, definitely we would consider this as high risk disease.
Yeah.
See, we must look into the start from scratch.
Right.
If the symptoms have been recent onset of this child, especially the met on the skull coming now, you must take it as high risk disease. The reason being that this child came to you, I mean, how long was the symptoms for this child?
1 month.
1 month.
Yeah, and
Now
fever
that
for
is,
some time.
yeah, see, we must also understand, how did this 18 months cutoff come? So this 18 months cutoff has come just because on the whole database which was maintained in the US. And they have put different, simulated different cutoffs and said 18 months is a better cutoff than 12 months. But somebody who started at 17 months or 16 months with a new lesion coming in the brain is most likely to be high risk. So in this situation, we should take everything into account. The fact that LDH is so high, ferritin is, I don't know what the ferritin was. Ferritin was also high.
Ferritin was not there.
Not there.
LDH was 2003.
2000 is so high. With the skull met which is coming, it cannot be a straightforward intermediate risk disease. So suppose we want to treat for technical reasons as intermediate risk disease, we must do 8 cycles of chemotherapy. If you're not doing rapid Kojak, we must do aggressive, as in good surgery, as we would approach as close to high risk as possible. This lesion might require radiotherapy. And also we would do probably retinoic acid as well for whatever it's worth. Maybe the transplant is questionable, but transplant is questionable in high risk also anyway, what truly it means. But the other reason what I wanted to bring was this NMIC not amplified. Maybe I am not amplified in terms of number of copies. It will be useful to know in these situations whether NMIC numbers have actually increased but not classifying as amplified. Maybe you have 6 copies or 5 copies. That itself makes it pretty aggressive. I mean, aggressive compared to just having 2 copies of NMIC. So it'll be useful to know how many copies were there of the NMIC gene. And if you get 6, 7, may not technically hit 8 to call amplified. But if you get NMIC elevated, they in this situation would do aggressively as well.
Right, sir. Thank you. So I think in the absence of the SCAs and NCAs and NMICs and problems like this, the real world clinical scenario with, like sir has nicely told, has to be taken with a pinch of salt. And I agree with Dr. Anuj that, it's that bad IR which would have been classified as a HR. So, the treatment would change and you have to look at the patient as a whole and not, like Dr. Sajid so nicely told us that, there's that table which is there always. And when you go through it in detail, you realize that it doesn't fit into each and every patient. So, you have those problems. So we've discussed this, and this was the question whether to treat as intermediate and high risk, and what protocol would you use? So I think Sir has told us this. So obviously, no NMIC, you have to wait or start chemotherapy with this aggressiveness. I would think all the oncologists would agree. So to start the chemotherapy.
Respect to the first cycle is same anyway.
Yes.
Most of the time. So we can always change it from second cycle, even if it was a situation where we are not sure what it was.
So now the $1 million question, where everybody would probably differ is, should MLPA be done for all cases if we were in a purist idealist world? Yeah, the panel there.
So MLPA, so we can start with the simple areas. In high risk, if the patient is more than 18 months, stage M, NMIC also doesn't differentiate that subgroup. So definitely not needed in clinical high risk group. If you have NMIC, MLPA not needed at all. The set in which it is needed is mostly intermediate risk group, especially to decide the number of chemotherapy cycles, 4 versus 8 versus 2. Because the recent COG classifier is also including 2 markers in that, 1P and 11Q, and DNA index. In the INRG system also, it's only the 11Q aberration which makes MS from observation to directly high risk. So that is the only one scenario where SCA can have substantial difference, that to 11Q aberration. In intermediate risk L2 disease, 11Q can make you from low risk to intermediate risk group. So I think it's only the intermediate risk group. In the high risk group, you can do MLPA if NMIC is negative to look for ALK aberration. Other than these scenarios, I don't think it's not needed for all, definitely not for all.
Ma'am, Dr. Kamboj.
At our place, we are doing NGS. MLPA has good results if it is done on blood and marrow. It has doesn't give good results in the block, the formalin fixed tissue. So that's a problem, and it needs a separate kit. There's a separate kit for formalin fixed tissues that is to be applied, and it does not give good results due to the broken fragments. So yes, ma'am, there are specific probes regarding what we are trying to see. There are specific probes there. So those are used, but it gives good results on blood and marrow. So we are not doing, so we are doing NGS on this.
Yes.
Yeah. So basically, at our center again, we are preferably to do MLP in fresh tissue.
Yeah, we are also doing that.
Fresh tissue. MLP,
That will rule out all the possibility of formalin tissue artifacts.
So,
and it will also take same time. I mean, NGS also takes 21 days and MLP also takes a lot of time.
Just be a bit careful about MLPA. We have probably done more damage from Tata with MLPA than the benefit by starting MLPA. And we have done more than like 500, 600 MLPA so far. Lot of it on paraffin blocks itself. So that component has been reasonably worked out. There's 80-90% result success rate is there even on paraffin block. And I think only 10-20% we do not is in uninterpretable or we don't get it. See, we must remember what MLPA does. It tells you, it is like, suppose chromosome 17. It is looking at some 7 genes on chromosome 17. On chromosome 1, it is looking at some 3 genes because these are preset 3 sets of probes, which comes from the company, and you do all 3 sets, you test on it. And in that, there are fixed these 4 areas where it is loci, which is looking whether it is gain is there or loss is there. Now, if you had a hyperdiploid tumor, it will show everything as gain. So that doesn't mean there is segmental chromosomal anomalies. You actually got a numerical chromosomal anomaly. That is a good prognostic sign. Okay, so do use that MLPA with a lot of caution. So if you actually get 17 chromosome, all 7 genes are gained. One chromosome 1, all 2 genes are gained. Chromosome 2, all 3 are gains, and you have no losses anywhere. Then you must question whether it's actually whole chromosome gains. It is just that you're testing those 3 points. That's why it's showing as gain. That is not segmental chromosomal anomaly. Or you cannot interpret it. May be segmental chromosomal anomaly, but you can't interpret that. So then you have to do either a ploidy or you do an array CGH and then tell that actually ploidy is hyperdiploidy is there or no, or it is a diploid chromosome. So it has to be used in caution. Definitely, as Anuj says, high risk, don't use it. There is absolutely no value of doing it. Completely resected L1 disease, there is no value of doing it. Whatever chromosome you find, if it is an L1 disease, it's limited value. In a 4S disease, what you were telling in Hematology may be for 11q disease, that's a fully differentiating tumor and good risk. The rest of it, I would be intermediate risk to some, but I would use it very, very carefully. Very, very carefully. So it is not to be assumed that it's an answer. NGS is probably a better way to do it. Definitely a better way to do it.
So
interpretation is more important. So
very, very clear point, sir. Thank you for that. So, and how do we evaluate the response to therapy in this child? So, Dr. Oberoi, maybe you would like to take this.
We can do the PET scan or we can do the functional MRI. With the help of a whole body functional MRI, with the help of a diffusion imaging, we can see whether lesion is the residual lesion or a response to the treatment, whether size is decreasing or not. Diffusion weighted images.
So, how commonly is functional MRI available? We don't have it with us.
It is really available. Yeah, it is routinely.
PET CT and bone marrow. So that is, I think, standard. Okay.
Routinely doing we are.
Nice.
For whole body we are doing it. Yeah.
So, Dr. Anuj and Dr. Megha, so what would be your take on this? I mean, most of the, the country is doing a PET with a bone marrow. That is quite standard. So anything else you would like to add on to it?
My approach is also the same. We do a PET CT along with that bilateral bone marrow aspiration to look at the CR.
So now you've given okay. So neoadjuvant chemo was given with rapid Kojak, and this is the residual tumor with the mass as 3.6 into 2.7 into 2.8. So Oberoi sir, if you could just guide us through this CT. I know there are just 2 cuts over here, but Dr. Oberoi sir, if you could help us with this CT. This is the post-chemo CT over here.
This is a post-chemo CT is showing a mass with calcification and mass size quite remarkably reduced.
Right. And the PET was
showing no activity.
PET is showing no activity.
No activity.
And bone marrow has been done and it's negative.
Bone marrow is negative.
So maybe I'll ask Dr. Dr. Shilpa now. Ma'am, what would be your approach to go in and remove the abdominal lesion?
It seems to be operable, apart from the fact that the left renal vessels have to be taken care of carefully, and consent should be taken for nephrectomy well in advance, just in case that the kidney may not be able to be saved. Otherwise, it looks that it will be possible to remove this tumor and save the kidney from the vessels.
Okay, thank you. So I mean, any of the surgeons here, anything else? Sajid sir? वो खत्म हो गया after cleaning. Marrow is clean, sir. Go ahead, Mr. You're right. So I think the surgery was done, and again a GTR was done with piecemeal removal with renal preservation. The kidney is here you can see the kidney here, and the tumor is held in the Babcock forceps, and GTR was done, and this was the final image with the left renal vein. You can see nicely over here, and a little bit of fibrosis is fascia is left over the left renal vein, and the kidney is nicely pink in color. So a good job has been done over here. And the histopathology has shown a differentiating neuroblastoma with 5% viable tumor. So now again, Dr. Anuj and Dr. Megha, maybe one by one. This patient actually was counseled for a high-risk treatment, refused for high-risk treatment. I mean, it was upgraded from the intermediate risk like the house has already discussed. And then the NMIC was done again and it is positive, which was, I think, the clinical scenario all along. So 2 months later, the child is presented with seizures and brain mets. So, Dr.
Now the scenario is very clear. I think it was a high risk to begin with it.
Absolutely.
And with the induction rapid Kojak, he got the best induction, responded well, underwent surgery, but further consolidation of high risk regimen was could not be given due to parental consent, and definitely if NMIC would have been amplified, it would have been easy to convince the family that time also for high risk treatment. So now it's a palliative scenario, and essentially it just makes us understand that NMIC should be interpreted very carefully.
Right. So, Dr. Jaskaran, maybe you can put in a word on any role of palliation with radiotherapy.
Yeah, I think if the brain metastasis is the only site, then
Right.
it should get radiation. And if we consider it only as an oligometastatic site, then even stereotactic radiation can be offered in such cases, but it's still not the standard. The standard is still the conventional radiation.
Right. So essentially this patient was put on palliation. So any burning questions from the house on this particular case? Or? So I think a very, very clear scenario. It's very commonly you see things like this without a lot of genetic information, and clinically it's a high risk and it's being treated as per a different protocol, and then you get a outcome which is very similar. If this was a high risk to begin with, we would have probably anticipated this outcome and looked at and counseled the family accordingly. So so we have 2 more cases, ma'am. So should we take just one, or how do we go about it? Okay, yeah, that's fine. Second case is yeah, it's a upfront surgery sort of thing. Okay, so this is an interesting case. 1.5-year-old girl who came from UP Varanasi, and she came to our center with the involuntary chaotic movements of the eyes, inability to walk, inability to sit. Associated, she had poor oral intake and fever for 3 to 4 days, and some difficulty in chewing deviation. There was no history of difficulty in chewing deviation and no other history of drug intake. She went to 2 other hospitals in UP, and where she was examined, and I'll come to this. She was treated elsewhere and managed as post-viral cerebritis. I think this is quite commonly we see this scenario with patients with these kind of problems. MR brain was done, CSF studies was done, and she was treated on a neurological basis. So, and there was no other history. So I'll go back to the current examination, and this patient was conscious, irritable, and there was deficiency in the power, and cerebellar signs were there, and there was ataxia obsoclonus and eyelid myoclonus in this child. This is a pre-therapy. When she came to us, a video, parents had shared this yesterday. This was a pre-therapy video. So, quite a disabling situation here for the child and for the family. And anthropometry was, Z-scores were a little behind. So, I'll ask Dr. Megha, how would you proceed? How would you examine? How would you take this case forward?
So it looks like there is ataxia, myoclonus. Looks like there is a possibility of OMAS here. Maybe we are dealing with that. And since so much of workup has already been done, here I'll just like to do an ultrasound abdomen to look for my suspicion of any renal mass that may be there. And maybe if even on ultrasound, if it is absent, maybe this is a scenario in which I like to do a MIBG to find out the primary, maybe.
Okay. So, Dr. Anuj, would you like to take things, anything to add in this scenario?
Yeah, so here I would like to do, after once if the USG is normal, I would like to go for PET CT, which is because with obsoclus myoclonus presentation, 40 to 50% of patients have neuroblastoma, but vice versa, out of 100 neuroblastoma, only 2 to 3% have OMS. So with OMS, we have to do a thorough workup for neuroblastoma, and interestingly, it's not, majority of the times it's not abdominal, so it's like 60 to 70% abdominal, but a major chunk, about 20 to 30% will be thoracic also. So a PET CT will be easily available. So if USG is normal, I'll go for PET CT.
Now I'll ask you to take off your oncology hat and put on a general pediatrician or a pediatric neurology hat back on, and then answer this question, because that is what happens in the real world scenario. So would you, if he comes to you, he's definitely an OMAS, and we are in a HOMAS tumor board, so take a PET karenge. But if you are a pediatrician or a pediatric surgeon who's not dealing with OMAS daily, so what would be your take? How would you manage this?
So initial,
would you do a PET straight away?
No,
Because
so other than the medical stabilization, which is very important, clonazepam therapy, and many a times the kids are already on anti-epileptics. Yeah, so PET CT, I will still go ahead and do to look for occult neuroblastoma, which is because 40-50% is a high number.
Convention. Okay. Okay. Very small. Yeah. Yeah. Yes. So, this child had an OMA score of 14. And so like our pediatric hematology unit, which is very robust, we have a very robust neurology unit. So, you kind of the surgeons get stuck in between sometimes. This child had an OMA score of 14, and she was already on ACTH and IVIG, and they even gave rituximab, 4 doses. And we do the Mitchell-Pike scoring system, which is very standard. And we did this, and that was the 14 OMAs, so quite debilitating. The general blood investigations were normal. And what was done was actually a whole body MR was done. That is the protocol in our institute. So we don't go for a PET upfront, but point well taken, it can be done. So I don't have the images, sorry. I mean, could not get them. So it was a T1 isointense, T2 hyperintense lesion, and D11 to D12. And it was a small lesion, like you have already mentioned, that 11 into 18 mm into 27 mm. And it was an L2 kind of a IDRF positive. Portal vein was close, and the IVC was close, and the adrenals were normal on the MR. So we've already discussed that, what other diagnostic modality, and a Dotanoc PET was done. Again, apologies for this photograph, little crumpled there, which showed a somatostatin receptor expressing lesion in the retroperitoneum, close to the suprarenal and the right crus of the diaphragm. No other lesion else, where it was 1.6 into 1.3 into 2.2. So very similar to the MR finding, which was corroborating with this. And this is where like Sir was saying, probably the PET MR kind of situation can help to do just one investigation and get away with it. So I'd like to ask Dr. Megha, so that is there any role of any tissue biopsy here? Would you like to go ahead for a biopsy? Thinking that this was a more amenable place for a biopsy. You know, it's very close to the portal vein and the...
I think I'll take a surgeon's opinion, and if they are okay to go ahead with surgery in this scenario, I think a safe resection, I'll go ahead with that.
So, yeah, so let's ask the surgeons. Dr. Shilpa, ma'am?
Yeah, so I think we should go ahead with surgery in this case and then give them the whole tissue for biopsy.
Right, right. So, sir, anything else? Dr. Sajid, Dr. Devendra? Yes. So I think it's very clear. There's no role of tissue biopsy here once the PET is done. So we went ahead with surgery. Again, I'm sorry, I don't have the operative photographs, but this was a 3 into 3 centimeter lesion in the right paracaval space, medial to the IVC and above the left renal vein towards the crura and the posterior to the head of the pancreas. So a little difficult situation, but kind of excisable. And the histopathology showed that this was a ganglion neuroblastoma nodular. So, Madam Kamboj, if you could just help us with this, what else would you look at specifically to kind of diagnose this lesion?
See, first thing is we need to see both the components, the ganglion component, the neuroblastic component, and to label it ganglioblastoma, at least more than 50% of differentiating cells should be there. And if I can see the report, and not you have in this nodular type, there will be different nodules. Some nodules will be showing the neuroblastic undifferentiated part. Some nodules will be showing the differentiated ganglion part. So that's where the dissection gives a complete report, and it would be somehow lost in biopsy. Maybe some area will come, some not come. And both. You can see it on macroscopic also. And the ganglion part will look whitish firm, and the neuroblastic part will look more congested, hemorrhagic, brownish. So there's a difference in color also in both the components. And the margins are important in this case, the completion of this for the completion of surgery. And IHC is not mainly done because when you're seeing ganglion outrightly, so it will just support a few markers, synaptophysin and ALK, and just one or two markers are enough to call it a ganglion neuroblastoma. So not much need of IHC is there.
So the second part of the report is for the later part of the story. So it was, so she was doing well. She received therapy, IVIG and ACTH for 2 months, and just 3 months, 4 months post surgery, she had recurrence of symptoms in terms of the OMA score being 9 now. So she again had inability to walk, and she was irritable with neuropsychiatric kind of features which the child started having again. And then they came back and received pulse steroid therapy, settled a bit, and again the entire workup was planned. So I would like to ask Dr. Anuj, so what next? How do we go ahead? Do we do the whole gamut of PET and MR and everything again, or what do we do now?
Yeah, so here I just want to know whether the first resection was GTR, gross total resection, subtotal resection, or there was any residual tumor behind.
Good. Yeah, so that's the question we asked ourselves, and we went back to the PET scan, we went back to the MRI, and we went back, and you see the supplementary report. Their slides have been reviewed on clinician request. So we looked at the operative findings and everything, and it kind of corroborated because it was a retro cable, just 2 into 1.8 centimeter tumor. So, keeping that in doubt, we thought that let's go back and revise. And all the parameters of radiology, gross pathology, as well as surgical notes corroborated. So we thought it was a gross total resection.
Yeah. So just the principle of therapy in OMAS will be, it is the cross-reactivity of the antibodies which are against the tumor cells, which are cross-reacting with the cerebellar cells. So the main principle is to remove the antigenic exposure. So surgery in this scenario specifically, even though it is intermediate risk L1, L2 disease, a gross total resection will be very helpful to remove the antigenic exposure, even if the histology is favorable. Second treatment will be to suppress the antibody formation, for which IVIG and steroids have been shown to be very effective. In the only prospective COG study which was done for obsoclonus myoclonus with neuroblastoma, what the two arms were. One was IVIG and oral cyclophosphamide cycles, even if the patient is not a candidate for chemotherapy as per L1 histology. The second arm was IVIG with steroid and oral cyclophosphamide. If the patient is a candidate for chemotherapy as per intermediate risk, then no cyclophosphamide was given. What they found was giving just cyclophosphamide oral at low dose also help in decreasing the antibody formation. So it is a sort of like a second line immunotherapy. So given that data, which is a prospective randomized trial, I think even if the surgery was complete or some doubt, oral cyclophosphamide or 2-3 cycles of cyclophosphamide should have been added. Now, if the child is having recurrence of symptoms, most likely either the antigens are somewhere else. So we should do ideally a repeat PET CT scan, I think.
All right. So just a vote from the house again, like cyclophosphamide, how many would add upfront to OMAS? Straightforward OMAS, I mean, how many I mean, that's a good study. I mean, whatever I could understand of it, it was a RCT and published in a good journal. So I just studied that. But cyclophosphamide again, sir, maybe your take on that.
We don't do, but it was always second and third line in multiple guidelines. There was no protocol prospective study to use cyclophosphamide if the first line failed to give it. But yeah, I mean, it makes, I mean, it's totally understandable that it would have a good immunosuppressive effect because it's commonly used for most rheumatological autoimmune disorders.
Right. So straightforward. So we did another PET scan, Dotanoc, and this showed a lesion again in the same area, which was almost the same size. This is the previous report, this is the current report. So whether it was tumor left behind or whether it is a recurrence, so that was difficult to answer that time. So Dr. Megha, maybe you could take that. What do you think? It was a recurrence or it was?
I'm not sure. It just that it is correlating with the symptoms. So maybe.
This is disease, definitely.
Yeah.
Did you have imaging? Did you send for observation to document, yes, there is no disease left behind?
No, sir.
So probably this is a recurrence.
Yeah, because the symptoms had improved for around 4 months. And
but symptoms can improve just with immunosuppression, even if you don't remove the tumor.
I agree, sir. But like for standard practice, I mean, we don't do a repeat cross-sectional
So
imaging.
that's good. Only thing is the pathology report said 1.8 centimeter something lesion was removed in that gross description. So maybe the whole tumor was taken out. Could be.
Yeah. So that was a question. So because it was a difficult location, so we were not very sure on that. What we took out measured 1.8 to 2 centimeters. Yes. Yes. Paracable towards the right crus. Yeah. Yeah. Just, I mean, behind the cava and going towards that area.
And usually they don't recur, unlike this one. But even I have seen one patient like this. That's why I was saying. Even I have seen one recurrence in OMAS.
Yes.
Rather than well, then probably they're taken into high risk only. Definitely they want.
I think Shumada is unfavorable, I think.
Like chemotherapy to be given
Shumada is
like nodular ganglion neuroblastoma, but not high risk.
Okay. So histology is thing, but again you can say that was an L1 disease. So there is no.
Yeah, correct.
And I would take.
Right. So Dr. Shilpa, any points on that? Dr. Shilpa, can you hear me?
It's difficult to say because it was done after 4 months. Yes, I can hear you. Do we have any report on the histopathology?
Yeah, so it was a ganglion neuroblastoma nodular.
It's difficult to say whether it was a recurrence or a residual. Looks more like a recurrence because the shape is different and it's longitudinal. The other tumor, you were quite sure you removed the whole thing. Had it been there, you could have palpated it and it came after 4 months. So it more like looks like a recurrence rather than a residual.
Right. So now we have this PET scan. So what is the next? Do we need any other investigation or what do we do now?
Does this patient need chemotherapy now?
Yes.
Yeah, now I think we have a sorry.
Yeah, please go ahead.
Okay, yeah. So now the child needs chemotherapy. Yes, definitely, because even in the previous scenario, I think GNB nodular, we need to look at the histology of some nodules. There might be some nodule which have say poorly differentiated or even undifferentiation. In that scenario, the histology will become unfavorable. So definitely child needs therapy, and I think now starting with neoadjuvant chemotherapy will be better before surgery, so that will help in one controlling the OMA symptoms also, and it will help in shrinkage of the disease, and then re-excision can be planned. So intermediate risk regimen, carboplatin etoposide or maybe cyclodox, carbo-etopo will be better, I think, here.
Right. So I think.
Let me ask you, as you are the surgeon, would you like to go back in and try to remove it, or you would be hesitant?
So I'll off the record, I'll tell you that this case was discussed with the global neuroblastoma meeting also. And there the medical oncologists all said that take it out, and all the surgeons said give chemo. Because sir, this child was 1 year and 4 months when this happened, and then 4 months later. So she was around 80, almost 2 years. No, the immunosuppression went on. The ACTH, the rituximab was stopped after 4 cycles. The rest, ACTH alternate day and IVIG once a month was going on. Yes. Yes, yes. So, this was the scenario there. And
what was the MRI finding respect to vessels and other things in the second after the so-called recurrence?
yeah, so this is a better thing because I don't have the MRI images, unfortunately. And this was again in the retroperitoneum, posterior to the portal vein and posterior to the head of the pancreas and anterior to the right crus of the diaphragm. So that's why the surgeon said give chemotherapy and the oncologist said do surgery.
That's why I'm asking what was the MRI. This is still resectable.
It is resectable, correct. But going in again with that doubt of recurrence versus, so that there was a question there. And we gave.
To mature the tumor with chemotherapy and then go in, so that there is no.
Right, ma'am. So I think that middle path was taken and 2 cycles of VP carbo was given. So, and then the surgeons lost and we went in again. And again, this was, we don't have better pictures. The C of the duodenum here, the pancreas you can see here, part of the nodule you can see here, and then you lifted the pancreas and the duodenum in a reflected it, something like you would do for a Whipple's and go in behind that area and cauterize it, and this kind of a lesion was there which was removed. And this time I called the surgeon from the other OT to tell कि भाई ये निकल गया है कि और कुछ भी निकालना है, because I was so there was my colleague in the other OT and who does a lot of reconstructive urology, and that person was in a soup. So that person said, "ये मेरे से क्यों पूछ रहे हो?" But anyway, so what we thought was that we have resected the entire lesion from there. And the histopathology showed us reactive lymph nodes with no metastasis.
Wow. Did it shrink?
But why did the activity?
Why the activity?
What happened to the PET before surgery?
No, we did this, ma'am. This was the PET. Yeah.
BP carbo was not.
No, after BP carbo, we went in for surgery.
Nitin, I guess you should have explored this area very well. Cauterization, go into the retrocavum, go into the inter-outer cavum region. Just because we are in a situation of a recurrence and just the visible thing, instead of that, an exploration. In addition to that should be a well think, yes, because this coming as a reactive node again places a doubt because we have some activity with the daughter now. Definitely there is some tissue there. Have we missed it? Have we left it? So further follow-up for that, and certain you never expected this histology being coming as reactive.
Correct.
You always felt that this is disease. What do you think the extra step in a recurrent setting to exclude, I've come now, I'll sweep the entire area, look for any other more suspicious thing?
Going one step further, I don't know, or the same person who has reported and seen all the radiologist intraoperatively also to do ultrasound and to see, because it's a retropancreas which we are looking at.
Yeah.
That area would be visible, but in any case, if we start off with doing before dissecting and then if localized on ultrasound, kind of some guided kind of.
I totally agree with you. Totally agree with you. And so that duodenum was totally cauterized, and the entire retroportal and retrocaval area was looked at in detail.
Because once you mobilize, there will be gas which will intervene, that will interfere with their window.
Yeah.
So before that is done, maybe we can.
One lateral thinking for that, for the removal, is there any possibility of laparoscopy? Because the vision is very good with the laparoscopy. Because for this lesion, small lesion behind the pancreas, if laparoscopy vision, maybe vision for the vision. For this lesion, sometimes because if
we had a very similar case. We had a very similar situation, Dr. Nitin, and it was lucky it was away from the. It was not going behind the IVC. It was only sitting over the crust, not crossing the midline. We could locate it.
Further look like.
It's like saying that I will look in the keyhole, but I'll not open the door inside. You're opening the door inside the abdomen.
So I take both your points and the Anjan's point. Like for example, a fundoplication is any day is easier laparoscopically because of the area where you're working, or a cardiomyotomy or a Heller's or a achalasia is easier. If you do an open Heller's, it's a nightmare. And I would agree with Sajid's point here that you need to reflect everything, and that may not be possible laparoscopically, sir.
Can you take us through this limited images are there? Can you point out where is the disease here?
So sir, this is the crust, what I can make out of here.
Okay.
And then
where's the IVC?
This is the IVC here, and this lesion on top over here, this small lesion.
IVC has to be medial. This is in the inter-outer cable region.
Yeah, this is the aorta here.
That's the outer, and the semilunar type is the dark one is the IVC next to it.
Yeah.
And this lighted one is the lesion.
Right.
And what is this yellow thing? It's the too high for the collateral system on this side.
This one?
No, on this side.
This one?
Yeah. What is that?
That I'm not sure.
That doesn't fit into the collateral system. That's not. Yeah, that looks like this. If that you consider that.
Yeah.
So when you mobilize the kidney.
Suprarenal was fine. The renal vein and the IVC junction and everything was looked at clearly.
This activity in this.
Yeah. ये तो normal calacial है. Madam is asked the right question. So, well, now it's been, she was operated in maybe February of this month, and this year, sorry. And now it's October, and till now she's fine. She's coming with no problems. And this is her video from day before yesterday. So we are in a soup. We are very closely monitoring her. So the question I wanted to ask the house was that do we do a PET again, and when do you do it? Sorry about that. She's
We took it as like a consolidation search because you didn't find the disease.
post second this thing. Yeah, almost 1 year is over. So yes. Yeah, 1 year, 1 year. If you count starting from the previous this thing.
The end is good, Nitin, but there are still unanswered questions.
Yes, absolutely. That's why we brought it here.
Course is zigzag, but the end is well. हमको तो एक पेट जरूर करना चाहिए क्योंकि पता चले कि उसमें क्या हुआ। नहीं बट
That's why we are not doing the PET.
No, no. The main advantage of doing FDG PET is able to present in the next meeting also. I think some
Right. So any more questions on this from the house? Yes. So, I mean, that's again a real-time issue, real-world scenario.
The reason is exactly what you showed. That the lesions are quite small many times. They're only 1 centimeter, 1.5.
Yes, very small.
Second thing, they will not be FDG if they're well differentiated. And they will also get absolute answer. The recommendation is to go for impact. Is the right thing to pick up a non-FDG. Generally, they will only that wherever they go straight to.
Thank you, sir. So thank you for this session. Thank you, everyone. Thank you, panelists, for your time.
Thank you so much, sir. It was an exceptional interaction that we had. And I would like to thank the speakers, the panel, and also the expert of the session, Dr. Sajid Qureshi. Sir, your passion for the work was quite visible, and it was a privilege to learn from you today. Thank you. And with this rich academic session comes to an close. And
Yes. अरे इस सेशन का और आते हैं. Yes, wait. Thank you.
and Shalini ma'am will be giving the valedictory message.
So big thank you to everybody. Special thank you to all the faculty and the delegates, both offline as well as online. And thank you so much for making this event a great success. And I would also like to mention our sponsors, MCure and Dr. Reddy's, the administration of Rajiv Gandhi, the marketing department, especially Manish and Kunal, who've been running all around all the time and making all the arrangements. Rahul from IT, the F&B team for the delicious lunch that they provided, the maintenance team, and definitely the hardworking team of PHO department of Rajiv Gandhi. If I start taking names, it will not end. So thank you so much, Chandan, and everybody who was around, Khushi, Janvi, Nitin, Pooja Sharma, Pooja Elawat, all the ward nurses and all our awesome PHO fellows. Thank you so much, Radha, Ayushi, Hina, and Vidhi. Where is Vidhi? Yeah. Thank you.